Welcome everybody to the 13th annual meeting of the UK Pharmacogenetics Stratified Medicine Network meeting. My name is Munir Pirmohamed. I formed this particular network over 13 years ago, and I've been leading it since then. And we have great meetings in this particular venue every year. So the idea behind the network, and it's not just pharmacogenetics, it's also stratified medicine or precision medicine, and obviously the terminology has changed over the years. But the idea behind it is really to serve as a vehicle to showcase advances in all aspects of personalized precision medicine and foster the uptake and diffusion of precision medicine into clinical practice for patient benefit. And by holding meetings like this, having workshops, etc., it enables networking and fosters collaboration. And I think over the years, that has happened to many different people, working amongst academics, developing their networks, but also between academia and industry. That's happened as well. So I think that's an important role of this network. So I'm just going to tell you what we've done over the last year and what we're planning, and then introduce the speakers, if that's okay. So one of the things we did was to hold a workshop on precision prevention. This is an area where there's a lot of discussion, but very little being done at the moment. And this paper, which has just been published in BMC Medicine, highlights some of the need for new thinking and so on in terms of area of precision prevention. One of the three pillars from the government is that we need to move from treatment to prevention. And it's not just going to be prevention generally, but actually also precision prevention as part of that. So it is open access, so download it, please, and have a read of it. We also held a meeting on drug discovery together with LRIG. LRIG is a drug discovery industry group, which was held in Liverpool in the docks there, highlighting the sort of novel technologies one can use for drug discovery development, including using AI-based technologies. So what are we planning this year? Obviously today's meeting, but we're also planning a workshop on the 3rd of November on polygenic risk scores. This is going to follow on from the symposium we have on polygenic risk scores later on today, but maybe focusing on implementation. What are the barriers? How do we prepare ourselves for polygenic scores into clinical practice? And then we've also have a symposium at the British Pharmacological Society annual meeting in Manchester on the 9th of December 2026 as well, so hopefully you can attend that. So what I also want to tell you about is something that the UK network has been involved in, but is something which has been funded separately, which is the UK Centre of Excellence in Regulatory Science, Innovation, Pharmacogenomics. It's one of 7 CERCs in this country, which is set up through funding from the Innovate UK. And the idea behind this CERC PGX, and many of the people who are leading the work packages that are in the audience, is to develop proportionate, forward-looking, inclusive and responsive regulatory pathways that enhance innovation rather than stifle innovation. And there are 5 work packages. First one is on guidelines, which I'll come back to in a minute. Work package 2 is very much industry focused, and Jackie O'Brien leads that, and she's going to be here, or is already here. Work package 3 is about education training. I'll come back to that. Work package 4 is about health economics, led by Duffield Hughes and Chris Sampson. And work package 5 is on patient public involvement, led by John McDermott and Ramona Moldovan. So I can't go through all of these and tell you exactly what we're doing with this, but just to tell you about 2 work packages. The first one is about guidelines. We've been developing guidelines which are UK-based. There are CPIC guidelines, etc., but we wanted more UK-focused, more clinically focused guidelines, and we have developed 4 guidelines which have been published. 5th one, which is about to go into to the journal for review, and then the final one, which is ongoing at the moment, but we've got another list of guidelines which will be prepared. So these are UK-based guidelines. We get input from the MHRA, NICE, and various bodies as well as part of developing these guidelines, so that they are representative and hopefully will also be used because they've been peer-reviewed, if you like, by the community that's going to use them. So that's the work package 1. I'm going to highlight work package 3 because there's a stand in the table where you can get tea and coffee. where they will be talking about this particular work package, education, training. They've developed 7 modules, which are all freely accessible through the British Pharmacological Society website. It's about upskilling the workforce, really, because there's very little knowledge of pharmacogenomics and so on. So what we want to do is to carry on with the work of the CERSI together with the network through the British Pharmacological Society, the Network of Excellence in Pharmacogenomics, etc., so that we can actually develop pathways for implementation of pharmacogenomics and other areas of precision medicine in this country. So I just want to finish up by thanking all the sponsors. I've already been around some of the tables, thank them personally, but please do visit their stands as well later on. So I'm just going to move straight on to our first speaker. Great pleasure to welcome Professor Cathie Sudlow. We worked together for a while on HDI UK stuff and so on, and also on certain committees as well. But Cathie is a professor of neurology and clinical epidemiology, director of the Usher Institute at the University of Edinburgh, and is also taken on, she didn't have enough to do, so she decided to do something else as well on top of that, is to become director of the UKRI Adolescent Health Study. But what Cathie is going to talk to us about today is the report that she wrote on data science, really big, and data assets and so on, and how we can make use of that. And it was called the Sudlow Review. It's referred to as a Sudlow Review by everybody, and this is going to be a reflection 18 months after publication of the Sudlow Review. So thanks very much, Cathie. Thank you.
Thank you very much, Munir. It's really lovely to be here, and many thanks for the invitation. So as Munir said, I'm a medic by original trade, but about 15 years ago, my career sort of took a transition over into population health, and my training in epidemiology came to the fore. I worked for about 8 years, or 9 years actually, as the chief scientist for UK Biobank, which was a fantastic opportunity to get into building capabilities and resources that would benefit and be used by thousands of researchers. And then I moved, always on secondment from my home university, the University of Edinburgh, to work alongside Professor Sir Andrew Morris, the Director of Health Data Research UK, and set up the BHF Data Science Centre during the pandemic, and was lucky enough to be involved in helping to co-develop a number of capabilities, data linkage, data access capabilities, that were part of the effort to inform policy and practice during the pandemic, and very much pulled together with the notion that they would also benefit in terms of access to data and capabilities, discoveries that would improve lives relevant to a whole range of other pandemics like heart disease, cancer, diabetes, metabolic syndrome, arthritis, renal disease, mental health disorders, and so on and so forth. So that's my background, and it was during my time at Health Data Research UK that I had the privilege of being commissioned to write this review for UK government, given that I had navigated health data linkage, health data access, and the generation of biosample-rich population-based resources for a number of years. And I'd been bending Chris Whitty's ear for quite a long time, and I think he was getting a bit hacked off with me. So he got together with Ian Diamond, then the national statistician, the UK's national statistician, and Tim Ferris, who at the time was the Director of Transformation at NHS England, to commission this review for UK government on the health data landscape across the UK, and to outline some of the barriers to access and use of data for public benefit in all its ways, shapes and forms, and then to come up with some solutions that might be helpful to move the field forward, given the barriers. So this I did whilst I was in HDI UK. There's no doubt I couldn't have done it without the support of many colleagues who are too many to name, but I've told you about some of the key players at the top of the chain, if you like. So just to cut to the chase, that review, it took about 18 months actually to develop. It was supposed to take 6 months. These things, I understand from talking to others, always take a bit longer than intended, and it landed and was published in November 2024. HDI UK did a fantastic job helping with the launch. But one reflection that I have on being involved in that process was that there's a sort of before, during, and after with any review or report like this. And I'm sure this is the experience of the many illustrious others who have been involved in this sort of process. So there's all the stuff you do in the run-up, some of which I've told you about, that gives you some sort of reason to be commissioned to do a task, and maybe it does include bending people's ear a lot. And then there's the actual writing of the review, and this involved consultation with hundreds of stakeholders, individuals and organizations. It involved bringing my and many of my colleagues' prior knowledge and expertise together. Very importantly, it involved conversations and discussions with many members of the public and patients who are obviously at the heart of this, and the most important potential beneficiaries of uses of health data for benefit. And then there's the after. And the after bit has been quite interesting, and I hope to have time to tell you a little bit about that as well. But it's not a single point in time. It's not like you write it and you kind of submit it. And so I did expect it to sit on a shelf and gather dust, to be honest. So I did think it would be a bit like my experience of writing a PhD. It was equally as kind of tense and sweaty and all done in the kind of margins of the day and so on and so forth. But actually, surprisingly, it has been quite interesting repercussions afterwards. So here are the key points. Health data is used every day, by and large, very safely, in day-to-day practice by physicians, by nurses, by many other clinicians and others who contribute to the health service, and indeed in many other walks of life where health data means health-relevant data, and health-relevant data are generated and used in many other walks of life as well. But particularly in the NHS, used to improve people's health and lives. And people are generally, and if you look back over 15 years of surveys, focus groups, discussions, etc., people are generally very supportive of the use of their health data, not just for their own benefit, but to benefit other people. So our generous, altruistic population is very keen on benefiting others as well. And we know that across the UK, we've got fantastic sources of health data from the NHS and beyond. We also know, and this is a key point, that the really transformational insights come not from looking at one particular data set that you manage to obtain access to, or maybe you generate yourself with colleagues, but actually it comes from linking different sources of data together at the individual level. And that's a key point, and it's been an important point to keep making to colleagues in government. There are, of course, as many of you know, unfortunately, many obstacles and delays to accessing, linking, and analysing health data. And these arise from what are, frankly, extraordinarily complex and often very inefficient systems for managing and access data. And many of you here will have encountered those for some of your work. So by design, we don't have a system that is particularly well set up to subserve the purpose that we have this fantastic opportunity around, and that was one of the key points that it was important to make. And also important to make is that because of those barriers, which are not just technological, but they're technical, cultural, political, and also sort of legislative, regulatory, etc., the more decision makers you have in a chain of decision makers, the more likely it is that one will say no along the chain, and then the whole thing comes crashing down. So information governance and decision making, infrastructural processes as well. All of this prevents and delays things that I think many people in our population, our patients, the people we encounter in day-to-day life, they kind of expect these fundamental discoveries and fundamental kind of organization of data to be, for good, to be happening. This prevents analysis and research about health conditions that affect all of us. Every single one of us gets sick from something, every single one of us knows somebody who's been ill, and the same kind of infrastructures and processes, by and large, are required for a wide range of different purposes. So as a result of not having this in better shape, we're letting everybody down. And as a result, I posited that the UK's health data should be seen as part of our nation's critical national infrastructure. So the Office for Life Sciences have an interesting take on this, and they did a really smart exercise of summarizing about 66,000 words of text onto one slide. So unless you have insomnia and or want to read the whole thing, and there are some real nuggets in there, so you might dip into particular chapters, you can look at this slide and get a kind of overview. But essentially, lots of sources of data, lots of fantastic initiatives, some of them shown here. We don't make enough of them because of complex and inefficient systems and poor connectivity between data sets. There's huge untapped potential for a range of different purposes, not just research and innovation, but lots of kind of on-the-ground healthcare planning and delivery stuff as well, and only with an ambitious and joined-up strategy that takes a national approach, invests properly in the long term, with leadership reporting right at the top of the chain, with processes and standards that are recognised across the nation, can we actually really shift the dial. So what do I mean by health data? I mean health-relevant data. So we have nationally collated sources of NHS data that are brought together, largely structured, coded abstracts of data, for example, hospital episode statistics or some particular disease registers. These are brought together at the level of each country. And they can be linked together using NHS number or CHI number in Scotland or various other unique identifiers. They tend increasingly now to be brought together and provided where they are accessed by researchers from a wide range of backgrounds and organisations within trusted research environments or secure data environments. We don't have one for the whole of the UK. We have at least one national environment or provisioning system for each of the countries of the UK. None of them is perfect. We have some overlap and duplication as well, and there's a need to resolve that. But that was not the case before the pandemic. We didn't have all of that. So we are in a better place, arguably, than we were. Scotland and Wales were ahead of the game on this. And then we also have local and regional sources of data which are more granular, which tend not to be brought together at entire country level, although there are some exceptions to that, and there are different technological mechanisms for doing that, so it's not impossible. But things like images, free text data, some laboratory data, and so on. But relevant to our health as well are data that arise from other sectors across society in day-to-day activity. Many of these are held by various government departments across the 4 nations of the UK, and there have been efforts to try and pull those together and link them to data from the NHS. So social care data is obviously incredibly important, but also census, education, disability, income data, and so on. And then outside those day-to-day administrative structures, we have data that we generate in our day-to-day lives through club cards and mobile phones and wearables and so on. We don't often know that we're generating, but it exists. And there are increasingly mechanisms and studies to try and link those types of data to healthcare data, for example, to demonstrate. Let me give you one example. So a study of ovarian cancer, where cases with ovarian cancer and controls without gave their consent for their prior shopping records to be interrogated and linked through to their future or current cancer status. And there were some early demonstrations that there are warning signals in shopping data from women who subsequently develop ovarian cancer based on their buying habits of analgesics and anti-bloating agents and so on. Ovarian cancer, of course, develops very quickly, and there is a big search for ways to identify it sooner to improve the prognosis. So that's just one example, obviously, in this case, with the consent and buy-in of the individuals involved. There are also environmental data, weather data from meteorological monitoring, climate data and so on, but also air pollution data from broad national and local monitoring stations that can, using geocoding, be linked to other sources of healthcare data in the right way. And then we, as a community in academia and in industry, generate data from research studies. There are some large cohorts I've shown on this slide, and also large-scale trials that can benefit from linkage to other sources of data, both to find patients and recruit them into studies, but also to follow them up over time remotely and cost-effectively for outcomes that appear and can be characterized in the data. So a range of examples. And here is one setup that emerged during the course of the pandemic that was led through a collaboration with the 4 nations emerging secure data environments and HDR UK and the British Heart Foundation Data Science Centre, whereby it started to become possible to enable researchers to securely access multiple linked data sets from a wide range of different sources you can see on the slide. And that essentially starts to enable research at whole population scale. It's not the scale you need for absolutely everything, but it's really useful for certain purposes where you want to include everybody for surveillance, for drug safety monitoring, perhaps for, and that we have had demonstrations of this, and for rare diseases it can be, or rare outcomes, it can also be particularly powerful. So I'm going to show you one example of one particular outcome of many hundreds that came from these types of endeavours, which was linking different sources of national health data across the 4 nations to look at under-vaccination against COVID-19 among individuals aged over 5 across all 4 nations of the UK. And you can see that although early on in the pandemic, vaccination rates were high and therefore under-vaccination rates were low, by the time we reached the middle of 2022, people's vaccination status, when compared with what the JCVI was recommending they should have or should have had by that point in time, was not that wonderful. Of course, there's a nuance to interpreting this, and it doesn't necessarily mean that they weren't adequately protected, so there are ways of exploring this data more deeply. But the key message was, as a result of being able to link those vaccination data to a range of other data, it was possible to demonstrate the types of characteristics that are associated with under-vaccination, perhaps no massive surprises there, and that the risk of getting severe COVID-19 and ending up in hospital was clearly increased in under-vaccinated people, and it was possible to segment across deprivation, ethnicity and other groups to start to have conversations about how this issue might be rectified. So one example of very many. And then when it comes to local and regional data, I've got one example for you of more granular data where in Scotland it has been possible to pull together at least up to 2018 from 2010, and of course that is behind real time, and we could and should do better on this, an archive of all the medical images, the actual images that have been captured across NHS Scotland on its population of 5.5 million people, together with retinal images acquired at high street optometrists in a large subset, about 1 million retinal images there, and link those securely and safely with de-identification and within a secure data environment to all the health data about those individuals during the course of follow-up after those images and before those images were taken. This is starting to enable scientists to do some very interesting work, for example, to look at patterns in brain images or in retinal images and the way in which they might predict subsequent dementia or neurodegenerative disease. We know from research resources like UK Biobank that this looks very promising, but this is doing it with messy real-world data and starting to model what it might actually look like at population level. So data from beyond the NHS, I've spoken about health-relevant data from other administrative sources, and there are also demonstrations of linking these data across sectors at whole population scale. So Wales have been fantastic at this through their SAIL data bank, where they've built up fantastic trust with multiple sources of data and brought them together securely to allow people to study at whole population things like the association of school absence or exclusion with subsequent health outcomes and vice versa. And in England, under the leadership of Ruth Gibson and others, the eChild resource has started to enable similar studies, but at England-wide scale. Although, as yet, the English resource that's used for this has not been able to link in primary care data, which the Welsh has, and that is, of course, a major additional benefit. And then some similar work also going on in Scotland. A colleague of mine, Livy Swan, is starting to look at linkage across multiple government sectors at local authority and at national level to study the effect of unhealthy and healthy homes on young people, and particularly with a focus on respiratory outcomes. So research-generated data, this is really important because we, as a community, work on and generate data from, for example, large-scale clinical trials or very large-scale population-based cohorts or smaller clinical cohorts. And I have a few examples for you of how routinely collected data can be used to find, recruit, and follow participants in large-scale clinical trials. I'm using examples I think you will have heard of to illustrate the point. But the recovery trial, for example, which ran during COVID, very large, more than 50,000 participants, because of a very simple, streamlined, easy-to-use protocol at the clinical coalface, but centralized services through these large national resources were used to provide national linked data on hospitalizations and deaths for the follow-up of participants in those trials to find out which treatments worked and which did not. Wouldn't it be wonderful if also the recovery trial participants' data could be linked to primary care data for longer term follow-up to look at the effects of these treatments on long COVID? That has not yet been possible, but you never know. So the NHS Gallery trial is another example. It's got an interesting and perhaps somewhat controversial result, but I use it to illustrate that national data was used to issue invitations to millions of people who were eligible to participate in that trial, and within just a few months, 140,000 participants had been recruited to that multi-cancer screening blood test trial. And then a smaller trial run from Scotland is using a similar approach to identify patients with brain hemorrhage and to follow them up through the data for key health outcomes across several nations of the UK. So what about large-scale cohorts? So I've shown you here some of my favorite ones because I either have been or am intimately associated with delivering them or with advising on how they could or should be delivered. Most recently, of course, the adolescent health study. I can see Richard smiling at me from the audience. And there are several people involved with that program now here. So it's another interesting new cohort looking at another point in the life course that has been very much understudied at this sort of scale, looking at adolescents growing up into young adults and the influences on their health and well-being. But a similar design and approach to some of the more established cohorts you see on this slide with Our Future Health scaling fantastically well. So UK Biobank is arguably the most mature, largest, and has the greatest depth and breadth of those resources to date, certainly in the UK and arguably globally. And I use it to illustrate that when you set up a cohort like that and when a huge amount of money is invested in it, it's really important that it's possible to honour the efforts and the consent of the participants and their willingness to participate to help make sure that it comes to fruition and is used widely and can be linked to relevant health records for the follow-up of the participants. And those kind of linkages have been used in UK Biobank by thousands of researchers, and here is a smattering of illustrations of how they've been used. So Biobank data analysed from its objective accelerometry, which is done in a 100,000 subset, linked to a range of other data, but including health records for follow-up, showed these much stronger protective effects of physical activity against cardiovascular outcomes than had previously been understood. Memory clinics in the NHS are using some of the brain analysis processes that have been developed on UK Biobank acquired images for dementia studies and rolling into clinical practice. And clinicians are starting to use tools for the prediction, genetic tools, polygenic risk scores and others, as you have been hearing about from Munir, to predict risk of developing heart disease, cancer and other conditions. So those are a few examples of the benefits that come from linking these studies to other sources of data. So we know many sources of health data can be used to save and improve people's lives. There are great examples that demonstrate what's possible, but unfortunately, these are the tip of the iceberg. These examples I've shown you are somewhat the exclusions, and they hold within them many further possibilities. So there are lots of things we don't know, and we don't do, and we can't do yet, or we don't do in real time, or we don't do quickly enough. And I've shown you a couple of examples here on the slide. So the notion should be to reduce that friction and move things forward appropriately. So here were the recommendations of my review. We as a nation, need a coordinated strategy for health data as part of our critical national infrastructure. I recommended the setup of a national health data service with senior accountable leadership that would enable a lot of this stuff to happen with high-level buy-in and proper funding. Crucial to this is ongoing coordinated engagement discussions with patients, public, and importantly health professionals as well, who've been less consulted with over the years, particularly GPs. Policymakers and politicians, of course, important. And we need UK-wide standardised processes for access, governance, standards and accreditation. So it's been interesting to see the subsequent influence on UK government policy. This was the bit I maybe didn't expect or didn't know what would happen. So the review was generally positively received, aligning with the government's economic growth agenda and proposed shifts in healthcare. It was a privilege to become involved in some advisory groups that informed the life sciences sector plan and the 10-year plan for the NHS in England. There's been some There's been some changes in enabling legislation, so a couple of directions from the Secretary of State. This is when Wes Streeting was Secretary of State for DHSC, have been steps forward towards better access to general practice data. So data for consented research, directions to enable more ready linkage of some of those data to large-scale cohorts which fulfill particular security, privacy and confidentiality conditions, and then a move forward for Open Safely, one of the resources in England that's enabling access to primary care data linked to other data. So these have been useful advances. And then major new investment has actually come about. So I heard about this 48 hours before the Prime Minister announced in a car factory when he was talking about something else primarily, that the government was going to partner with Wellcome to invest, sorry, I've got an auto advance going on here, to invest a large sum of money in National UK Health Data Research Service. So that has now been launched. A CEO, Mel Iverson, who's an absolutely fantastic person, has been appointed, and the chair of the Health Data Research Service, Nicola Blackwell, is working closely alongside her. So I do not have my ear right in that space, so others may know more than I do about how that's going. But here are the key features of that Health Data Research Service: government-owned, UK-wide remit, some key must-have whole population national data sets that I really hope they will cling on to as being core, because they are important for so many different domains of activity as the kind of fundamental pillars, and some very important underlying principles that reflect some of the recommendations in my review that you can see there on the slide. So there have also been some, for me, and hopefully these have benefited others as well, some interesting broader opportunities to influence this general space. So one is becoming involved as a commissioner in the National Commission being led by the MHRA into the regulation of AI in healthcare. So this has been led by Lawrence Talland, the new and very dynamic CEO of the MHRA, and chaired by Alistair Denniston, who you saw in one of Munir's earlier slides, who is a fantastic leader in this space of AI in healthcare. So that commission will be reporting later in the year, and hopefully we will have better, clearer, and where appropriate, faster ways of moving helpful AI approaches into healthcare to optimize delivery of healthcare. And then also the opportunity to give evidence to ministers and other politicians, in this case to the Science and Technology Committee at the House of Lords. An interesting experience for me, and also a chance to sort of sit alongside some other fantastic people giving evidence to that inquiry, which is yet to be published. There are curveballs. So within a very short period of time of publication of my review, one of the privacy lobbying groups had made some comments on Twitter, and then about 10 hours later had made some further comments. So I actually think the privacy lobbying groups have a very important function. They hold us to account and they make sure we understand what's going on. I don't think it's particularly helpful for them to write things like this, but I don't think it helps them actually. But that's just my opinion, and you can see this as you wish. And there have been some setbacks, of course, most notably in our sector in general, most notably recently, an issue with UK Biobank data, de-identified but being offered for sale by researchers in breach of their contract with UK Biobank on a Chinese website. UK government, Chinese government became involved, and these records were not sold on, so they were taken down off the website. The researchers and the institutions involved have been barred from using Biobank, but unfortunately, so for the time being as everyone else, because Biobank has had to shut down access temporarily to its research access platform. I have to say they have, as a team, moved impressively quickly with all the people who have been advising them to set up an oversight committee to generate some recommendations about how they will move forward. And I think there is a kernel of benefit in this whole episode, in that some new recommendations that I think will affect all of us in the sector will emerge, and there will be more clarity. And just before I stop, another huge opportunity I want to finish with on a positive note is this fantastic capability. Now I'm kind of focusing a little bit more on some things up in Scotland to take advantage of, for the population of Scotland, of the fact that 3.5 million people's neonatal blood spots from that neonatal blood spot test have been kept in Scotland in an archive somewhere over near Glasgow, with potential details on those cards and the potential to use those blood spots, which are sitting there not being used for really anything at all at the moment, and link them through from 1965 onwards to Scotland's rich longitudinal records, which I think would unlock fantastic research potential. And I think this community could be very excited by that. However, there is a very long way to go to make that a reality, but I and others are working on it in the background up in Scotland. So thank you very much.
Thank you very much for a great overview. No, are you able to take questions?
Oh, I am. I realised I'd run over a bit, so I was going to run away, but we've maybe got just a few minutes. Yeah.
I'm just going to there are spaces at the front, so you may want to come and sit down. Questions, please. So can I start? HDRS sounds very exciting.
Yes.
But I'm not quite sure what the model is, how it's going to operate. And it seems that there will be costs to access HDRS, but then there'll be costs underlying that to the SDs, etc., that are linked to it. Do you think it might become too expensive for academics to be able to access?
So, I mean, in all honesty, I don't know, Munir, because I'm not leading it. So I suppose those questions would be better directed at Mel Iverson, who is, and Nicola Blackwell, who's chairing the board. They're in early setup. My understanding is that what they want to do, well, they have been bound to continue investment into 3 key infrastructures that already exist in England: Open Safely, NHS DigiTrials, which is the capability that allow that kind of recovery NHS gallery and recruitment into our future health and so on. So I think that's great. And also the network of secure data environments that has been established and is kind of moving forward, perhaps 2 steps forward, 1 step back in England. That's the regional secure data environments. So those will continue, but that's for about a year or so, whilst the organisation lays out its plans and decides how it will operate best. I think the other thing is that it's clear that their initial focus is going to be on recruitment to trials, following the kind of call to action from James O'Shaughnessy's report. And there will be an emphasis, I'm sure, on enabling commercial clinical trials. The hope would be that any trials that don't benefit from commercial funding because they're investigating things for which there is not the potential to generate a commercial proposition will benefit from those efforts as well. They'll also focus on single point of access and streamlining access. I don't think the costs are yet clear, so I guess it's a watch this space.
Okay.
One.
Okay, any other questions, please? John? Is there, yeah. Microphone, please. Let's come on.
Thank you so much for that. I'm John McDermott from Manchester. In the 10-year plan, there's a big commitment to population genomics, and a lot of the attention has been focused on maybe how we get that data out there and use it in clinical settings. But simultaneously, we're going to have to demonstrate to making a difference to individuals and the population.
Yeah.
You spoke a little bit about trying to link individual level data and some of the challenges around that. Do you think to be able to demonstrate that we're delivering on population genomics, we have anywhere close to the data infrastructure we need to perhaps capture those outcomes?
I certainly don't think we've got all of it, and it's difficult to be a specialist in every single type of data, but my take on this in the review, and I think I largely adhere to that, is that we have got some if one thinks about England anyway, we've got some fantastic national infrastructural opportunities, for example, in Genomics England, and you can quibble about how they focus their efforts and investment and so on if you want to, but it's a fantastic national opportunity to provide those kind of services. They've got a mature, well-run, secure data environment. It hasn't, to my knowledge, been as accessible and easy for users as it might be, but there's an opportunity to make that better. I think with the genomic medicine services as well scattered around England, there are 7 of them. Again, my understanding has been that the testing that they focus on and do has been harder to scale, perhaps because of underinvestment in the right sort of technology, likely because of the very broad range of different laboratory infrastructures that we have associated with those across the UK. So I think there's a great opportunity, though, to demonstrate through that national capability and joining up that network better and enabling an even better interaction between the centre and the regions, GEL and the regions, to take that forward so that those linkages and discoveries and benefit stories can be put out there. I would also just comment that there are good stories already, and you and others in this audience will know them. So I think it's on all of us to really demonstrate the existing good stories and say why that these are exemplars, but they're not good enough. It could be so much better, and maybe sort of emphasising those narratives will help us with politicians, people and others to take this forward further.
So we have to move on, if that's okay. So that's because of time, but you're going to be here for coffee time or something?
I'm going to stay all day, actually.
Oh, you're brilliant.
Yeah,
oh, brilliant.
Yeah, I might nip out in the middle, but yes, so thank you very much.
I want to ask you a question later on, if that's okay.
Thank you. Yes, of course.
Thank you very much, Cathie. Great. Sorry, it's a packed agenda and so on, so I will have to move on, so in terms of time. So, pleasure to introduce Professor Segun Fatumo from Queen Mary University, London. And Segun is Professor and Chair of Genomic Diversity. You can see we are covering this morning diversity in terms of data sets, diversity in terms of populations, diversity in terms of genomes. So Segun is going to tell you how you can harness the African genome in terms of diversity that can help with precision medicine. Thank you.
Thank you very much. Good morning, everybody. So today I'll be just following up on the fantastic talk by Cathie and see how we can do much more in diversifying our data across our population. So this is a very good example. I'm sure that many people in the room know about PCSK9 inhibitor. So this is a story about just one mutation. Of course, we know today we have medication that is helping everybody all over the world to lower cholesterol. But what is not always emphasized enough is that this PCSK9 inhibitor was discovered because some African ancestry individuals were included in a study. So in that study, they found that those African ancestry individuals, they have a mutation in PCSK9 gene that is helping them to naturally lower cholesterol. So today, we have this treatment that is helping to lower cholesterol, not only for African ancestry, but for all population. So this is one example, one very good reason why we should include our population in genomics. You probably have seen this figure before. Africa is significantly underrepresented in genomics, despite being the origin of modern women and most genetically diverse. So in this paper, which we published a few years ago, we show that most of the genomics studies that have been done primarily in people of European ancestry. And you see European ancestry having about 86% of genomics and just 1.1% in Africa and 5.9% in European ancestry. So you see we are not really doing very well in other populations. Of course, we're doing very well in the European ancestry population. So Cathie has really mentioned, talk about UK Biobank, which is really a fantastic resource. So UK Biobank, like you know, has about 500,000 individuals But this also includes about 38,000 people of non-European ancestry. But what you will find in literature is that most of the studies that have been done, even when data are available, are focusing primarily on people of European ancestry. In literature, we see about 93% of publication, excluded those non-European ancestry in UK Biobank, even though data is available. So studying other populations, there is a scientific advantage, including African genomics does not just have diversity. This is not just about diversity. It had resolution, discovery power, and also clinical precision. So let me tell you a bit more about Africa. Africa is the most diverse continent in the world, both genetically, culturally, ethics, and linguistic, and all that. So Africa has about 3,000 different ethnic groups, speaking more than 2,000 different languages. So why is African genome so important? There have been so many multiple genetic studies that confirm what is considered to be the heart of African theory. About 50,000 to 100,000 years ago, so the modern human migrated out of Africa and started to populate the whole world. So when they left Africa, so they only left with a small part of the African genetic variation with them. So what this means in a broad sense is that other populations, including European population, are largely carrying a subset of the genomics within African population. So Africa is the most diverse population all over the world. What is not always well emphasized is that there is even larger genetic differences within African than between African and European population or between African and Asian population. I'm going to show you one example. So here is a study that we conducted within East Africa in Africa. And then you can see that's a map of Africa. You see we had sample collected all across Africa. So if you just zoom in to that population I circle in Uganda, so we have sample collected in two different centers in Uganda. And if you look at the PCA, if you are very familiar with PCA, you see that one population just within Uganda tends to be tending towards Central Africa, and the second one is moving towards East Africa. That's how much even population can be so diverse, even just within one country. And you can see a lot of diversity within African population. So this diversity has many implications. Number one, it helps us to understand the modern evolution and its effect on human disease. Number two, it means that genetic study in non-African population, including their clinical relevance, may not be generalizable to African population. It also means that there are many genetic variants that are yet to be discovered, and one of them could be another PCSK9 inhibitor. So we need to really study our population. So it also means that findings within one population within Africa, for example, say South Africa, may not be transferable or generalizable to another population within Africa, say Ugandan population. I'll show you an example from some of the study that we did in Uganda. In 2019, we published what was considered to be the largest ever genomic study in African population. This was just a study of about 5,000 people that we recruited in Uganda. We did which were genotype on Illumina array. So we had another 2,000 people. We did the whole genome sequencing, and we had a few other samples from South Africa and also Nigeria, Kenya, and Ghana, making 14,000. So that was considered the biggest ever genomic study in Africa. So recently, you probably have seen a genomic study report population that has about 5.4 million people. You have seen a GWAS of 5.4 million people of height. You see GWAS of 3.5 million people of kidney disease. But in Africa, this was 14,000 people, considered the largest ever genomic study in Africa. In that study, in about 2,000 people that we did whole genome sequencing, you see we identified 9.5 million novel variants that were not present in the 1,000 Genome Project Phase 3. At that time, the African Genome Variation Project and the UK Tech. 9.5 million variants is really a lot for a sample of 2,000 individuals. We also did the GWAS of a range of cardiometabolic traits, and we identified novel loci. Many novel loci But what I really want to emphasize here, if you look at the last column, the last two columns, is the minor allele frequency for African population compared to the allele frequency in European population. You see that most of those variants that we identify to be novel in Africa, they were mostly monomorphic in European population, meaning that they were absent in European population. So what this means is that this novel variant would never ever be identified in other populations because they are very specific to African population. So we also assess heritability for all the 34 cardiometabolic traits. So we found that height, as an example, is less genetically determined in Uganda compared to European population. So we found that the narrow sense heritability for height was 49%, whereas the European population was about 80%. So in contrast to that, we also found that heritability estimate for LDL was significantly higher in Uganda, about 54% compared to about 20% in European population. These are really very, very important. So since then, we've been trying to leverage resources and data from all across Africa. So in this study, where we tried to, we did a multi-trait discovery and file mapping about 125,000 individual African population. So we identified some novel loci that were not found. And this is very important because just before this paper was published, there was a GWAS of lipid traits in about more than 1 million people. So you expect, and we decided to just focus on Africa and leverage resources within Africa. So we identified about 20 novel loci that were not identified in that particular study. So here is also an example where we're trying to assess assess lipid traits and type 2 diabetes, and the causal relationship between lipid trait and type 2 diabetes. What you will see here is that we found some consistent Mendelian randomization findings about HDL exerting a protective effect on diabetics. But also found something that's a bit contrary to what you find in the European population, again, raising the possibility of ethnic differences between European and African ancestry. So this work was recently published this year in Nature Genetics. We collected a sample in Uganda, about 500 people that we did oleic profiling. So we analyzed about 3,000 protein from that 500 people. About 163 of them are people with diabetes or pre-diabetes, and we had about 300 people control. This was like the first major proteomic study in African population, just about 500 sample individuals. So we investigated the causal association, the association between the protein level and the cardiometabolic trait. We found 280 protein that were associated with HbA1c. We have 42 with HDL and 46 with LDL. So we also identified about 400 independent pQTL association, about 346 of them are cis pQTL and 53 of them are trans pQTL. So we did perform some co-localizational analysis to determine share risk variance between pQTL and type 2 diabetics. And very interesting to show you one gene, very interesting there. So one significant co-localization signal was identified with a posterior probability of more than 95%, so which is indicating a very strong evidence for a shared causal variant. And for the MR, you're probably very familiar in this room with the AC inhibitor, which is really very good for blood pressure. So we did also MR and find causal association between HbA1c and type 2 diabetics. And these are all having very, very important. For example, the AC show causal association with type 2 diabetes, which is really very important for potentially repurposing this drug for type 2 diabetes. So I'll move quickly to proteomic risk score and show you how we use African-derived genetic risk score and how they outperform the European ancestry PRS. So in this study, we developed a PRS using different data sets. We have a PRS that was developed using multi-ancestry data set in 1.4 million people. Another one with the African ancestry individuals, just 56,000 people. and developed the last one with the European ancestry individual, about 1.4 million people. You see the weight a bit different between how the PRS were developed. So we want to test this PRS on the South African population in continental Africa, and also do validation in African population. So here it's just showing the number of cases and number of control of those PRS. So the best PRS from the European ancestry, multi-ancestry, and the African ancestry were all significant in the African ancestry in South African population. But we saw that the PRS developed from that African ancestry was doing much more better. So we were achieving R-square of 1.1% compared to 0.69% from the multi-ancestry PRS and the European ancestry, doing very, very poorly in African population. So we decided to take the best PRS and validate them also in other population in Africa, including Nigeria and Ghana, and also the Kenya population. Again, we'll find the same pattern of the African derived PRS doing better in South African population and also other population in Africa than the multi-ancestry PRS. So here we try to see whether we can use PRS for stratification of people. We have on this plot here, you see we put people into different decile. The first decile up to the 10th decile. So we see that the participants in the 10th decile of the African-derived PRS, they had more than threefold higher rates of developing type 2 diabetes than those on the first decile. And we also show here that those people on the 10th decile are diagnosed for type 2 diabetes about 2.6 years ahead of people in the first decile. Again, this is just showing the power of PRS and what this could be, for example, in the future, even in clinic. But whether Africa is ready for PRS is something completely different. So here, because before this work, what was common in literature was that the multi-ancestry PRS is just as good for our population. So we decided to take the multi-ancestry PRS and the African ancestry PRS and test them across different countries within Africa. So we saw consistently the African-derived PRS is doing well in all the population. Multi-ancestry PRS also is doing very well, but not as much in some population. For example, here you see the Kenya population not doing as much. So here we're trying to see the discriminatory ability of PRS, comparing to the conventional risk factor like age, BMI. We added the 5 principal components, and we achieved the area under the curve of 67.9%. But when we had PRS to the model, so you see we had an improved discriminatory ability of 69.8%. So that means that PRS is really a good variable to add to the conventional risk factor. So we did exactly the same thing for lipid traits. And if you're familiar in this domain, so this plot on the left here, you see, like, if you look at the previous paper, you see like exactly like the opposite of what we show here. So consistently, we show that the African-derived PRS is doing much more better than the multi-ancestry and also the European ancestry. And so we were very excited to see African ancestry doing better in African population. But here, we picked the best performing PRS that was doing very well, South African population, and tested the same PRS in Uganda population. But what we saw is that the same PRS is not doing very well in Uganda population. Again, this now takes me back to what I said previously, that in terms of the larger genetic differences, even within African, than between African and other European or Asian population. So if you'd like to know more about this work, you have much more detail in this paper. Okay, so recently in the paper we published earlier this year, we also tried to see how PRS are developed within continental Africa, how they are doing, comparing with those developed in African ancestry, in diaspora, or European ancestry. So we ran a GWAS of Southern Africa, so that some population of Southern Africa, Western Africa, Eastern Africa, and developed PRS in those. You can see here Number of sample is very limited, about 5,000, Southern Africa, Western Africa, 7,000, Eastern Africa, 9,000. We also developed one PRS looking at all the continental Africa, about 23,000. Another PRS with diaspora African, about 80,000, and the Pan-African PRS. We want to see how the PRS are doing in continental Africa. So the target data set here was Malawi. We did validation also in another Malawi data set. So what we saw here is that the prediction and transferability of PRS of kidney disease here, so may be driven by the genetic distance. Because we saw that the PRS that was developed in Southern Africa is doing much more better in Malawi, because that's the closest genetically to Malawi than even the biggest PRS in African ancestry. So as I round up, I'm going to talk to you briefly about our approach to increase genomic diversity and achieving a much more accurate genetic risk score across our population. So number one, so we are building omics data, data resources, and biobank. And I will show you an example from Uganda. In 2011, so we developed the what we call the Uganda Genome Resource. I've already mentioned to you, we did genotyping, 5,000 people. We had the whole genome sequencing. We did the proteomics. We generated proteomic data sets. We also currently doing some DNA methylation, and we had a range of cardiometabolic traits. So in 2024, so we're also generating a UGR single cell, just a small number of sample, 450 sample. And 2025, we recently created a new biobank of 10,000 people in Uganda, and we're looking for opportunity for doing whole genome sequencing in all of them, and so also generating different omic profiling in all of them. So recently, we had a grant from a private organization where we are creating a new biobank of people that are unrelated. We are funded for all the cardiometabolic traits, whole genome sequencing, working across Africa within what is called a GenCode, which is the Center of Excellence for Genomics in Africa, where we're trying to generate genomic data sets in 25,000 individuals across Africa. So this is currently ongoing, and we're going to be finishing this by maybe the latest in October this year. And here, so this last one here is giving opportunity for longitudinal data sets. So where we have the first point of data sets collected in 2011, and we have the second point, 2025. So we can look at 2 time points and see the differences. So apart from that, so there's also a growing number of African genomics across Africa. What I just show you is what I'm leading on, but apart from that, you see a lot of resources that are growing up in Africa. So this will be a great value for discovery and also for genetic prediction that can generalize much more broadly within African population and also globally. So number 2, what we are doing, so we are establishing new consortia and also leveraging resources and expertise that are within Africa. So recently also, we established what is called Kidney Gen Africa. This is helping us to facilitate multi-center research in Africa. So I'm leading this with my colleague in South Africa, June Fabia. So we have the other investigators all across Africa, and we have so many people in other countries. We have collaborators, many of us here in the UK, in the US, and also across Europe. So this is very important because we are pulling resources together. And I'll give an example. This paper that I led just a few years ago, we're trying to look at kidney disease and genetic of kidney disease. This is very, very limited in sample, just 3,000 individuals. We identified just two loci at a locus called GATM, another locus called HPB. Now, but with this consortium that we just recently created, so we are able to now ask people to all bring their data instead of just looking at just one resource that is very underpowered. So here we just building GWAS, looking at Western Africa, Southern Africa, and also Eastern Africa, and doing GWAS at different stages, stage 1, stage 2, look at continental Africa, and also try to analyze that with Africans in diaspora. So what you will see in the result here is, when you run GWAS of kidney disease in Eastern Africa, so those loci you find to be novel or associated with kidney disease are distinct from the one you find from the Western Africa and also from South Africa. Again, this is also emphasizing the same thing I said at the beginning, that there might even be larger genetic differences within Africa than between Africa and European population. And let us just go over this and show what we found. So this work was just recently published. Also very important to mention is the role of ApoL1. If you're in the kidney genetics domain, you probably know about ApoL1 and the role that it plays in kidney disease. Most of the things that we know about ApoL1, they are from African Americans. And there was not much that had been done in the African population. So we know that about approximately 13% of African American population carry this variant that is known to be strongly associated with kidney disease. So we decided to check this within our data set, and we look at different regions in Africa. So we saw that the ApoL1, the frequency of ApoL1 varies a lot across Africa. About 5% in some population. In East Africa, about 1.3% compared to 13% of African American. Southern Africa, about 8%. And just you see that difference, that it's not the same thing as what you see in African American. And again, the association that we see between ApoL1 and kidney disease was much more limited than what you will see in African American. So this is really important that we're able to compare with what is in the other population. So this was really published in Nature Communication. So number 3 things that we are doing is that we are building capacity and creating opportunity. I'll give an example. Within Kidney Gen, we have some funding from the MRC, and this funding also allows us to train. We have a plan to train 120 African early career people of African heritage all over the world. We have some money for research exchange, where we bring people from Africa to the UK for training for up to 6 months. Currently we have an announcement for seed funding for Africa early career, up to £10,000 for them to plan some study that will help them to be able to apply for bigger grants. So we have this opportunity to build capacity. We did a workshop just recently. We're going again to Malawi in January. We do that for every year, so just to build capacity. I was in South Africa just last December, and the story in the room was we don't have enough data. And I asked one question. I said, today, if we have all the data set that we need to do all the fantastic genomic resource, do we have the capacity to analyze the data? And the answer was no. So because we don't have the capacity, so we need to focus on what we can do. And what we can do is to keep on training people and build capacity. So if you want to know more about Kidney Gen Africa, so we had a vision that was well highlighted in this particular paper. So I conclude by saying that, like genomics is a very powerful tool for advancing precision medicine, but that will only be important if it includes all population. I've shown you today that Africa has the greatest diversity on earth, but it remains really severely underrepresented in genomic study. So from our work, I've shown discovery of novel genetic variants that are unique to African population. I've shown that our African data set can improve prognostic score and also fine mapping. So we now must move to, we have to generate much more large-scale data set, which we are doing, we are working on. We have to build local capacity, build infrastructure for research and training, and also foster equitable collaboration and leadership within Africa. Thank you very much.
Time for questions, please. There's a microphone coming.
So Segun, fantastic talk, fantastic work you're doing. Kudos, it's great stuff. So can we just look at some of the practical implications and look at, for instance, the African diaspora in the UK? And in the NHS doesn't help really, because it asks you what you identify as. And for instance, just around the corner here, there's a big population of Somalis and Ethiopians, and they do not identify as African. They would like to identify, please, as Arab, Middle Eastern. So that you've got issues with the patients really wanting to identify with a country rather than a group. You've got huge differences, as you've laid out brilliantly there, between west, east, north, south. How do you then come to a practical implementation of all this extraordinary knowledge?
Great question.
I mean, in a sentence.
Okay, so I'm trying to think about how best to answer that question. So Sub-Saharan Africa is a little bit different from the people from North Africa, like Algeria, Egypt, Morocco, which they are much more closer to what people call a Middle East, which can be also called maybe Western Asia or thereabout. So you can see from the study I showed today, we are focusing much more on the Sub-Saharan Africa. And we are trying to do that, not excluding Northern Africa, because they always come to us and say, why are we not included? Of course, it's always good to see how much difference we have. But genetically, people from the Northern Africa are much more a bit closer to the Middle East. So that's one point to mention. If you look at the All of Us program in the US, we're currently doing a lot of analysis in there. And what we decided to do is to infer ancestry genetically, instead of asking people, instead of the self-identification. So, of course, genetics will tell you whether people are African or wherever they are. So we decided to follow that. Whatever genetics tell us, whatever the gene tell us is what we follow. That's another way to do it. Another way to think about it is that people can decide to tell you who they are. If I like, I can tell you I'm from European ancestry. That's what I want to be, So I think there are many, and that's one of the reasons why it's important to, when you understand all these barriers, to have a biobank that is focusing specifically on these people and trying to see how you can tackle those barriers.
Okay, time for one more question.
That was a fantastic talk. I have a quick question about applying PRS in the African Americans. I think there's just a huge amount of genetic admixture in the U.S. African Americans. I wonder if you have a thought about exactly how the PRS will be applied, since the data that you have is primarily Africans.
I don't have the answer to that. I've not looked at the admixed Africans. So what we have looked to develop PRS here are African ancestry. If you look at the US, for example, most of the so-called African ancestry are mostly people from the Western Africa. So we've looked at that. But there are also some admixed people that we've not really looked into the data.
Okay, great. Yeah. Thank you very much.
Thank you.
Okay, the last talk in this session is from Professor Sarah Feiner. It was going to be a double act, but unfortunately Professor Van Heel is not well, so thank you very much for, you were going to give a talk anyway, you're going to do all the whole talk now. Sarah is Professor of Clinical Diabetes and co-lead for Genes and Health and works at Queen Mary University London. Thank you.
Thank you very much. So, yes, apologies if some of the slides I don't do brilliantly. The hardcore proteomics is very much David, not me. But hopefully I'll give you a good kind of overview of our work in Genes and Health. Many of you know the study already. We've got plenty of current and past colleagues in the audience, and it's great to see you all. But I'll assume that not everybody's familiar with our cohort and really take you through things quite broadly in terms of us as a study, our data infrastructure, and the kind of research that Genes and Health is now doing ourselves as a team of researchers, but also with the global research community. So Genes and Health has been going for over 10 years now, and it really started as a result of understanding and seeing in our clinical practice in East London the significant health needs of our British Bangladeshi and British Pakistani population. And this is where I practice clinical medicine as a diabetologist. And these are the kind of numbers that jump out at me all the time in my clinical practice in diabetes clinics. And what you can just see here really is the difference in prevalence overall of type 2 diabetes in our Bangladeshi and Pakistani population in East London, but also the fact that diabetes is coming on in very young ages. And this is very disproportionate compared to our white European population, who are actually similarly socioeconomically deprived. And so really for people in their 30s and 40s in these communities, 1 in 10 people have type 2 diabetes, which is pretty astounding, okay? So there is a clinical need, certainly, to improve health and reduce inequalities for people from these backgrounds. Diabetes is just one example. But as you all know, there is also a need to overcome the underrepresentation of people from diverse ancestry groups in our genomic research. And that again fueled the kind of fueled Genes and Health as a study in terms of determining why we need it and why we need to focus on specific ancestry groups. And so studies like UK Biobank, although they've recruited British Indians pretty well, they've only actually got 240 British Bangladeshis in the study. So there's a real need. And Segun's beautiful graph, which I didn't show today, of the ancestral representation in global genomic studies also really demonstrates this, and South Asians are only less than 1% of the participants in the world's genomic studies. So Genes and Health has been going for 10 years, and we've recruited over 76,000 participants into the study. And you might say, well, look, you know, there's lots of studies doing this now, there's Our Future Health, etc. Why do we need Genes and Health as a single study on its own? Well, we have particular unique features, okay? First of all, we've got this genomic and health data that I'll go into more detail about in due course. But within these populations and within these communities, there are high rates of rare genetic variants, which arise because of autozygosity or consanguinity between related individuals. And that gives us the potential to make really, really important genetic discovery, and I'll give you some examples of that later. Secondly, we've taken with Genes and Health this kind of breadth and depth approach to how we deliver our research. So the breadth is essentially our recruitment at scale. And we have a very simple, short approach to people that we want to invite to join the study, and it's very simple to join Genes and Health, and that's why we've managed to get to the scale of 76,000 people. But we also have a mechanism to recall our participants, and that has been very successful at smaller scale, but it allows us to then deep dive into specific hypothesis-driven research, perhaps following up a rare variant or a particular phenotype that we're interested in. And so some of those are the unique features of Genes and Health, and have really fueled some fantastic science, which is not just from ourselves as a group of researchers in East London and now our sites around the UK, but has really allowed the world's kind of best researchers to come to us as a genetic resource. And this is our publication list available on our website. And we have over 250 users of our trusted research environment, and we've been kind of quite ahead of the curve in terms of setting up an open access data resource with very stringent security, no data export. That has allowed us to bring in those many research teams from around the world. And I'll talk through some of the data that we've got in a little bit more detail. So, where do we work now? Well, we started in East London, and the majority of our volunteers are from East London, but I'm really pleased to say we've got sites now in Bradford, Manchester, West Midlands, and a few other sites dotted around. And the reason we've opened up in those sites is because it really is where the greatest number of British Pakistani, British Bangladeshi people reside in the UK, again, where there is health need, and also where there's some great colleagues to work with as well. And when we look at our East London data, we estimate that we've actually recruited 1 in 8 of the eligible population, and similar numbers in Bradford. And that's something we feel quite proud about, because it really demonstrates, I guess, how well-reaching we are, and how the approach that we're making is engaging and building trust and building really excellent participation. Some people say, well, hang on, there's 7 out of 8, you've still got to involve, and that's a bit of a
challenge for us. Now, why have we managed to get to these big numbers? Well, this isn't all about data and fancy science and all the rest of it. This is also about building a study, and we've done this from the get-go, that is trusted, that is truly community engaged, and that is built on face-to-face recruitment with and involving people from these communities, making that first contact, often in Bengali, in Sylheti, in Urdu, in relevant languages, and building that trust by saying this is why we're needed, this is what we're doing, and proactively addressing sensitive topics. And of course, things like data security and how we're using data is a big, big sensitive topic. And our research teams around the country are very, very skilled at communicating how we manage our data, how secure it is, how we've never had a data breach, and really kind of how we work as a study to overcome some of that. And I think we've succeeded in many ways. It's not easy. It's very, very labor intensive for our teams to go out and recruit, but it's the way that we think research like this needs to be done, and building that trust is absolutely critical. We have not just our community members at the front face of the study, but we have also a fantastic community advisory board that guides and shapes the study as we go along. And we go to where we meet regularly, but they also particularly help us when there's a sensitive topic to discuss, like a research team wanting to work on stem cells, or in the light of kind of data breaches in other studies, how are we kind of communicating our own data security policies, things like that. And they've been a really, really key part of our study and our growth over the last 10 years. And I guess the other thing is that our partnerships are, that we're not just an academic study, we have multiple NHS partners, and that's been really, really valuable for us, particularly in terms of health data linkages. We've got a number of community organisations working with, supporting us, funders including Wellcome, UKRI and NIHR. But most recently, we've had a really phenomenal industry consortium with 8 pharma partners in a pre-competitive arrangement, with them all working together in a consortium, funding our study and the generation of some very high quality exome data, but also working in a way that really advances our science and maximises our potential as a study. And it's been a very, very successful few years working with those partners. So that's some background. Now, let's just talk a little bit about the data that we have. So, I mean, I can't possibly kind of say any more than Cathie's already said today about the absolute value of NHS data, health data. We've got this phenomenal resource at our fingertips, and the longitudinal nature of NHS health data is so, so valuable for us in research terms. And this was apparent to us really very early on when we started just churning through some of the data linkages that we had, and we saw just how many data points single individuals had for traits like creatinine, a measure of kidney function, and that we could map these out in trajectories and understand people's health really just, from a data linkage. This comes as no surprise now, because we're all getting much more kind of, in tune with the potential of this. But it's really underpinned a lot of the potential for us as a study to work across many areas of health and disease. And this is possibly the most unengaging looking slide you could ever look at. But I guess what it says is that, so our data team, which is 2 people, phenomenal 2 people, they describe themselves as data avaricious, okay? We go out, we make these data linkages, we have a phenomenal set of data linkages from multiple local NHS partners in East London, our primary care partners, nationally with NHS Digital, with multiple secondary care trusts, and lots more. And what that allows us to do is build some really phenomenal data pipelines, and that is based on our binary traits, so disease, yes or no, okay, and then also increasingly quantitative traits. So these are just some examples of the quantitative trait data pipeline that we've got. And we've got well over 100 of these and multiple time points per every single trait here. And we refresh these twice a year and are bringing in increasing numbers of linkages as we go along. And for many of our volunteers, they're coming with 30 years of health data, and it's, you know, it has huge potential to work across multiple disease areas, but also at these kind of quantitative trait pipelines. And we're also now beginning to supplement that data with specific data linkages, including, we've done a lot of work at the moment on prescribing data. We're starting to bring in imaging data, and we're doing some specific work as well on mental health and maternity data, and trying to fill in some data gaps with some surveys as well. We're obviously a little bit biased towards illness because we predominantly recruit in GP surgeries and NHS settings, but actually I think it's pretty good for those of us working in common disease to have a little bit of bias in that way. We are still missing national primary care data, and we're super excited about HDRS and the potential there. That's going to add huge value once we can get national primary care data. And we've had all sorts of headaches along the way. Many of you are familiar with these. One of the particular ones was getting approval for worldwide territory of use within our trusted research environment for our international researchers and our pharma partners. That's finally, after a very, very long process, been approved. And this is just another new set of a new data linkage that we've just brought in, which is some retinal screening data, which overcomes a lot of the challenges in primary care to ascertain kind of end diabetes kind of complications and things. Okay. So what about our genetic data? Well, we have Illumina genotype GSA chip data on 51,000 of our participants. That's actually going up to 70 later this year. And we've also got these high-depth exomes, really high-quality exomes that was funded through our industry partnership. And these are all available in our trusted research environment for researchers to access and to link to our health data. And what we're very keen to do, and the way we work, is that we try and make this data as research ready as possible, so that you can apply to us. It's a simple procedure. If it's a data-only application, it's quicker and easier than the biobank one. You pay a small access fee, and then the world is your oyster with this data, and it's all in reproducible pipelines, Regini ready for those of you kind of doing your genetic analyses, and a really, really nice resource for you to work with. And our GWAS pipeline is in fact, much of it is in publicly available data sets for you to use. And when we run GWASs, which we do every year with our data refreshes, we see all sorts of interesting things, funny traits like rare, not rare, but kind of blood cells, subtypes, basophils, and genetic associations with that, which we hope is going to interest someone out there. It's not an area for any of us. And predictable associations, and that's a very reassuring thing for us to have BRCA pop out of some of these GWAS studies that we do across our quant and our binary traits. And then when we go then into our exome data, which is where I think we have real value, added value, when we meta-analyze, and this is work with one of our pharma partners, we can begin to see the added value of having people from these ancestral backgrounds involved in our study and having this exome data, because we can start to identify novel gene phenotype associations, which biobank does not have the ability to do. And this ability to discover these rare variants is really underpinning a lot of the work that we're doing with our pharma partners and that they are doing themselves. And actually, in particular, what we're able to discover, and again, this relates to the autozygosity within our cohort, is that we're able to identify a lot of homozygote individuals carrying predicted loss of function genotypes. And they may be, and we, as the data kind of scales up, we're continuing to discover those. And so that's actually allowed us to set an even higher recruitment target, because we're continuing to discover these ultra-rare loss of function variants that are kind of aiding a lot of discovery. And again, this is just another representation of this, of these gene knockouts. And what you can see here is that in our 55,000 exomes, we were able to find 546 knockouts that hadn't been identified before. You might say, if you then look on the right, well, UK Biobank's done better. I'm sounding awfully competitive, aren't I? I'm not really, honestly. UK Biobank has managed to find 3 times that much, but that's with recruiting 10 times as many, with having a cohort size 10 times bigger than ours. So ours is an efficient way to identify more of these gene knockouts, okay? And this is work, again, with our pharma partners, it's starting to use some of those ultra-rare variants to be able to inform drug development pathways. And these are a whole load of new drugs coming through for LDL cholesterol triglycerides. And a lot of these rare variants are providing evidence that is very coherent and consistent with the drug development pathways that they're building. And not just about developing new drugs, but also giving safety signals for drugs. Okay, so HSD 17B13 is a big drug target for pharma companies to treat fatty liver disease. And we have 3 female individuals in Genes and Health who have gene knockouts, who are homozygous for loss of function variants in that gene, and they're all healthy. Okay, and that is a really, really helpful thing for a pharma company to know in that drug development pathway. Similarly, we have the converse, so people with knockouts for IGF-1R are hyperglycemic, and that's a signal that has arisen from drugs targeting that pathway, and it provides, again, further triangulation of what we're learning about drug safety. And one of our biggest stories, and actually this is a really early one, was a single Genes and Health volunteer that we were able to recall. This is actually one of our Bradford volunteers. We recalled on the basis of her carrying being homozygous for a loss of function variant in the HAO1 gene, which is in a metabolic pathway. And this was a pathway that was being targeted by Alnylam with an RNAi therapeutic that they were developing for pediatric or primary hyperoxaluria. So a really nasty inborn error of metabolism causing kind of early mortality in the children born with this. And our individual volunteer who had a knockout for this gene in this pathway was entirely healthy, okay? She'd had normal pregnancies, she was fit and well, no diseases at all whatsoever. We recalled her. We confirmed that this gene was having an impact biochemically from urine metabolomics. But the fact that she was healthy gave huge amounts of kind of security and information to Alnylam to be able to say, we've got this new drug, we really think it's safe. And this data went into the FDA submission. It wasn't the only thing, but it was a key contribution to that FDA submission. And this drug is now used it's even approved by NICE now. And it really just shows the power of a single volunteer, yeah? And having had that great conversation with them at the outset, recruited them into the study, built trust, which allowed us to then recontact her, invite her into a recall study that she came to. And we've ended up really helping to bring a new drug. Okay, so this is where I'm a little bit stretched. We're doing a lot of proteomic work now, and this is with Claudia Langenberg and team also at Queen Mary, and we've done a pilot study with 1,500 of our participants coming through recall studies, and we've taken a plasma sample from them, spun it down, got it into the freezer within an hour, and then run multiple proteomic assays. And this is kind of early days, it's reasonably small numbers, but what this is allowing us to do is, particularly with the predicted loss of function variants that are novel, where we don't have conclusive evidence on their functionality, but even more so the missense variants, where our bioinformatic tools don't particularly help us determine functionality. The proteomic data that we're generating is fantastically useful to determine functionality without the years of lab work and in vitro work that many of you know from days of old, and that obviously still has a place, but the proteomic data is really, really informing a lot of that functionality that we really need to know about. It's also telling us a lot about the different proteomic platforms and how they perform. We've used a combination of mass spec and affinity-based platforms, and they've all got different quirks and benefits, pros and cons. I won't go into detail on this because it's well beyond my comfort zone, but we've got plenty of preprints on this for anyone who's interested to look into. And again, so what we see is then this is just our homozygous missense knockouts. We've got far more of them than the predicted loss of function variants. And we can just see the proteomic data with these extreme outliers associated with this missense variance, and that's really demonstrating where there is a functional impact that then our pharma partners or our researchers can then follow up in whatever way they want, whether it's drug development or a disease association or whatever. Okay, back to my comfort zone, and we're nearly done. So my work and my team's work is very much on type 2 diabetes and using a lens of kind of population health to understand things like the specificity of type 2 diabetes in South Asians. And this is where, again, yes, we've got this phenomenal resource based on rare variants, but actually the common variation can tell us a huge amount as well. And those of you who are clinical, and there's many people in the audience will know that type 2 diabetes in South Asian populations is different to in white European populations. It tends to come on at younger ages. It's often in lean individuals, and people often progress fast to insulin treatment. And we were able to do a big piece of work harnessing the kind of potential from polygenic risk scores has been beautifully articulated already, but actually doing an even more deep dive into the polygenic risk of these diseases and working with what's called partition polygenic scores that have been grouped into etiological pathways. And by using those partition scores, we're able to unpick specific genetic risk associated with type 2 diabetes in our South Asians, which is the genetic risk for insulin deficiency and unfavorable fat distribution. So those really specific clinical features that we see are underpinned by genetic difference. And people who have the highest genetic risk in these partition polygenic score categories are diagnosed a staggering 8 years earlier, they are slimmer, and they progress faster to complications. And I won't go through all of this because I've talked about some of these examples already, but I think another really, really important story that my colleague Emma McGavin at Queen Mary has uncovered is common variants in a CYP gene. Many of you, the pharmacists and pharmacologists in the audience will know this already, leads to poor activation of clopidogrel. What hadn't been established is just how common those variants are in South Asian people. They're, I think, present in 1 in 4 or 1 in 5 of our participants, and that leads to clopidogrel not working nearly as effectively, and then a greater chance of recurrent heart attack, which is where clopidogrel is used to prevent it. And that has been taken already into national and European guidelines. So again, another nice case story. The last demonstration, I think, of where we as a study can add value is, again, it's another common variant story, but it also rests very heavily on our longitudinal data. And this is work that my team are doing a lot of work on now, and with Eunice Zhang and Exeter. And this is looking at the genetic variants that affect the accuracy of HbA1c. And this is a big, big emerging story. We're also working on it in Black African, Black Caribbean individuals in a new study in the UK. And what we know now is that there are common genetic variants that affect the red blood cell, often the integrity of the membrane around it, that significantly impact how your HbA1c reads glucose, okay? And for an equivalent level of glucose, people carrying some of these variants might have a much lower or a much higher HbA1c. So we've demonstrated this now in G6PD deficiency. This is more of an impact story in people of African ancestry, but 1 in 63 of our participants in Genes and Health have this variant. It's X-linked, so it's men more than women, and it leads to a 10 millimole per mole lower HbA1c with an equivalent glucose. Therefore, a significant delay in diagnosis and inevitable a higher rate of complications. A really staggering contributor to the health inequalities we see in diabetes. But there are more. There's PISO1, a gene variant that's not particularly associated with a clinical syndrome or condition, but it's carried by 1 in 12 South Asians. That lowers the HbA1c by 4 millimoles per mole. And again, that does have real impact at population level. Underdiagnosed type 2 diabetes and pre-diabetes, so you miss all of your chances to prevent the condition. And then thalassemia trait. We all know thalassemia trait's out there. We don't screen for it regularly outside of pregnancy. It's affecting 1 in 20 South Asians. That has the opposite impact. It increases your HbA1c with an equivalent glucose. And so we're over-diagnosing and probably over-treating. Okay? So I hope I've shown you in a fairly whistle-stop tour what we can do with, firstly, a study that builds trust and works well and authentically with underrepresented populations where there's health need by building an infrastructure based around health data and genetic data, and building an infrastructure that is A, safe, and B, open access and brings people into it that can really drive research and research impact. We are continuing as a study. We're looking back 10 years, but we're also now looking forward 10 years, and we're just at the moment in quite late-stage discussions about a second industry consortium, which will be super exciting if that gets funded, and we're aiming to recruit up to 125,000 people with more multiomics, more data, and more of what we're doing already. A huge, huge thank you to our research volunteers who really have built this study for us, and their participation and their ongoing participation through Recall is just phenomenal. And also to our team, many of whom have been working with us since the very, very beginning, and it's a fantastic group of people to work with, and I'm just one small cog in this big and wonderful team. Thank you.
Great talk. Thank you very much. We've got time for 1 or 2 questions.
Don't ask me about proteomics, though, please.
Cathie.
Yeah, first of all, Sarah, what fantastic talk. Really, really brilliant to learn all those details about genes and health study. I've got 1,000,001 questions to ask you, but for now, you're operating through a TRE or secure data environment model, and you have done from the get-go. What kind of challenges do you encounter when it comes to combining or meta-analysing your data with other resources that work in a similar way? So you've combined with UK Biobank, which has presumably relied on the fact that you have access to UK Biobank data that you can upload to your own TRE and combine it in that way. I just wondered if you could reflect on those
it's
challenges.
It's a really, really good question, and actually we're being pushed quite hard by our industry partners at the moment to take a slightly different approach to this, because of course so I guess there is huge potential for us to meta-analyse with summary statistics, and that's what genomics people do all the time, and you can get huge value from doing that. And so that is the predominant model of joining up across data sets, okay? We very, very rarely export any data other than those summary stats, okay? And if and when we do, it is with very, very high levels of scrutiny and export control, and basically no one has export controls switched on apart from David, actually, so it's quite a different model. Now, that model has been set up on the basis of TREs, I guess the early days of TREs, where you had your TRE and that was yours, and there was no kind of integration across TREs. But I think they are changing, and quite rightly, the ability to combine at more depth than just the summary stats is recognised. And I think the TRE developments, and I know UK Biobank are well ahead of some of this, the TRE and the technical developments to join those things are coming through, and we're basically fact-finding at the moment to work out how we can do that, because yes, our partners are very, very keen for us to do so.
Great. Last question.
Thanks, Sarah, for great presentation. My question is around whether you have investigated the gene environmental interaction if you compare South Asian people in the UK with whether you have access to also South Asian people in their continent?
It's a really good question. So in my team's work and my colleague Eunice Zhang's team, in diabetes, we are doing a lot of work now with a cohort in India, which provides an ancestral comparison, but also an environmental comparison. I guess in all honesty, Genes and Health is not a great cohort for environmental work, and that is on the basis of our NHS data. You know, we're able to identify people with their lowest super output area, so a small geographical location, but we don't have individual level environmental data. We also don't have sufficient consent for a lot of social care data linkages, and we've talked about this quite a lot as a team. Our original consent was very much built around health data work, and we have to respect the consent processes and the sensitivities of any kind of wider determinants of health, social, data linkages, which I think would be quite challenging to a lot of our participants. So I think, there are a few environmental things or social factors that yes, you can look at, but I wouldn't say it's our particular USP.
Great, thank you very much. So thanks very much to all the speakers this morning. It's time for tea or coffee upstairs, and please try to come back for 10 past, please. Thank you. Okay, let's get started. So this session, and we always have this particular session, a second session, it's for emerging career researchers. Note, I don't call them early career researchers, we call them emerging career researchers. It's a great pleasure to have 3 emerging career researchers who are going to tell us about some of the work they're doing in the pharmacogenomics area. So the first speaker is going to be Dr. John McDermott from University of Manchester. And John has been doing some excellent work in many different areas of pharmacogenomics, but particularly on the implementation end. And he's going to tell you about a study that he's been coordinating called the Integrating Pharmacogenomics Guided Prescribing into Primary Care Study, the NHS PROGRESS study. So please, John.
Thank you very much, Munir. Hello, everybody. So I'm John, clinical geneticist based in Manchester and an academic at the University of Manchester. So you will all know genetic variation is incredibly common in the population. We've heard already today how frequent these genetic changes can be. I've just come from the European Society of Human Genetics. Caroline Wright presented some beautiful data looking at UK biobank cohorts and all of those cohorts, showing that the average individual in those cohorts carries around 4.5 million variants. And as we've heard already today, that is probably a vast underestimate when you look at other populations as well. The question is, how do we take knowledge of that genetic variation and apply it in practice to undertake personalised or precision medicine, which is very much adjacent to what we're thinking about here at this conference. So broadly, you can split it up into a number of steps. First of all, we need to do really good work, good scientific work, to demonstrate that genotype to phenotype relationship. How might a change in a gene influence your response to a medicine? And then once you have an important genetic change, how do you develop the technologies to ensure that it is available in a clinically relevant format and a clinically relevant time frame? And then we need to implement. We need to show that actually, A, this isn't disrupting normal standards of care, and B, it's actually improving outcomes on an individual or a population level when you put it into practice. And of course, across all of that, we need to make sure this is acceptable to patients and also healthcare professionals who will be using this information and demonstrate quite clearly that this is going to be health economically viable for a health system, whatever that health system may be. Now, historically, we've been very, very good at this bit, establishing genotype to phenotype relationships. As I say, in Gothenburg, where the ESHG was, there were beautiful talks demonstrating new disorders. We've done this for many years, but actually moving this into routine clinical care, which is very much the promise of the 10-year plan, we've actually not done huge amounts of this before, and that's the area that my group tend to think about. To think about pharmacogenomics specifically, we know there are lots of implementation pilots, implementation efforts around the world, and many colleagues here would have been involved in those. We know that a few years ago, Jesse Sven and colleagues published the PREPARE trial, demonstrating the value of preemptive pharmacogenomic guided prescribing to reduce adverse drug reactions. But despite this increasing wealth of evidence and a large number of publications from groups like CPIC and increasingly now CERSI in the UK, implementation in the NHS has remained limited. And so the questions we started to ask ourselves as part of the Network of Excellence for Pharmacogenomics, which I am part of, based out of Manchester, is why does that gap exist? Should we overcome it? How do we overcome it? And part of the question that we need to think about is, what do we mean by a pharmacogenomic intervention? If you were to say we're going to implement pharmacogenomics in the NHS, what does that actually mean? And I think if you ask different people, you'll get different answers. If you ask people who focus in the laboratory space, they'll think very closely about the test itself. People will agonize over the testing approach, which technology to use. If you ask the clinicians who might be using that information, they'll say, well, no, pharmacogenetics is how I use that information to actually guide prescribing. And in reality, it's a combination between those two approaches. The testing approach, and this is very broadly, can be split up into single gene testing, so you're looking at a single gene, single point in time, or panel-based testing, multiple genes. And you can use different technologies for that, whether it's a SNP-based approach or sequencing-based approach. And then there's a question of how you actually get that into practice. And again, this is broad, but you can think about reactive testing, which is very much what we do at the moment. You see a patient, you think they need a test, you put that into practice. You can do a reactive with planned reuse, where you use that data across an individual's lifetime again, or fully preemptive. And healthcare systems have very much started with this reactive single gene testing approach, but increasingly programs are moving towards this bottom right-hand corner, looking at preemptive models of delivery and panel-based testing. And just to explore that schematically, so reactive testing, you see a patient, you need to wait for a period of time, and then actually think about adjusting the medicine. In many scenarios, that won't work, because you can't wait potentially a month for a result to come back. If you've got a patient with pain, you just want to issue that prescription. Reactive with planned reuse gets around that issue to an extent for future prescribing. And then fully preemptive, the idea is you have that data embedded within your health system, and every time the patient presents, you can use it again in the future. There's obviously huge technical limitations to how you surface that data in the right way. And this all starts to surface around the challenge of turnaround time. And we've started to explore this idea of the decision utility function, the idea that the value of a pharmacogenetic test is greatest when you have it at the point of prescribing, and then it decreases exponentially the longer you're waiting for that result. And those of you who are clinicians will be quite clear that if you have that information when you're going to do the thing you want to do with it, it's very valuable. If you have to wait many months, it breaks clinical pathways. So we think an awful lot about how we design these interventions, and part of that is about talking to people who are actually going to be using them. I'm a clinical geneticist. I do not do huge amounts of prescribing. So we go out and speak to clinical colleagues who will be doing that. And so we did a lot of work with GPs, focus groups, with our colleagues at the NHR ARC, and we said, what do you want from a pharmacogenomic intervention? And some said, if I'm going to use this being pharmacogenetics, I need the results to come back really quickly. I can't tell my patients to come back in 4 months for their prescription. And my favourite quote of all was, I don't want to think about genetics. I don't understand it. I don't have time or inclination to learn. It needs to be simple. And what I want, if you take nothing else from this talk, I want to reinforce that this is an odd group of people who think a lot about genetics, think a lot about pharmacogenetics. The people be using this information do not spend a lot of time thinking about genetics, and they should not do, because they are busy, they are doing other things. So we need to make this intervention useful and easy. And that's kind of the background to the PROGRESS study and why we developed it in the way that we did. And essentially, it was a multi-center implementation trial of pharmacogenomic guided prescribing in primary care. And we looked broadly at the recruitment, sampling, and laboratory pathways, and then tools to inform genotype-guided prescribing. So it was very much the how do we do this, how do we get this into practice? And the objective was to determine how pharmacogenomic-guided prescribing can be delivered and used effectively in primary care practice, and specifically to look at the factors that influence its implementation, influence the uptake of the use of that data. And so the way the study was designed is that a patient would attend their GP practice, and they would be considered as part of routine clinical care for one of these index medicines. So antidepressants, opioids, PPIs, and statins. And there'd be a conversation between the healthcare professional and the patient saying, we've got a study ongoing at the moment where we're looking at using genetics to choose the right medicine for you. Are you interested in that? And if they said, yes, I am interested in that, they'd be given a study pack, which they would take home. They would consent asynchronously, which was a lot of work to design that process, but we thought it was very important, given this was being done at GP practices around the country. And then they would, these images are taken from the video that we developed. They would be coached in how to complete the saliva sample, and they would post that back to us, and then it would hit our laboratory. It's important to state here, because it becomes relevant a little bit later, is the GPs had two options. They could either prescribe before the results were available. So the patient would be recruited, but they'd say, well, we'll start you on a medicine now, and then when we get the results, we can amend it if we need to. Or they could say, no, we're going to wait until the results are available. And clearly there were lots of factors that would influence that, individual factors for the patient, but also the preferences of the GP. We didn't dictate that explicitly within the protocol. The sample would hit our laboratory based in Manchester, and the vast majority of all the samples were ran using the Agena Bioscience Veridase core panel, and we would look at 4 key study genes, CYP2C19, CYP2D6, SLCO1B1, and CYP2C9, and we were trying to aim for an end-to-end turnaround time of 10 days, and that was based on some discrete choice experiments that we'd done several years before, looking at how the willingness to participate in these types of initiatives based on a number of factors. And then we knew that there would be some specifically CYP2D6 alleles that we would be unable to resolve using SNP-based genotyping. And so we had collaborations with PacBio and Nanopore, which was an adjacent program of work to look at how we could resolve those, but they weren't included in that 10-day turnaround time. We would then generate the data from the lab test, and then it would be uploaded into a clinical system that we have in Manchester that's called Geno. We adapted that, we piggybacked on it for pharmacogenomic guided prescribing, and this is the type of thing that the GP would see. So the patient's been enrolled in the PROGRESS study because they prescribed citalopram. Prescribing recommendations can be reviewed below. This patient's an ultra-rapid metabolizer, an alternative should be chosen, and then they could click on more detail for what those alternatives might be. And there's this drop-down list, and you could choose from all of the study medicines if the patient were to present again. So that was during phase 1 that we used this system. And throughout the study, people could access it if they wished. But in reality, the model that we wanted to move towards was a model where GPs, clinicians, healthcare professionals didn't have to go out to a separate system, because again, I mentioned this discrete choice experiment work that we'd done previously. One of the biggest factors that influenced whether a healthcare professional was going to use pharmacogenomics was they didn't want to go out to a separate system. They wanted it accessible within the patient record. And we worked with clinical architecture and colleagues at First Data Bank to develop this Progress RX type system. And the principle of that was it was agnostic of your laboratory provider, and it's agnostic of your electronic healthcare record provider as well. And essentially, part of that is about structuring your genomic data as part of genomic archetypes. So this is a QR code that will take you to that genomic archetype, but essentially we would take that unstructured data from the different laboratory assays, we'd have an import interface and then structure it within this data repository. So in principle, when a healthcare professional went to prescribe within their GP practice, there would be a call out from the clinical system to Progress RX. There would be an API call, and this is the type of alert that they would see. So this is an example of codeine. Sorry, it's a little bit small, but this patient's a poor metabolizer for CYP2D6. They've got reduced morphine formation. Consider an alternative. And the wording and the structure and how these are presented, it's really, really important. And so we've done a lot of work around the kind of user design of how these things are surfaced, and things like the CERSI guidelines, the knowledge base that underpins all of this is really, really important. But this is how clinicians want to be able to see the data. It's part of their workflow. It's not something separate that they have to think about. So we surfaced that data with 3 different flags, and this was part of our analysis process. So no impact, the genetic data didn't influence the likelihood of them responding to that medicine. Clinically relevant, so an orange flag where maybe there wasn't an explicit recommendation to change the dose or the medicine, but there was an increased risk of the patient potentially not responding in the future. So this is CPIC guidance that might say things like monitor more closely for side effects, for example. And then clinically actionable, where there was a clear recommendation, they should have a change in their dose or a change to the agent that was chosen altogether. So we looked at 3 key areas. We looked at the prescribing behaviour, which was monitored as part of the study, so what clinicians did with this information, because we're just getting this information out there into the wild and seeing what they do with it. We've now looked at relevance of data for previous prescribing, and we're in a follow-up period at the moment where we're looking at how clinicians continue to access this data over time and the potential value for future prescribing. So our primary objective, what the study was powered against, was to look at the proportion of patients who had a clinically relevant pharmacogenomic variant related to the medicine class, which precipitated recruitment to the study. And this is based on a pharmacogenomic clinical utility metric, which we defined a few years ago. Really, our secondary objectives were the kind of key things that we were interested in from a process perspective. So this is how that information is being used, the turnaround time, can we actually get that information into the hands of clinicians, and is that information actually are the recommendations being followed? Is it leading to a change in prescribing practice? So as part of the study, we recruited 1,350 participants from GP practices across England. This was based on an initial identified eligible cohort of 1,424. A number of patients didn't return samples. A number of patients withdrew during that consenting process. And so this led to our full analysis cohort. Recruitment across the study sites was not equally distributed. This is important, an important potential source of bias. So we had some extremely engaged clinical practices. We had some clinical practices that weren't particularly engaged and might have recruited a handful of patients. You can see our recruitment over time. The vast majority of recruits, or a large proportion of recruits, were from the northwest of England, but we did get recruits from each of the GMSA or the GLH regions around the country. And we saw a kind of broad distribution of ethnicities and male to female, with a higher ratio of females recruited. The majority of patients recruited were of white ancestry, and as we've heard already, it's important that we think about how we can improve that for studies going forward. So thinking about the turnaround time, this is the time from the patient walking into their GP practice, knowing nothing about the study, to getting results into the hands of the clinician. So we were able to achieve a median turnaround time of 10 days. There was a number where it was significantly longer. That was often because the samples weren't returned, or the patients hadn't consented, they hadn't gone online. And so you can see that the standard breakdown. We've got a significant amount of time that's taken from the patient being seen to them consenting online, but we've really managed to accelerate and shorten that laboratory process to get the results through as quickly as possible, where from the results hitting our laboratory, we were able to generate an output that could be loaded into our systems within approximately 3 to 4 days. So significantly rapid turnaround times, given how lengthy turnaround times for genetic testing can often be. Goes without saying, pharmacogenomic variation was incredibly common across the study cohort. This has been seen many times before, but it's important to see in this breakdown. When we specifically look at anyone who had a non-wild type variant in any of the 4 key study genes, that was just over 90% of individuals. And when you look at the broader gene panel, that was almost that all participants would carry a variant that could theoretically impact prescribing. So we know genetic variation is common. We know we can get those results back relatively quickly. But actually, are patients exposed to medicines for which it's relevant? And that was the next step. And we found that approximately 1 in 10 participants had a red flag recommendation. And you can see the breakdown by the different medicine classes here. So large proportion of patients were recruited based on SSRIs and statins. So here you can see around 1 in 10 participants had one of these red flag recommendations. Another 40% or so had an orange flag recommendation. So around half all participants were receiving a piece of guidance that was potentially going to influence their prescribing behaviour somewhat. And you can see the breakdown by the different medicine classes here. obviously the way the guidance is written, how you assign these different flags is a decision for each individual health program, each individual research project. And so for statins, we had no real red flag recommendations, whereas for SSRIs and tricyclics, we had a relatively larger number. So again, that's great. We found genetic variation is very common. We found it's related to medicines. People are exposed to these medicines, but is it changing behavior? And we found that it was. And remember, this is data that we are just putting out there into these portals, into the electronic healthcare record. We weren't sure what healthcare professionals would actually do with them. And we saw that pharmacogenomic guidance significantly impacted clinical decision making. So if you had a red flag recommendation, you were far more likely to have a prescribing adjustment than if you had an orange flag and a green flag recommendation. It wasn't perfect. We know that the guidance wasn't always followed, and similarly, people who had one of these green flag recommendations would often receive another medicine when they came back to see their GP. But that's, to an extent, what we expected, because we know this is a noisy environment. Clinical decisions shift, patient preferences shift when they're potentially coming back for these medicines, and so it was useful to see that the prescribing recommendation impacted clinical behaviour. And so we saw around 25% of all participants had their prescriptions adjusted based on red or orange recommendations to the class that was recommended. But of those individuals that didn't have their prescribing adjusted, we wanted to understand what potentially were the factors that led to that. And again, you can see here, with regard to the odds ratio, that the recommendation flag made a big difference. One of the things that made the most difference was this idea around delayed prescribing. I said towards the middle of the presentation that clinicians had the decision whether they made that prescribing adjustment at the beginning or they waited for the medicines. And actually, if they waited for the results to be available, they were individuals were far more likely to follow that prescribing guidance. And that speaks to this concept of models of service delivery that I touched on right at the beginning. So if that data is available at the point of prescribing, the information is far more likely to be used. And so when health systems are thinking about how they design these interventions, it's really important to, A, prioritize turnaround time if you don't have that preemptive model, but B, think about how you can embed that data within the healthcare records so it is there at the point of prescribing if this is a route that we're going to go towards. And so this is just another way to present that. So we saw that clearly the recommendation flag influenced the probability of having a prescribing change, but if you stratify by the results were available before or after, you then saw a significant difference. And the final thing to touch on, the value of having that data available longitudinally is a piece of work that we are undertaking at the moment, looking at data collected from these primary care electronic healthcare records, looking at prescribing data in the future. And as I said, this is ongoing, but we saw that this data was being reaccessed over time, both by the portal and via these the API callouts. And we saw that around just over 10% of participants had their data accessed to guide future prescribing, 80% within class, 20% out of class, and we've seen around 90% of participants want access to their own results, and that's a separate program of work we have ongoing at the moment. We've just got access to previous prescribing data. As you can imagine, these patients have had lots and lots of medicines. This is the 10 years prior to being recruited in this study, nearly 50,000 past prescriptions across this cohort. Around 85% of participants were exposed to at least one medicine with a CPIC guideline, and there were lots of medicines. So the median past prescription number was 26, with a significant range. Incredibly, someone had 232 different prescriptions across those previous 10 years. But what's relevant, if we combine that with the genetic data, is around 65% of participants had a red or orange flag recommendation, and around 30% of those had a red flag interaction at some stage in the past. The work that's ongoing now is to understand whether that might be influenced by other factors, and then moving on to, did that potentially impact on outcomes, which is a much broader piece of work. So to conclude, using a reactive with reuse strategy identifies clinically relevant or clinically actionable variants in half of all participants. We saw that pharmacogenomic guidance results in meaningful behaviour change, leading to prescribing adjustments in around a quarter of all participants. The models of service delivery absolutely matter. So We need to move from generating data, generating the insights from those data, to actually changing behavior in clinical practice. And how you change behavior is influenced by how we design these systems, how we design these services, and clearly having that data available at the point of prescribing has significant value. The next step is to truly ensure that by doing this, it's leading to meaningful outcomes, improvement in outcomes on both an individual and a population level. And this is what we're aiming to do in the PROGRESS study, but as part of a wider portfolio of work, thinking about how we can capture those outcomes on a population level and show that this is making a difference for the health service and a justifiable way to use the money that is within the NHS. So this has been a huge programme of work. It's an ongoing programme of work. I'm very grateful to all my colleagues at Manchester. Nicola and Eva have been our project managers who've very much kept us in check and led on this. I'm incredibly grateful to them. Very happy to take any questions. The final thing I want to say is we are recruiting to our next study at the moment, which is a study looking at pharmacogenomic guided prescribing of antidepressants, if GP practices are interested in this. And we've got a training course coming up in Manchester. Thank you very much.
Thanks, John. Open for questions. Maria?
That's a fantastic study that you're leading, John, and great talk. Thank you very much. Have you considered adapting the PROGRESS protocol to a population-based cohort like our Future Health that feedbacks to the participants? And if you have you contacted them and asked them if they're interested? Because they start sharing genetic data as well, I think.
Yeah, great question. And I think that would be a fantastic piece of work to do. The challenges are around, and it's not just our Future Health, it's lots of these studies and how they're set up. So their kind of chain of custody around the genomic data, how they perceive the data to be clinical grade or not. So I think there is work going on at our Future Health to think about how it's uplifted from research data to clinical grade data, and then it can be returned potentially. At the moment, I don't think that's quite where they are, but it's definitely something that I think we should think about in the future, because there is huge amounts of data out there already that can be reanalyzed, reinterpreted, and then if we have these pathways, these portals, get it back into practice. I think it's a really useful thought.
Thank you for this very interesting presentation. I just have a quick question about the interaction alerts that you showed. The content of what is presented to the GPs or to the practitioners who are ordering medications, have you asked the GPs what they would like to see?
Yeah.
Okay.
Yeah, so when we designed our kind of knowledge base, as it were, that underpinned a lot of the PROGRESS study, we worked with the PIs at each site to say, what do you want? We'd kind of say, this is the standard guidance, and they'd look at that and say, I don't know what any of this means. This is too complicated. So we'd work with them to try and adjust that. There's obviously governance issues around how you do that, because then you're not just relying on established international consensus, you're adjusting it. So we have to think about that very carefully within the ethical framework. But I think if we are to return this information, we can't just do that verbatim CPIC.
Were these a self-selected group of GPs that were enthusiasts? Because if you go to wider, I'm asking about generalizability in primary care.
Yeah. They are. That's the nature of any study. You've got GPs who are very enthusiastic in research, number one, but also kind of genetics and precision medicine, number two. The hardest bit really is getting them to recruit, getting them to remember the study and put it forward. Actually, I think there are ways to get GPs who potentially aren't engaged, providing they're happy to use that information if it's just surfaced to them, like they would use an EGFR alert that surfaced them to guide nitrofurantoin prescription. So they might not want to engage in the study, but actually as a service, if we develop it right, our sense is that they will use it because it is just another biomarker to guide prescribing.
Yeah. The problem with the alerts that come up is they switch them off.
Correct.
And we know about 75% are switched off.
Yes.
Yes. Okay, any final question, please? Yeah.
Just real quick question. So, you know, CPIC does their recommendation strong, moderate, optional, and I'm curious to know, did those categories for our strength of recommendations, did they impact prescribers and if they were going to follow the recommendation or not, or did you guys take those into consideration when you were designing your study, especially the CDS alerts?
Yeah, so we took them into consideration when we were designing the different flags, if that makes sense. So when we had to make a decision about whether it was red, orange, green, we took into consideration the different CPIC strength of evidence recommendation, because that traffic light system was far more understandable to clinicians, but then that informed the back end of how we designed that knowledge base.
Thank you very much, John. Okay, the second talk is from Dr. Stefanie Lipp, who is a senior lecturer in clinical pharmacology and genomics at Glasgow University. And Stefanie has been running a very large randomized controlled trial called the Phoenix trial with amazing trajectory of recruitment, and she's going to tell you how she's managed to do that.
Great, thank you, Munir, for the introduction. So I'm working closely with Professor Santosh Padmanabhan, who cannot be here today. And this is the first time Phoenix has been presented publicly, a pragmatic two-arm NHS trial of preemptive pharmacogenomic guided prescribing in acute and secondary care. So 3 numbers set the scene here. Phoenix has randomized 2,277 participants. As of 5 minutes ago, it's actually 2,304. And of these, 1,931 now have a clean link pharmacogenomic report. And this is the analysis population for everything I will show today. Recruitment spans more than 25 specialties in NHS Greater Glasgow and Clyde, and ranging from acute medicine to mental health. And one important point up front, because this trial is still ongoing, this is an interim methods and cohort talk. Nothing I show today will be stratified by randomization arm or conditioned on clinical outcome. It is all pooled baseline descriptive data, and the full package was reviewed by our trial statistician on 11th of June, and the statistical analysis plan for the primary endpoint remains untouched. So Phoenix sits in a very specific gap in the evidence. We know that PREPARE was a pivotal European trial. It showed that pharmacogenomic testing can reduce adverse drug reactions, and it was largely built around the trigger drug, delivered mainly to specialty clinics and used patient-reported endpoints. But Phoenix asked a different question. We combined prospective genotyping with their patient's entire prescribed medication list in UK NHS acute and secondary care. And we also use a more definitive safety endpoint and include a built-in health economic evaluation. So Phoenix is just not asking, does genotyping the trigger drug help? It is asking, what happens when preemptive pharmacogenomics is introduced into a messy reality of an acute NHS setting? That real-world substrate rather than a tightly selected cohort shapes everything that follows. The aim of Phoenix is to generate preliminary evidence on whether pharmacogenomic testing can improve medicine safety and health economic outcomes in hospitalized and secondary care patients. And the main comparison is PGX-guided prescribing versus standard of care at 3 months. That is a key design point, not a result. One of the features of the design is worth making explicit. The index drug has 2 roles. It is a replacement trigger, because patients enter Phoenix when they start one of the listed pharmacogenomic drugs, and it also anchors the primary outcome. The primary endpoint is measured on that single pre-specified drug and is a composite of an adverse drug reaction at CTCAE grade 2 or above with a formal causality assessment and or treatment failure. And this gives us a cleaner and more attributable safety signal. However, the intervention itself is the whole prescription. The PGX report does not only comment on the index drug, it returns guideline recommendations for every relevant medication the patient is currently taking, and the clinical team can act across the full regimen. So the design is deliberate. 1 drug for a clean primary endpoint, and the whole prescription for real-world care. And this is the actionability I will show later in what is calculated across the full prescribed medication list and not just the index drug. So our secondary objectives frames around our primary outcome, which falls into 3 broad groups. First is the clinical implementation, how often pharmacogenomics leads to a change in drug choice or dose. And the second is medication safety, ADR severity, serious ADR, self-reported events. And the third is medication management, dose adjustments, drug cessations, adherence, quality of life, and participant experience. One secondary objective is important for what I'll show later. We specified that we could measure the frequency of actionable genotypes at baseline. So when I show the actionability burden of Phoenix, this is what you're seeing, a descriptive baseline count pooled across the cohort. It is not an effective comparison. And eligibility, we made it broad by design because Phoenix is designed to reflect the real acute care population. Patients are eligible if they are above the age of 18, a resident of NHS Greater Glasgow and Clyde, and newly started on or about to start one of our index trial drugs. They must not have had the drug in the previous 3 months, and this was reduced from 12 months to a substantial amendment. They also need to be able to provide consent themselves or trigger to a legal representative, provide a barcode swab, and be followed up for 3 months. Importantly, I'd like to highlight that we included patients who lack capacity through a legal representative. And these are often the multi-morbid polypharmacy patients who stand to benefit most from pharmacogenomics, and they are also often the patients who are excluded from trials. The exclusions are expected safety exclusions, for example, which is very short life expectancy, advanced liver failure, severe renal impairment, and pharmacogenomic specific ones like liver transplant and stem cell transplant. And this is the design in one picture. The patients provide consent and a buccal swab, and then are randomized 1-to-1. In the intervention arm, the sample is genotyped immediately, and a guideline link report is returned to the treating team within 10 days. In the standard of care arm, the sample is stored and genotyped at 3 months. A key point here is that the report only covers the drugs the patient is currently taking. It is delivered as a single paper report at one time point, and it does not go into the permanent clinical record. What makes this durable at pace is smart recruitment. We use the NHS GGC Hospital Electronic Prescribing System to identify eligible patients algorithmically, with all data handling covered by Caldecott Guardian approval, and this is how a single health board has been able to sustain this level of activity. And the panel includes 13 pharmacogenes mapped to 74 index medicines across 93 drug gene pairs. These variants were selected because they currently have CPIC and DPWG prescribing implications. In routine production, 13 of these genes are reported for the 74 index drugs, and so this is a genuine preemptive pharmacogenomic panel, and the result is lifelong and reusable, rather than being a single drug test. Since April 2025, this is my most favorite slide, Phoenix has recruited across the entire whole hospital, and recruitment will continue under the funding ends on the 30th of September 2026, when the Living Laboratory Award concludes. The bubble plot shows every specialty on the Queen Elizabeth campus contributing. The size of each bubble represents the number recruited, and the color shows the drug family. The 3 largest recruitment specialties are cardiology, around 20%, acute internal medicine at 13%, and general surgery at 11%. But what is the most important feature is the long tail, with more than other 20 specialties also contributing. The message for this audience is that Phoenix is not a narrow tertiary specialty study. It reflects the real case mix of acute NHS Health Board, and that's what it makes it informative for implementation. So how are you doing? Phoenix is also efficient. If you look at screen failures per enrollment, where a smaller value is better, Phoenix compares well with major implementation and platform trial benchmarks. We have recruited more than 2,000 participants in 14 months from a single health board. Prepare recruited 6,944 participants over roughly 40 months across 7 countries. And electronic health record-enabled trials such as Recovery show that what is possible when routine clinical systems are used intelligently. The point is that HEPMA-driven model is just not a convenience. It is doing real operational work. It allows us to identify eligible patients rapidly, reduce screening waste, and sustain high throughput recruitment within routine NHS care. And everything from this point is interim baseline data. It is pooled, descriptive, and was signed off by a statistician, as previously mentioned, and no arm comparisons. And I'll show you 3 things: who we recruited, whether genotype data looks as expected, and how the service is performing. So this is the cohort we recruited. The median age is 58, and the age range is wide, from young adults to the very elderly. At consent, 78% of participants were taking 5 or more medications. So this is a polypharmacy-rich, multi-morbid acute care population. There are 2 features that I'll come back to shortly. First, socioeconomic deprivation is bimodal, with strong recruitment for both ends of the deprivation spectrum. And second is current smoking prevalence is around 25%, which is important because smoking is a major driver of CYP1A2 effects in this cohort. This is the kind of population NHS pharmacogenomic implementation will actually need to serve. Equity matters in implementation, so we measured it from the start. What I'm showing here is Phoenix's own recruitment distribution descriptively. By SIMD quintile, recruitment is bimodal, and the age breakdown helps explain this pattern. Younger patients are more concentrated in the most deprived quintiles, while the oldest participants are more concentrated in the least deprived quintiles. When each groups are combined, they produce a bimodal pattern seen in the whole cohort. And this matters because when the primary result is available, its generalizability would need to be interpreted against the recruitment profile. And measuring this now also makes it actionable. It allows us to identify underrepresented groups and target them during the remaining recruitment period. The next question is the genotype data, whether the genotype data looks right. We cross-reference Phoenix allele frequencies across 5 independent European sources, 1,000 genomes, Genome, non-Finnish European, Prepare, UK Biobank, and PharmGKB. For the Phoenix protocol implementation, grade markers include the CYP2C19 star 2 and star 13, and CYP2C9 star 2 and star 3, and SLCO1B1 star 5, and TPMT and DBWD. Phoenix sits within the expected concordance band. In other words, the genotype produces European reference frequencies for the markers that matters most for written implementation. And the labeled rate points are deliberate caveats, not headline findings. These include the systematic HLA tag, SNP overcall, NUD 15 star 3, based on a few handful of calls, and a panel coverage gap for UGT1A1 star 28. And we have put a structured question to the lab on each of these, and I'll come back to this shortly. The headline is that Phoenix provides a credible Scottish pharmacogenomic reference dataset for the protocol markers, and with transparent caveats where the data requires further checking. And this is not just the raw allele frequencies that look right. The full pipeline also looks right from genotype to the predicted phenotype. When we compare Phoenix with Prepare's published phenotype frequencies, Phoenix is within a few percentage points for every major metabolizer gene shown, and the ratios are essentially 1. That supports biological transportability at the level of the genotype and predicted CPIC phenotype. In other words, our acute NHS cohort looks very similar to Prepare's cohort for the pharmacogenomic signals that we'll expect to see. And what it does not prove is clinical effect transportability, and it does not tell us whether the same reduction in ADRs will be seen under NHS prescribing conditions. That is the empirical question that Phoenix is designed to answer, and only the primary analysis can answer it. And now to baseline actionability, which is the descriptive secondary objective I mentioned earlier. The number depends on the drug list you use, so we are showing all 3 nested scopes transparently. At the Phoenix Protocol 74 drug scope, participants have at least a mean of 1.10 actionable drug-gene interactions, and 2/3, 66%, have at least 1 actionable result for a medication that they're already taking. If we widen the scope to all CPIC plus DPWG guideline drugs, the mean rises to 3.23, with 90% having at least 1 actionable result. And we widen further to the full PharmGKB universe, the mean is 5.41, with 94% at least having 1. Every number here is calculated across the full prescribed medication list at consent, and it is not compared by arm and not restricted to the index drug. And the clinical message is simple. In a real acute care population, actionable pharmacogenomic results are the norm and not the exception. So where does the actionable load actually sit? The leading combinations are dominated by the CYP2C19 cluster, particularly clopidogrel and the proton pump inhibitors. And beyond that, the main contributors are SLCO1B1 with atorvastatin, CYP2D6 with codeine, and CYP2C9 with ibuprofen. And there are 2 practical implications. First, for a panel design, a focused 4-gene core of CYP2C19, CYP2D6, CYP2C9, and SLCOB1 captures most of the actionable burden. And second, for clinical pathways, the signal points to target high use cases in cardiology, gastroenterology, and pain medicine. Universal testing is one model, but it's not the only route to implementation. And when we talk about phenoconversion, genotype is the starting point, but it's not the whole story. A patient's predictor metabolizer status can be shifted by 2 things: co-prescribed drugs that inhibit or induce the same enzyme, and lifestyle factors, especially smoking, which is a strong CYP1A2 inducer. And when this happens, the effective phenotype no longer matches the genotype, and this is phenoconversion. And for example, a CYP2D6 genetic normal metabolizer who's taking a strong CYP2D6 inhibitor may behave clinically like a poor metabolizer. And if we only read the genotype, we will miss that. So what we've done is we have quantified phenoconversion across the cohort, across every prescribed drug, using a 4-layer sensitivity framework. At L0, which includes both drug and lifestyle modifiers of all strengths, 83% of participants show some phenoconversion, and that is the maximum estimate. The drug channel dominates, with co-medication alone accounting for 77%, and while lifestyle accounts for 26%. And L1 and L2 then progressively restrict the definition to stronger modifiers. Under the strongest only filter, L2, the estimate falls to 50%. What is clinically most relevant is L3 at 78%. This only accounts for phenoconversion when the predicted shift crosses the boundary from normal metabolizer to a non-normal metabolizer, and which is the point at which CPIC or DPWG dosing recommendations may change. So L0 tells us that modifiers are common, and L3 tells us how often they are likely to change the clinical decision. And this is the number we should use when sizing clinical decision support. And for CYP2C19 specifically, 42% of participants phenoconvert from genotype to effective phenotype. And 98% of those shifts are toward a reduced function, largely driven by proton pump inhibitors and other inhibitors. And all of these estimated are generated from a log rule set. Finally, is this deliverable at scale? So far, 2,079 unique kits have been processed across 2 panel chemistries. We retired from the legacy panel and moved to version 2.0 in the late 2025. And the key service metric here is turnaround time. That has improved substantially from the onboarding period. By Q2 of 2026, the median turnaround time was 23 days, and in the most recent month, May, the median swap to report time was 10 days, with 83% of the reports returned within a 28-day target. That is the clearest sign that the service is moving into steady-state delivery. The core quality on version 2.0 is at above 99.9% for every Phoenix protocol actionable gene, except CYP2D6, where it is 98.6%. The remaining issue there is largely hybrid alleles, and we also have 15 structured questions open with the laboratory focused on the small number of variants where Phoenix diverges from the European reference frequencies. Taken together, this is what NHS pharmacogenomic delivery at scale actually looks like. High throughput recruitment, improving turnaround time, high call quality, and active quality assurance where the data need further verification. So where next? So we know that recruitment will end on the 30th of September 2026 with a 3-month follow-up. The cohort should complete around the turn of the year, with the primary analysis following in early 2027 under the Trial Steering Committee oversight. That is the result the field is waiting for, a pragmatic UK NHS test of pharmacogenomics in routine care and secondary care. Alongside the primary analysis, we are developing 3 linked strands of work. The first is a drug list expansion proposal for a definitive trial. The second is health economic evaluation. And the third is focusing on smoking and CYP1A2 vignette in psychiatric inpatients, which will open once the sub-cohort matures. We are also very open to partnerships with industry and on panel design and health economics with policy colleagues on implementation pathways and with labs on assay validation. So the 3 things to take away from this talk. First, Phoenix is recruiting the real NHS acute care population, older patients, polypharmacy-rich, multimorbid, and bimodal in deprivation. This is the population pharmacogenomic implementation has to serve. The second is the genotype data looks credible. Phoenix is concordant with European reference data sets and will prepare at the level of allele and predicted phenotype frequencies. So the biology appears transportable into UK acute care. What remains to be tested is whether the clinical effect is also transportable. And this is what the primary analysis is to answer. And third, rigor matters. We are separating baseline description from effectiveness using L3 rather than L0 as the clinically relevant anchor for phenoconversion, showing transparent sensitivity layers, and working from a statistician signed off interim data. So Phoenix is not yet a conclusion. It is the NHS substrate on which the conclusion will be built, and that conclusion will come from the protected primary analysis. I would like to begin to thank the Phoenix Chief Investigator, Professor Santosh Padmanabhan, who made this trial happen. It has taken 5 years of study design, collaboration building, partnership development, and funding work to reach this point. And on a personal note, I'm very grateful to him for introducing me to pharmacogenomics and giving me the opportunity to be part of this trial. And I'd like to thank the whole Phoenix team, the investigators, trial managers, recruiters, statisticians, and the clinical research faculty nurses, and everyone involved in the delivery. And we have also been extremely fortunate to have the Trial Steering Committee chaired by Professor Sir Munir Pirmohamed with Dr. John McDermott, Professor Sir Mark Caulfield, and Professor Heng-Kian Guchla. And they provide independent oversight, expert challenge, and invaluable guidance throughout the trial, helping us maintain scientific rigor, protect trial integrity, and keeping Phoenix focused on its central clinical question. Thank you to MyDNA and Gene by Gene for the essay, pharmacogenomic report, and also all the support in making this work. And to NHS Greater Glasgow and Clyde and the University of Glasgow and the Living Lab, and to every participant who has taken part so far in this trial. And thank you, and I'll be happy to answer any questions.
Well then, thank you. What she hasn't told you is that the DNA goes to Houston and they get the results back within 10 days. They're going to Houston.
Yes, that's right.
And you often got a phone call saying Houston calling, is that right?
No, we had issues with customs when Trump changed all the tariffs. So that was a kind of a moot point in the trial, but I think it's a bit better now for some reason, because every package depends on the custom officer in the US on whether they let sample go to the lab or not. So that was one of our challenges we had, but hopefully we have fixed it now.
Okay, questions? Any questions? So you don't have oncology in there, is that right?
No, no.
Why is that? Because the hospital doesn't have oncology?
So I think when we meet with our colleagues in oncology, they're quite protective of their patients. And it's also about clinician engagement, because they feel that patients who are under their care are quite unwell, and they come in with new acute leukemia, and there's a lot of things going on, and most of them may get a transplant for their bone marrow, so we had to kind of adapt of what was available in terms of which specialties to engage with. So that's where
quite a lot of polypharmacy in oncology patients.
Yes, there is, yes. So that's something we need to try and figure out in the last few months, but it's also very consultant engagement dependent on where we can recruit our patients from too.
So since there's no other hands, Luca, please, yes, go ahead.
I had a question, but I have a comment on the oncology part. So I work in a cancer hospital, and we do preemptive pharmacogenomic testing, and we have learned from parents, and that has worked well for us and patients, that we approach them about at least 4 weeks after they start treatment,
Okay.
and then they are much better because their diagnosis has sunk in, they understand what's happening. So leaving this buffer time,
Yeah.
maybe
That's really helpful.
would be helpful as well.
We'll take that back to Glasgow and see what we can do.
And then I had a question.
Yes.
I'm a pharmacogenomics person, so don't take it negatively, but I hear so many physicians, like you showed the list of the gene drugs that were the most actionable.
Yeah.
I hear you have, I think, proton omeprazole and CYP2C19, and then decreased function SLC01B1 with the torvastatin. When I talk to primary care physicians about this, they tell me, oh, these are not important. Have you heard something like that?
So we are also looking at clinical engagement when we have a recommended action for our PGX report, and I would say it varies a lot. All PGX reports is vetted by me and Sandosh, and then I write to the clinician and the GP. So far, we had not had any issues with GPs following our recommendations, actually, but that's something we're going to look at the end of the trial to see whether any of our letters were followed through. The other thing is with our clinicians as well, because they are very busy. So having an email from me to let them know about a recommendation sometimes can add to their clinical workload. And most clinicians on the whole are actually quite supportive and quite engaging through our experience. So that's something that we would look at also at the end of the study to see how many clinicians engage with us and our recommended changes.
Thank you for a very interesting presentation. I don't think I fully grasped your study design, and I'm not sure exactly when your endpoints are reading out.
Yeah.
But very interested to see the phenoconversion aspect implemented in the study. So the genotype-phenotype correlation is actually dynamic and time-varying, and I'm just wondering whether that time-varying aspect was built into your analysis.
So at the end of the study, because it's still ongoing at the moment, so things may change, and this will be something that we look at when the study ends, because we're going to also link with our safe haven data set about what has happened to our patients after the study and also during the period of their study as well. So there's a lot of education to do and looking at what has happened to our patients. Whether some of them gave up smoking after hospital admission, who knows? If they came in with an MI, so that's a few things that we need to look at as well. So
yeah, I mean, acute inflammation has a dramatic effect, and 3-6 months down the line, they may have phenoconverted.
Yeah. So we'll hopefully know when the study ends and when we've done all our data crunching and adjudication.
So, please.
Just wanted to find out, and I'm sorry if this is a really stupid question, but step by step, you've got acute patients coming in.
Yes.
You recruit them.
Yes.
You take a blood sample or whatever the case, it goes away, and then what happens? It's an acute admission for an acute issue.
Yeah. So we are recruiting from patients who have been admitted to hospital, and also we recruit patients from the secondary care clinics. So if they get started on one of our index drug listed, the recruiters would then approach them about the study and then recruit them. So that is based on the index drug which is started in hospital. Okay, so these patients might be day 1 of their admission or day 2 after coming in with a heart attack, for example, and then we go speak to them. Depending on which arm the study is, what we do is a cheek swab and no blood test, so because patients hate having any more bloods done while they're in hospital. So it's a cheek swab, and then the patient is randomized into 2 arms. One is the intervention arm, where we get the report back within 10 days, and the other arm where the sample is stored and then genotyped at 3 months. So after that, then we have recommended actions based on the PGX report, and we write to the clinician. So these patients are in hospital, either in acutely or started on medications in the outpatient setting. So that's what we're doing at the moment. Sorry to provide. Yeah.
So you compare to prepare. So thank you for showing that we were so inefficient at recruiting.
Sorry.
Very kind of you. Secondly, we recruited 7,000 across 7 countries in prepare. Yeah. Your eventual sample size will be about 3,000 or something like that.
Yes.
So will you have the power to be able to show the kind of effect size that prepare has?
Oh, that's a hard question. I think we may not be, well, I don't know. I think it's one of these things that we need to look into and speak to our statisticians. Because I think we definitely would need a larger sample size rather than 3,000. But given the time restrictions and ending in September, that's what we can recruit up to. So our target for the end of September 30th, I'm pledging it all to everyone, is 3,000 by the end of September. Because that's what we physically can do because of the funding which runs out at the end of September. So that's what we're trying to do.
Okay, any more questions? Otherwise, thank you very much.
Thank you.
Okay, last talk in this session. Pleasure to introduce Eunice Zhang. And Eunice has worked with me for many years and is just going to tell you about the role of DPYD gene and 5FU, etc. toxicity. And Eunice is a senior postdoc at the University of Liverpool. Eunice, please.
Thank you very much for the introductions. Hi, it's a pleasure to be here to speak to you about some of the work we've been doing over the past few years. So to start, what's DPYD? For those who have not heard about DPYD, so DPYD was cloned in the early 1990s and was mapped to chromosome 1. And it was found to be a large pharmacogene spanning nearly 1 megabase in length, covering 23 exons with large intronic areas. And it's highly polymorphic. If we look at the NOMAD database, over 1,800 variants have been reported. And we've got 83 variants with specific guidelines. So DPYD, it encodes the enzyme DPD, dihydropyrimidine dehydrogenase, which is largely expressed in the liver and is involved in the catabolism and elimination of 5-fluorouracil to the inactive metabolite dihydrofluorouracil. So 5-fluorouracil, together with its oral prodrug capecitabine, belong to a group of fluoropyrimidine antimetabolite chemotherapy drugs. They are commonly used either as a monotherapy or in combination therapy for a range of solid cancers, including colorectal, breast, or aerodigestive tract cancers. Annually, over 2 million patients worldwide and approximately 600,000 patients in Europe receive treatment with fluoropyrimidine. Fluoropyrimidine is very, very effective, but it's got a narrow therapeutic index. Up to 40% of patients who receive fluoropyrimidine develop severe toxicity. And some examples of severe toxicity include bone marrow suppression, diarrhea, mucositis, hand-foot syndrome. And those patients who develop severe toxicity, 0.5 to 1% of them lead to mortality, and up to 5% in elderly. So DYPD enzyme deficiency is detected in up to 60% of patients with severe toxicity. So here's a slide showing 4 variants that are commonly reported in the literature to be significantly associated with severe fluoropyrimidine-related toxicity. Studies over the past 3 decades have shown that they are strongly related with severe fluoropyrimidine-related toxicity, and landmark studies by group in Netherlands have shown that DYPD genotype-based dose reduction together with upfront DPYD genotyping improve patient safety, prevent toxicity-related deaths, and is cost-saving. And this led to drug label changes by the EU in April 2020 and drug label change by the MHRA in October 2020. So in November 2020, the NHS commissioned DPYD genetic testing across England. It's the first pharmacogenetic test to be tested nationally, which is a great success story. We do about 8,000 tests in England annually with turnaround time about 5 days. This is all great, but there are limitations with the current NHS DPYD testing. The genetic variants are commonly found in Europeans only. And if you look at the UK population, 18% of our population is non-white. So there is a gap with these 4 variants. So what we did was we undertook a systematic review in 2024, looking at DPYD genetic variants in non-European patients with severe fluoropyrimidine-related toxicity. We identified 32 studies, and we found 53 DPYD variants across 5 ethnic populations. There was poor evidence in populations of East Asia, South Asia, and Middle East, and there was positive data from the Latinos. But what was interesting is that we found the C557 variant, which was present at the prevalence of 2% in the African reference population. This particular variant was reported in 3 case studies and in a letter to editor. So this particular variant has got a decreased enzyme function according to CIPIC. And if we look at the UK census in 2021, 4.2 of the population, which equates to about 2.4 million of the population, have identified themselves as Black, Caribbean, or African ethnic groups. So at that time, we thought it would be beneficial to include this particular variant in NHS DPYD testing. So we applied for this variant to be included in the NHS genetic test directory. So then 3 months later, so we published our systematic review in June 2024. Then 3 months later, the addition of this dosing recommendation for C557 was published in tandem with the UK SEC board. And then a month later, in October, the American Molecular Pathology Group then reported 13 variants, grouping them into Tier 1 and Tier 2. So C557 was included in the Tier 1. Then good news came in September last year, where the 5th variant, the C557 variant, was introduced in national testing across NHS. So I just want to point out that together with the 557 variant, direct testing of this particular variant was implemented to replace the proxy test for the C1236G2A variant, which was a tech SNP for this particular deep intron cryptic splice site. So moving on to what we are doing in Liverpool. So we've seen that the 4 variants are commonly found in patients of European ancestry. We've implemented the C557, which is found in populations of African ancestry. So then what about other variants or other ethnic populations? So our aim in Liverpool is to identify DPYD markers of toxicity in all ancestry populations to minimize unintended health inequalities. So we are currently recruiting prospective and retrospective patients in the UK as well as internationally. We are focusing on cellular toxicity patients with grade 3 or more toxicity using the CTCAE version 5. And we are doing DPYD sequencing across the 23 exons, including the canonical 50 base pair of DPYD exons to cover the acceptor and donor splice sites. And we are also including the deep intronic variant in exon 11. So in terms of UK recruitment, we are actively recruiting across 21 NHS sites across 14 counties. And as of yesterday, we've got over 200 severe cases recruited. So to present some unpublished findings from the analysis that we've been doing. So of the 200 patients recruited, the data I'll be presenting today will be a subset of that, so 129 from the 200. And we also have clinical cases where samples were sent for clinical sequencing in Manchester as well as at St. Guy's and St. Thomas for extended DPYD testing. And we've also got individuals from the Genes and Health. So we've got a total of 289 severe cases, and we've identified 55 DPYD variants across these patients. So let's have a look at the 4 common DPYD variants I mentioned before. So of those 4 DPYD variants, only 3 were detected because we were actually focusing on severe toxicity patients who are either wild-type or carriers of these variants and required a reduced dosage of fluoropyrimidine but still experience severe toxicity. So if we look at the non-carriers, so the wild types for the 4 NHS variants, there were 2 C557 A to G variant carriers. So bearing in mind, we did this study before the C557 variant was implemented into NHS. So if, in retrospect, these patients most likely wouldn't have experienced severe toxicity if they were tested for the C557A variant and received a dose reduction. And I like to highlight the other variants that we've identified. So taking away all the NHS variants that we've identified and the C557, we've identified a total of 51 DPYD variants across 200 individuals. And there is also a subset of patients who are non-carriers. So among the 51 DPYD variants that we've identified, they are all very, very rare. They were of occurrences of single occurrence or at most 2 occurrences. So 18 of the 51 DPYD variants have got CPIC guidelines. 13 of them were normal function, 1 was decreased function, and then 4 were loss of function. And for the decreased function variant, it's part of AMP tier 1, which is the C868 A to G variant. And this was reported in a clinical case patient. And then amongst the 4 loss of function variants, we found 2 of these that belong to AMP tier 2. which is the C299-302 deletion, which is a frame shift, and then the C1774 C2T. So of interest, this particular variant was identified in a patient of European ancestry, but if we look at the allele frequency of this particular variant in reference populations, it's more commonly found in patients of East Asian ancestry with a minor allele frequency of about 0.1%. But then if you look at the allele frequency in patients of European ancestry, the minor allele frequency is below 0.001%, which is very, very rare. So coming to the other two loss of function variants with CPIC guidelines, they don't belong to any of the AMP tier groups, but they have got CPIC guidelines available. So one of them is the C61 C2T change, which is a stop-gain variant. And then we have the C601A2C change. So I've highlighted this in red because this variant was identified in two individuals. One was a clinical case and one was a research case of European ancestry. So again, all these variants are very, very rare with minor allele frequency below 0.001%. So coming to the other 33 variants with no CPIC guidelines, 4 of them were classified by ClinVar as pathogenic or likely pathogenic, and then 4 were classified as benign, and then 25 were variants of unknown significance. And of these, 4 were novel with no RSIDs reported. And we've predicted 16 of these to be deleterious in silico. So when I mentioned about in silico prediction, this was an in silico pipeline that we've used for our systematic review, where we included 12 in silico tools. And when we say they are predicted to be in silico, it will have to be predicted, so the prediction will have to be successful across at least 60% of the tools that we've used in order to classify them as deleterious. So then we also found compound heterozygotes amongst our cases. So 99 compound heterozygotes were identified where 2 or more variants were carried in tandem. And of these 99 compound heterozygotes, we found 4 individuals who carried 2 or more variants predicted to be deleterious in silico using our pipeline. Then this leads to a case report of fatality because we observed compound heterozygosity in this particular patient. So this patient was a 64-year-old female, white British, who suffered from anal cancer. She was started on capecitabine for cancer therapy and developed grade 3 mucositis 6 days later. And it was, she was admitted to the cancer center with high temperature with severe mucositis. 5 days later, and died as an inpatient a month later. So this particular patient was heterozygous for 2 CPIC normal function variants, C1601 and then C1627, and it's also a carrier of 2 variants, so with no CPIC guidelines, the C1859A2G and the C2890, which is a novel variant. Both of these variants have been predicted to be deleterious in silico, which is interesting. So in summary, we've identified 51 rare variants in addition to the 4 common variants that are currently being tested and the 5th C5578G variant. So 35% of our variants have got CPIC guidelines, we've mentioned about the AMP tier 1 and tier 2 variants and the CPIC loss of function variants. And then 65% of our variants have got no CPIC guidelines, but some have been classified as pathogenic by ClinVar, and majority of these are variants of unknown significance. And 34% of our severe cases were compound heterozygotes. So we don't actually know, the haplotypes of DPYD, how this affects DPD function. So we'll be doing further in vitro functional work to determine the effects of these variants and haplotypes. And we would also like to evaluate whether these compound heterozygotes were carried in cis or in trans. So it has been suggested in the literature that an additional 13% of patients at risk of toxicity could be identified by incorporating rare normal missense variants. But based on our findings from our study, this is probably an underestimation. I also want to point out, where we have a group of patients who are wild type as such, who are not carrying any of the exonic or intron variants that have been being assessed using our short read sequencing. It's possible that other genes are also involved in predisposing them to severe toxicity. So in addition to recruiting in the UK, we are also recruiting internationally. So currently we've got 8 countries on board, and we'll be having 7 additional countries coming on board. We've now recruited a total of nearly 120 severe cases worldwide, with 20 from China, 15 from Thailand, 20 from Sri Lanka, and then 10 from Jordan, 50 from Nigeria, and 4 from Malaysia. So we are still recruiting, and we would like to collaborate with any other countries who would like to come on board. So please do get in touch. So to end, I would like to thank all our colleagues in Liverpool and all our collaborators who've helped with sequencing our DNA and providing the genetic data for DPYD, and all our recruiters across the UK. Thank you.
Okay.
It was a great talk. Oh, sorry. I have a question. So for the, oh gosh, I can't remember the number now, 35 variants that you found that were normal function by CPIC, do you know how many of those patients that carried those normal function variants also carried a deleterious variant? Or were they compound heterozygous patients? Unless I was reading that wrong. Sorry.
So for compound heterozygous variants, we didn't have any. So those that I have presented were have got CPIC guidelines, and they were all just a single heterozygous carrier of the particular variant. Yes. So in terms of compound heterozygotes, they were all non-CPIC variants.
So we are updating, sorry, I work with CPIC. We are updating that guideline right now. Do you know when this is going to be published?
Oh, we are writing the paper.
We are done updating the guideline, and so we're hopeful to get this out in the next few months. So just curious when this would be published.
So we are nearly done with the paper.
We'll talk about it on Friday.
Yes. Yes.
Any other questions?
Thank you for the talk. That was great. I'm just curious about how you went about recruiting the international countries for the study.
Oh, it's difficult. It took us 3 years to get to this stage. there's a lot of research governance involved. So you have to do ethics, material transfer agreements, site agreements, and we have a lot of bureaucracy with our Liverpool sponsor as well. So now we've got a defined pathway for this. So if you are interested, so we can speak.
It's challenging because the countries take a long time because of different processes. So we've been waiting a year for some countries even to give us ethics approval for a very low risk study where you just need a sample from one sample from a patient who's got toxicity.
And just also to follow up on that, did you have any criteria specifically for these countries, or were you just looking for any countries outside of the UK to recruit?
So yeah, so any countries outside of the UK, and we are focusing on individuals who've developed severe toxicity and based on the CTCAE grading. Yeah.
Great, thank you.
Thank you for the talk, and I'm going to follow that question about the recruitment. In Latin America, we have a black population in different countries in specific areas. So I'm from Colombia. I'm going to talk about Colombia.
Okay.
In Colombia, you have a big black population in the Pacific coast and the Caribbean coast. Have you had that into account when you are recruiting the research sites? Also in Brazil, you have specific parts where you can find different distribution in population. I'm asking that because you mentioned that black population have a specific gene.
The C557A.
Exactly.
Gene
so
yes.
to make that then to translate it to public health, to public policies, health policies. Sorry. When we are prescribing for these kind of drugs in those countries, have you taken that into account?
So first, we have no collaborators in Brazil, and we do have collaborators in Colombia. But if you are working in this area, then we would really love to collaborate. In terms of dosing recommendations and guidelines, it will have to be through international consortia such as CIPIC or the national consortia, within the country itself. So, for example, with the dosing guideline that we've developed for C557A to G, we work, with the UK SAC board to develop that dosing guideline for national use here in the UK. So, I think different countries will probably have, different approaches to this.
So it's been difficult to recruit from South America. We've got one site on the board in Chile and one site in Colombia, but we'll be very keen to do other countries as well. So if you have contacts and so on.
Yes. Yes. Yeah. Thank you.
Okay, thank you very much, Eunice. Thank you. Okay, again, thank you to all our speakers for the last session. Great session. And you can see the future is in good hands. So time for lunch now. Again, same place where you had your coffee and so on. So it's about an hour or so, and the team will let you know exactly when you need to come back. Thank you.
Okay, good afternoon, everyone. Welcome back from lunch. I'm Vicky Chaplin. If we haven't met, I'm the Senior Clinical Lead in the Genomics Unit at NHS England. I'm a pharmacist by profession, but as part of my remit, I oversee the pharmacy work, nursing and midwifery, and also the implementation of pharmacogenomics to our patients. So this session is right up my street, and I think we're going to have some really interesting conversations, hopefully. So, we've got 3 sessions. I'll just kick us off with the first one. We should have time for questions after each session. And the first session is going to be on the role of pharmacy professionals in pharmacogenomics from Jess Keane. So Jess is a Welcome Forward North Clinical Doctoral Fellow whose research focuses on the implementation of pharmacogenomic panel testing into systemic anti-cancer treatment pathways, and she also used to be the pharmacy lead in the Northwest GMS. Thank you, Jess.
So good afternoon, everybody, and it is my pleasure to try and steer you away from your postprandial slump and to give you an insight into the role of pharmacy professionals in pharmacogenomics. There we go. I'll give a bit of an overview about what pharmacy professionals do and who we are, and then talk about some of the roles in the delivery of pharmacogenomics in the UK globally, and then think about some opportunities for pharmacy professionals. And I wanted to start this, rather than thinking what do pharmacists do, is why does pharmacogenomics need pharmacy professionals for implementation? I think lots of people will have talked about the 10-year plan already, and I'm sure it's high in a lot of people's mind. And it released last summer really some quite ambitious plans for the rollout of pharmacogenomics within the NHS in England, and I guess more globally across the UK, including making pharmacogenomics something that's part of routine care and incorporating it within the single patient record. But for patients and for the health system at large to really feel the benefit of all this testing as and when it happens, it's really critical that the results of testing are being used to inform prescribing and shared decision making. And I think that that is potentially where pharmacists come in. We know that prescribing is the most common intervention within healthcare at huge cost to the NHS. We know that depending on how many genes you test, pretty much everybody's got a variant in one of these types of genes, and we know that the costs of adverse drug reactions are very high and that pharmacogenomics could help with this, and that it can also be used to support medicines optimization. So there is really quite a huge scope, if pharmacogenomic testing is to be rolled out widely, to prompt changes to prescribing at a really vast scale, and work done by Esther Youssef and colleagues a couple of years ago estimated that for drugs with pharmacogenetic guidance available from CPIC, around 2.5 million new prescriptions every year would require a change if we had information about their patient's genotype. So if we think about this really huge prevalence of prescribing and pharmacogenomic variation, this represents what I would describe anyway as a paradigm shift from the way genetic testing traditionally has been offered within clinical genetic services, where people are referred into these specialists, and shifting outwards into mainstream healthcare. And as such, there's a real need, therefore, for mainstream workforce within the NHS to be able to support implementation. I always like this quote from Henry Dunenberg and some other colleagues over in the US. And what they've said, which resonated a lot with me, is that pharmacogenomics are effectively clinically inconsequential if they're not considered in the context of drug therapy. And so pharmacists, as the experts in medicines and medical treatments, coordinating this new type of service is just logical. And I think that's something that speaks to a lot of us. I wanted to do a quick show of hands, if that's okay. How many people in the room are pharmacists, pharmacy technicians, training to be pharmacists? Okay, so quite a few, so that's always reassuring. This slide's not really for you, this next one. It's for everybody else. So just in case, it's what do pharmacists do? And these are not just my words, but also the words of the General Pharmaceutical Council, who are our regulatory body. We are responsible for the quality of medicines that are supplied to patients, making sure that it's legal, making sure that it's safe and suitable. We're part of the multidisciplinary team that will make sure that the right medicines are prescribed to people. We're also often got a key role in organisational or system level governance around medicines use. And then on a more kind of local or individual level, we provide medicines and healthcare services and advice to patients, explaining to them how to take their medicines, what they're for, what kind of things to look out for, and answer any questions they might have. And importantly, just this week, the current crop of pharmacy trainees will have taken their registration exam, and when they qualify as prescribers, when they pass the exam, they will all be prescribers from day one. So they'll emerge as pharmacists and prescribers from day one. But as you can see, a really strong focus on the safety and efficacy of medicines. And I wanted to highlight as well the role of pharmacy technicians, because you'll note that I called this talk Pharmacy Professionals. Pharmacy technicians here in the UK are also registered healthcare professionals. They're registered with the same regulatory body. They often have quite similar roles, but they'll be involved in preparing and accuracy checking medicines, supplying medicines to patients, and increasingly that can be under patient group directive as well as whether they're prescribed or over the counter. They do a lot of work on that individual level, providing information about health, lifestyle advice as well as medicines, and really helping people get the best outcome from their medicines, and then that liaison role within the pharmacy team, within the wider multidisciplinary team. And increasingly we're seeing pharmacy technicians having very senior roles at kind of regional but also in national roles as well. So these are the people that we're talking about. How many are there? As of the 30th of April this year, there were almost 100,000 registered pharmacy professionals in Great Britain. The registry body is for Great Britain and not Northern Ireland, so apologies if I say UK when I mean GB. But as you can see, a really big, healthy-sized workforce by comparison to some of the smaller groups of people that have been traditionally involved with genetic testing and pharmacogenetics. The majority of these will work in community pharmacies that we see in our supermarkets and on our high streets. There's also a significant proportion that are working in secondary care, in hospitals, mental health services, the judicial system. Increasing number, especially over the last 10, 15 years, working in primary care. So we get GP-based pharmacists, for example, but also working in primary care networks and integrated care boards. And then there's about 5-10% of people that are working in academia, research, pharma, and so on. But you can see that the vast majority of these large workforce are working within organisations that are providing routine frontline healthcare. And there are loads of different roles that we do, and this talk is kind of based partly on a MSc thesis that I did about 4 years ago, where I looked at all the roles that pharmacists have in pharmacogenomic implementation globally. And what's really nice to see is that when I did that review, a lot of the literature was very much based in the US, some other countries globally, but notably very, very little in the UK. And actually, as we go through this talk, you'll see that there are lots of examples now of where pharmacists and pharmacy technicians are having these roles in the UK. So I'm going to summarise these as fast as I possibly can to get through the talk and allow time for questions. But I think one of the key and most important things that pharmacy professionals will do is advocate for pharmacogenetic testing at multiple different levels. We see this initially and historically in advocating for individual patients who have quite complex medication needs, where we think pharmacogenetic testing might actually be able to support with some decisions around treatment. And a really impactful example that I heard a couple of years ago was in one of our mental health services in the Northwest, where there was a pharmacist who recognised that this patient who was having severe psychotic episodes that were involving restraint, a number of times the police had to get involved, was being resistant or not responding to a number of different medicines. And then they realised all of these medicines were metabolised through the CYP2D6 pathway. And so actually, they advocated for pharmacogenetic testing to try and look into that. And in the meantime, they were able to switch over to a medicine called levomepromazine, which isn't metabolized through that pathway. And actually, the patient got to therapeutic levels very, very quickly and was able to be discharged after prolonged episodes where they were really struggling. And having that pharmacogenetic result then enables people to make logical and rational decisions about onward management for this patient. And these are the kind of things that are happening on a very small scale all over the place every day. But really importantly, we're also advocating for cohorts of patients who might be eligible for treatment. And a nice example of that would have been in the Northwest, in Blackpool, we had a cystic fibrosis pharmacist who, when they saw that MTRNR1 testing before aminoglycoside use was commissioned nationally, was able to set up a pathway and make sure that all of the patients in their service who were eligible for testing were having a referral set up so that their testing was being able to be used, be stored on their record, and avoid aminoglycosides in those patients who harboured risk predisposing variants. So we see these kind of things happening on kind of sometimes relatively local levels or maybe small regional levels, but we also see pharmacists being involved at system level within their organisation or even nationally. We've had examples where it's been pharmacists, and I've been privileged to work with the British Oncology Pharmacy Association, who have collaborated with others to submit applications to the test directory to have pharmacogenetic testing either added or amended so that it's routinely available at a national scale. And some of that's been mentioned earlier. The next thing that you see, and this varies very much across different health systems, is that pharmacists are often involved in ordering pharmacogenomic tests for patients. So really practical thing, like actually getting it done, sent to the lab and back again to be used. This varies, I think, especially in the States, where pharmacists may not always be permitted to order tests. And here in the NHS, we have that you need to have specific specialties listed to be able to request certain types of tests. So we need to think about whether pharmacy is a requesting specialty. Sometimes we have examples, I think there's one in Florida, where it might be other clinicians who actually request the test, but it's the pharmacists who oversee whether that request is appropriate and actually send that then onto the lab. So they're acting as that intermediate, or they partner up with other professionals to make sure that those tests go through. And historically, for a long time now, we've seen HLA testing prior to abacavir, so that's required before a patient would start on abacavir for the HIV, and often it will be the pharmacist making sure that that test has happened and we have the result back before the medicine's dispensed, and if not, then making sure that it gets requested. And the example there is from something I'm sure many people will be familiar with now, where in Tayside they first started testing patients with CYP2C19 variants on their stroke ward, and again, that was the pharmacist that led on the test ordering. The biggest example in the literature, which everybody will be very familiar with, is that pharmacists are really key and have a very strong role in making the recommendations that are based on pharmacogenetic results. So now that we have a test result, what do we prescribe next? And when we think about those red and orange flags that we talk about, that's because pharmacogenetics might tell you what could work or won't work, but it won't necessarily tell you what else to prescribe instead, or what that dose should be, or take everything else into account. I think we talked about phenoconversion earlier, and there are all these other things that patients may be contraindicated to, and lots of things to take into account. And so that's where there's a really strong role for pharmacy professionals. This little, I don't know, pie chart, it's not a pie chart, is it? This diagram highlights a nice piece of work that was done by colleagues at the Mayo a couple of years ago. And it was only in a small number of patients, but they did a pharmacogenomic panel preemptively. And what they found was that I think 56% of people needed a change to at least one of the medicines they were prescribed based on the pharmacogenetic results. Everybody else who didn't was because they weren't taking any medicines with guidance. So basically, if you're on a drug with guidance, there'll be a change to be made. And in those examples, pharmacists will have a really strong role. And a key example of where we're seeing that now here in the UK is for cardiology pharmacists who are involved in mavacamten clinics. So mavacamten is a drug used for hypertrophic cardiomyopathy, and the CYP2C19 result comes back, but it needs to be used in conjunction with information about the patient's concomitant medicines before a dose decision is made. I think this is a really key role that pharmacists and also pharmacy technicians will have around counselling patients and explaining to them not just about their medicines, but actually what the role is for pharmacogenomic testing in their pathway. So that's thinking about before we test patients, explaining why we would do the testing, what the benefits it might be, but also the limitations. Just because you have a pharmacogenomic test does not mean you won't have a side effect. And that's a really important thing for people to understand when they're consenting. Post-test, we see that pharmacists and pharmacy technicians are involved with explaining individual results to the patient, what it means for the medicine now, what it might mean for other medicines in future. And we've seen that certainly in the PROGRESS study, where a lot of the practice pharmacists have been really key in explaining to patients what the results mean for them going forward. And I think it's really important to advocate for patients who have results when they're coming back in. We saw that about 10% of people, the results are being re-looked at to inform future prescriptions. But, you know, this is quite hard. I don't know if anybody's done many drug histories with people. They forget what they're allergic to, or they don't know what the reaction are. How many people do you think are going to remember that they've got a 1555 A to G variant? You know, they're just not going to remember. This is complicated for patients, and if the healthcare professionals are finding it difficult, the patients will too. So we need to have the knowledge to be able to advocate for these individuals that their results can be used throughout their lifetime. I won't talk too much about health informatics, just to say that we know that the use of clinical decision support and storing results in a way that can be utilised longitudinally throughout a patient's life, wherever they hit healthcare, is going to be really important. And a lot of these models for how the services are going to be delivered are still being determined, and we've heard some really good examples today. What we know is that pharmacy professionals are already key in having the oversight and the governance of these electronic prescribing systems within our healthcare settings, and they know how systems are used, and they know the workarounds that prescribers use to avoid those pop-ups and things like that. And so they can be really key in ensuring the information is stored and utilised in a way that can actually inform patient care. There are lots of examples globally, which I won't go into now, but the US talking about the role for clinical pharmacists within an MDT, championing the use of pharmacogenomics within health systems. And in the PROGRESS study, John showed up earlier a nice slide about the integration of the results and how we're developing pop-ups that are interoperable. What's really important from my point of view to note is that many of the healthcare professionals who are working in these digital companies, clinical decision support systems, and at the front end have got backgrounds in pharmacy because they understand how information is used to inform prescribing. So I think that's really, really key. And at a local level, pharmacy professionals need to be able to ensure that their local systems are able to use and take up this pharmacogenetic data to make it accessible so it can inform prescribing. Because pharmacists and pharmacy technicians know a lot about pharmacokinetics and pharmacodynamics, they have been talked about in the literature and within the community as being a key professional to interpret clinically these results for individual patient care. Because of that, and because this has been a mooted role for pharmacy for some time, we're then the biggest target for pharmacogenetic education. So a lot of the education that happens, there was a systematic review a couple of years ago, and more than half of the educational initiatives that there are, or at least that have been written about, are targeting pharmacists, undergraduate pharmacists, and pharmacy technicians. But they're not just recipients of education. Lots of different pharmacists have been involved in collaborations to develop pharmacogenomic educational resources. And I want to highlight collaboration. I'm not trying to claim that pharmacists have single-handedly created all of the resources that are on this screen and the many others that you'll be aware of. But we know organisations like the Centre for Pharmacy Postgraduate Education have developed courses. CERSI PGX has had pharmacy involvement in the development of their pharmacogenomics module. So we're key in helping with these types of things, and often we'll be then leading on educational programs to empower the wider MDT. So we're not just talking about what can pharmacists and pharmacy technicians do, but how can we also support the wider multidisciplinary team to take what they really need to be able to do their job and learn, the kind of basic minimum about pharmacogenomics and then know where to refer to. And we've seen loads of examples of this. Wherever we see implementation, we see pharmacists leading on education. And then at system level, pharmacists in the US, this is on the right-hand side, it's not the best screen grab, but it's from the AACGP competency framework for pharmacists. What do pharmacists need to know about genomics to be able to do? Here in the UK CPA have developed a genomics knowledge guide for pharmacists and an advanced guide for more specialist pharmacists in genomics. And then locally, we've worked with the Royal College of Pharmacy, recently established Royal College of Pharmacy, to develop a resource to support all prescribers. So we're trying to drive these establishing competency standards and understanding what people need to know to be able to be competent within their roles. And again, I just want to highlight that we are frontline professionals who are providing education to patients, and we can't forget that. I think pharmacists have got a really key role. They're already a well-trusted and one of the most accessible healthcare professions within the UK because of the setting. You often don't need an appointment to see one, for example. So that public health role is really key, and it will be, I think, an evolving area as we look at how pharmacists are mobilised, if you like, to deliver education to patients. We know that globally and in the UK, pharmacists are leading implementation, again, collaborating, but acting as lead roles within these in implementation, but also in system level research. If we think about the DYPD transformation project that happened within the Genomic Medicine Service here, there were many pharmacy professionals involved in leading that programme. The PREPARE study in the Netherlands, again, had key roles uptaken by pharmacists. And so we're seeing this all of the time, that pharmacy is a role that is important in these implementation programs. And then we've got these national networks like CPIC, like the DPWG, that are producing guidelines, again, not exclusively pharmacists, but really having a key role. And we're understanding more and more about how pharmacogenomics needs to be embedded within medicine's governance. And I'll just give a small example of that, which is in the NHS England backed stroke pilot around CYP2C19 testing. What we saw that as well as the implementation locally in the trusts, we had integrated care board pharmacists liaising with the wider system to ensure that alternative medicines were available within formularies, so that prescribing didn't have to keep happening in secondary care, but actually if alternatives were being suggested and prescribed in secondary care, that ongoing prescribing could happen within primary care. So it's just a small example of where we're seeing governance happening. I wanted to thank NHS England, who I pinched these slides from, just to highlight the pharmacy leadership role that we have in NHS in England. You can see that in the middle, they're the JMS Alliance pharmacists, of which I was one, and many of my former colleagues are in the room. They work as a network, and they kind of liaise between, at national level, the Genomics Pharmacy Advisory Group, and then their regional organisations to ensure that there is integration of pharmacogenomics within these medicines optimisation networks that exist locally. They're all on this slide. If you want to speak to one, I'm sure they're happy to be contacted. All the contact details are on there as well. And they're a truly excellent bunch. And I hope that many of you are thinking more about roles that you could involve pharmacists with in the implementation and research projects that you have planned. And finally, I'm saying this is not quite an exhaustive list, but it's as far as I'm going to go today. Globally, pharmacy professionals have been really important in collaborating with others to develop guidelines around the use of pharmacogenomic testing. Who should we test? When should we test them? When we got enough evidence to indicate that we should use results to actually change prescribing. And I think what's really important is that we're not just thinking about the scientific evidence for this, but really practical things like, can that dose reduction actually be given? Is there a tablet that size if we want to do a dose reduction? So we can blend the evidence with what's possible in the real world. And these things happen at national level. We have national pharmacogenomic dosing guidelines available for different drug gene pairs in hematology, oncology, so many others examples, some of which are on the slide there, but also just making local decisions around alternative antiplatelets at a particular trust when people have got a CYP2C19 loss of function allele. So those are some small examples of guideline development. I'd like to finish this talk by saying, is it still relevant to everybody else that works in healthcare? Yes. It's not all for pharmacy to do. So if you're a healthcare professional who's involved in prescribing, supply, administration of medicines, you will need to know something about pharmacogenomics, and there are all these big national papers that explain why this is strategically important for these roles. So what are the opportunities? Well, I think we know the opportunities for pharmacogenomics that help improve the safety and efficacy of medicines, which, if you remember from the start, is key to the role of pharmacists. But it's a really good opportunity for pharmacists to step up as leaders within the healthcare space, help with things like clinical decision support and when to test. We've got a really key role in medicines governance, and we need to make sure that pharmacogenomics is linked in very closely with that. Some pharmacists will lead on research. I am now one of them. And we'll be thinking not only about which variants to test or specific drug-gene interactions, but evaluating the implications of testing on practice and making sure that it's really making a difference to patient outcomes. I mentioned before, there's a key role for public health and improving genomic and pharmacogenomic literacy with the general public. And I think really importantly, building on and maintaining the networks that are already established so that we keep this as a collaborative effort. So I've covered everything, and I'm 21 seconds ahead. So with that, I will say thank you very much and take questions.
Ooh, okay, we have a question already, so if we go there first.
I have two questions. One, in your pre and post test counseling, do you guys talk about familial implications? So patient has a DYPD variant. Do you tell the patient that their parent might have, probably one of their parents has this variant, or one of their children might have the variant? And then my second question, which kind of is related to that, at what point would you maybe call in a genetic counselor?
Okay, so I can take that in two parts. The DYPD testing pathway as a rule, is very much linked in with the prescribing of fluoropyrimidines. And to my knowledge, no, most patients who have a variant identified are not then onward being informed about the familial implications for that. I can think of maybe 1 or 2 examples where we have done familial testing because of symptoms that indicated that this was going to be important to that family, but they would have been eligible for rare disease testing in that scenario. But no, for the vast majority of patients who are going through that oncology pathway, no, that's not something that we inform. In terms of panel testing that we've seen within the PROGRESS study, I think we've never mandated to the clinicians there what they tell people, but we know that some patients will naturally ask about familial implications. And at that point, we would normally say that testing would not be required unless the patient, the family member themselves also requires that testing for that clinical pathway. So that kind of tends to be the answer. I'm really sorry, I've forgotten the second question.
Genetic counselors.
Genetic counselors, we probably have, I think, limited, because we have relatively limited actual clinical implementation at the minute. So I think when there have been those small numbers of examples, like the patient that I mentioned where they did the heritability for DYPD, that would have been referred in through clinical genetics and then onward to a genetic counsellor if that was appropriate. I think there are some pathways, because the setup for clinical genetic services is different around the country. For example, with the babies or young children who are identified as having MTRNR1 variants, then in some scenarios, they would be referred to clinical genetics and probably have a counselling discussion there. But there's also moves to try and set up services so that actually the frontline staff and potentially pharmacists can actually have those conversations with people and then only subsequently then refer on in more complex cases.
Thank you, Jess. Any more questions? Oh, yeah.
Sorry. Hi, Jess. Thanks for the presentation. My question is in 2 parts, and it's regarding the roles of pharmacists and pharmacy technicians. So given that the new pharmacists that are qualifying this year are going to be prescribers, how do you envision their role would be in pharmacogenomics? And then how would you describe the role differences across sectors, so between hospital, community, GP practice, and whatever else, and the difference in the roles and responsibilities of pharmacy professionals in pharmacogenomics?
Okay. I mean, as far as the fact that the pharmacists are going to be prescribers, my understanding is that that's an additional role, but it doesn't take away from their role as pharmacists as we know them, or their clinical pharmacy role. So I'd expect that, if anything, what it will do is just focus a little bit more on their role as prescribers, which we know pharmacogenomics is really key to. But they'll still have that really strong role within the multidisciplinary team. So I don't envisage a huge change there. Happy to be corrected, and we'll see how that pans out. I think as far as the roles for pharmacy professionals across the different sectors and settings, that's probably largely down to the implementation that happens within the pathways that they work in. So for example, if we were to see a big role, I mean, so far it's mostly been in secondary care where we've seen implementation, and so roles for people in community pharmacy and primary care have been relatively fewer, but I think that's based primarily on the drugs and the indications for testing. But if we were to see kind of national rollout, then I think we'd see the roles change in line with that. I mean, I think the principles that I've talked through about advocating, requesting tests, education will stay the same. It's just where they happen will be related to where services are. We know that clinicians in general, and pharmacy included in that, will only be working, most of them, on what's presented in front of them because the services are so busy. So I think that's where we'll see those roles expanding more in the areas where we're hitting services.
Great. Perfect. Okay. Thank you very much, Jess. So we're going to take a slightly different perspective now, same theme, and we're going to hear about the role of nurses in pharmacogenomics. So really pleased to introduce Dr. Anita Hansen, who's an NIHR senior research leader. I think you've been working in this area for over 20 years and is the senior nursing Research Fellow at the University of Liverpool.
Good afternoon, and thank you for the introduction and the invitation to speak about the role of the nurse in pharmacogenomics. So I'm Anita, I'm a Senior Nursing Research Fellow. I'm based in the University Hospitals of Liverpool, and I also am based at the University of Liverpool as well, at the Wolfson Centre for Personalised Medicine. And so today, a little bit different really, going to talk about some of the work that I've been involved in as a nurse working in pharmacogenomics and working alongside patients or those with lived experience who've actually experienced a serious reaction to a medicine, and some of the work that I've been doing with the population. And so I thought to begin it would be helpful just to give you a little bit of an idea of what the nursing workforce looks like in the UK and why the role of pharmacogenomics is important for the nurse. And so I had a little look at the Nursing and Midwifery Council register, and a report was published just last year in September, and that was able to show that currently we have approximately 860,000, a little bit more, health registered professionals on that database. And now this is broken down into nurses, midwives, and those who are duly qualified as nurses and midwives, and also nursing associates. Now, nursing associates sit somewhere between healthcare professionals and qualified nurses. But for the point of today, I'm just going to look at the nursing population. And as you can see here, we've got over 793 nurses on the actual register with the Nursing and Midwifery Council. But when I looked into this a little bit deeper, this is kind of an overestimation and a more realistic estimation of the number of qualified nurses that are working across the UK in the hospitals and community services and general practice is more likely to be in the region of 467,000. So a huge population. So the nursing population is split up into branches, really. So we have adult nurses, children's, mental health, and learning disabilities. So just a little example of what the nursing workforce looks like. And so why is the role of the nurse in pharmacogenomics important? Well, it really is because the nursing workforce is the largest patient-facing professional group within the healthcare system, and they are central to delivering patient care. Now, nurses have extensive interaction with patients, and with that in mind, they're responsible for the likes of gathering information on past medical history, long-term conditions, and all the medications that patients are taking to treat those conditions. They're also responsible for the administration and monitoring of medications, and quite often the nurse will be the first person that the patient will come to say, actually, I don't know whether this medicine's working, or I think I might be having a reaction to this medicine. So they're quite central to that, gathering that information. As Jess was saying, nurses they have a really large population of prescribers within our workforce. I think there's approximately 68,000 on the register at the moment. And nurses are also central to the coordination of care, often referring patients to the likes of doctors and pharmacists and other members of the multidisciplinary team, but also they're heavily involved in the research as well, in referring on to research teams as well, so patients can take part in research. But importantly, nurses are educators, and quite often they provide health education on a daily basis to patients, but they also provide advice and guidance on how to manage long-term conditions, and also give advice on the medications that they're prescribed for those long-term conditions. And so, just really to summarise that, nurses have an abundance of skills and knowledge, and they're in a really strong position to build a trusting relationship with patients. And with that in mind, if they were equipped with the relevant knowledge and skills, they would be perfectly placed to be able to educate patients on the importance of pharmacogenomics, but also act as an advocate for genetic testing when needed. And I just wanted to note as well that the role of the nurse, it actually spans across clinical, education, research and leadership. So again, perfectly placed to be able to support the implementation of pharmacogenomics into clinical practice if they are equipped with the necessary skills. But for the point of today, I'm going to talk about some of the work that I've been involved in as a nurse, working in pharmacogenomics for many years. And so just to give you a little bit of background, I've been working at the Wolfson Centre for Personalised Medicine for many years. And Professor Munir Pirmohamed is the director of the centre. And we work closely with a large team, a large multidisciplinary team. And nurses are quite central to that to make sure that we can deliver the research portfolio within the centre. Now, over many years, we've undertook research and recruited thousands and thousands of patients into different research studies. And we've explored a variety of reactions, for example, toxicities associated with immunotherapy. We've looked at drug-induced liver injury, and we work with mental health, and we look at clozapine-induced agranulocytosis, for example. But one area, we've actually looked at lots of different types of reactions to medicines, to different types of medicines. But one area of particular importance, and one that I'm quite passionate about, that I've worked with for a long time, is serious cutaneous adverse reactions such as Stevens-Johnson syndrome. And so I'm sure the majority of you in the audience will have heard of this condition, but just for those of you who haven't, just a very quick background, we know that Stevens-Johnson syndrome, or SJS, is a potentially life-threatening reaction that can be caused by a viral infection, but it's more commonly caused by a medication. It can be caused by any medication, including those purchased over the counter or herbal meds, but the more commonly implicated drug groups, as we know, are all the A's: antibiotics, anti-inflammatories, anticonvulsants, and allopurinol. And we know that when patients come present with SJS, their symptoms are often non-specific in nature, but then their symptoms can progress to a blistering rash that predominantly affects the skin, but can also affect the mucous membranes. And this can very quickly lead to a condition called toxic epidermal necrolysis, or TEN. And so we know that this is a devastating reaction for a patient to experience. We know that any organ system in the body can be affected, and patients sadly can lose their sight, they can lose their nail beds, it can affect the respiratory system, the gynecological system, and affect fertility. So as I say, affect any organ system in the body, and patients are often treated in an intensive care unit, and again, depending on the severity, moved to a regional burn centre. So as you can imagine, they've been prescribed a medicine to treat a condition, and then they end up with all of this. They're often left with long-term health problems as well. So quite often they experience psychological distress, which can lead to post-traumatic stress disorder. And so it is a really, really horrible thing for a patient to experience. And so what are we doing to address this? So there's lots of clinical and scientific research that's going on from a global perspective, and I'm not going to talk through this slide in the interest of time, but we know through global research that we've been able to implement really valuable screening programs for the likes of carbamazepine, abacavir, and Eunice talked a lot just before lunch about the DYPD screening program. So these are wonderful programs that are implemented to support patients who experience the likes of SJS or other serious reactions. And so this is fantastic to see. And to complement this, these programs, we also have obviously the CPIC guidelines and others, but what we have is the Centre of Excellence in Regulatory Science and Innovation in Pharmacogenomics, which we know the team, many of the team are here today, and recently there's been some guidelines published which will also support the implementation of pharmacogenomics into clinical practice to benefit our patients. But none of this would be successful without collaboration. And within the Wolfson Centre, we pride ourselves on collaborating not just on a local and national level, but internationally. And as Eunice highlighted with the DYPD study, we are collaborating on an international level so that we can kind of identify further variants of interest related to the DYPD gene to make the screening program more inclusive for other ethnic groups aside from the Caucasian population, for example. So yes, we collaborate on an international scale. But one of the most important collaborations is the one that we have with our patients. And so, as a nurse, I was extremely curious to find out what was important to our patients and what they felt about the pharmacogenomic research that we do within our centre. And so, approximately 14 years ago, I set up a drug safety, patient and public involvement group with the centre, and I wanted to find out from the patients what they thought about our research. Did they think it was relevant? Was it actually addressing the needs of the population? And I thought if we could communicate with those with lived experience, it would really help shape our research strategy going forward. And so what I found from the patients was they were actually very, very grateful for all the wonderful work that we do to help us better understand, predict and prevent reactions occurring for our patients. But they noticed that there was 3 things that we weren't addressing, and they were the lack of awareness of conditions like Stevens-Johnson syndrome or TEN amongst health and care professionals. They wanted to talk about the lack of education and training amongst healthcare professionals, but also the lack of coordination of care post-diagnosis and beyond. What they suggested was they were often seeing many healthcare professionals across a range of specialities, different hospital trusts across the region to see specialists, and there was no joined-up way of combining all of their clinical information. So quite often it was difficult to have a conversation with professionals about their history, and they'd forget sometimes about what they'd experienced and didn't feel like they could relay all of that important information during a 10-minute consultation. And so we started to work straight away on how we could address some of their concerns from a research perspective. And so we worked together to create a poster to raise awareness of the condition, and this was disseminated through the then clinical research networks that I liaised with across the country. We also visited the House of Commons with our patient group, and they had a voice there to talk about the importance of education and training for healthcare professionals, but also about the importance of research in pharmacogenomics so that we could make sure this was embedded into clinical practice. But one of the most important suggestions from our patients was the fact that about their coordination of care, and they suggested having what they called an SJS passport, my SJS passport. And so we started to work together to co-produce this booklet, and this booklet is an A5 paper booklet which allows the patient to coordinate and summarize all of the most important information about their diagnosis, about the reactions they've had to certain medicines, and what long-term conditions they're experiencing post-diagnosis, so that they could have that at hand when they attend their appointments with their clinicians. And so this went through an iterative process, and we finally arrived at version 1, and we were absolutely delighted that we had this tool in place. But I realised that this wouldn't be acceptable within the NHS if we didn't have evidence of its benefit. And so I spoke to Prof about this and my other supervisors. I was undertaking a PhD at that time to explore strategies to improve how we identify and report adverse drug reactions. And so we decided and we agreed that this would be a great project to assess as part of my PhD. And so I undertook a proof of concept study to explore the benefits of the passport and to understand its acceptability and usability. And the results from this project were really quite striking. And so what the patients found was the passport was a really valuable communications tool. And this was particularly so when they were admitted as an emergency admitted to an emergency department, and they could hand over the passport which explained what the condition is, and also it would highlight the drugs that should not be re-prescribed to prevent them having another reaction. They also thought the passport validated diagnosis, and that was not just amongst health professionals but also with family members and friends and within the workplace. The participants suggested that quite often, once they're through the acute phase of their condition, their family members thought that they were on the mend, and clearly that's not the case because they're dealing with lots of long-term health problems that they have to manage for the rest of their lives. And so the passport really did address this misconception. And just quickly, there were some young adults who were transitioning from child to adult services, and they thought the passport was very valuable, especially as the end of the study was during COVID, and so they were attending appointments on their own without their parents for the very first time, and this booklet really did facilitate the conversation about their condition. So there were some limitations, and the participants felt it could be improved slightly, and there were some refinements with regards to the personalisation of the passport and also the section prioritisation. They also suggested it would be wonderful to have this booklet in an electronic form so they could print it or maybe have it as an app. And so we got to work in addressing the findings, and we refined the passport, and it's now at version 2, which is being used on a global scale. We've also now, Eunice and another colleague, Eunice, who presented earlier, and another colleague, Alex, have now designed an app which reflects the passport. And so recently, a colleague and I, Dr. Dan Carr, we applied for some funding, and we got funding to be able to evaluate the app for its user-friendliness, to assess its functionality, and to make sure it was actually usable for the patients. And so this is what the app looks like, the interface of the app. And when we evaluated this, alongside our patient group, and we brought the patients, all the patients with lived experience of SJS from across the country into Liverpool, and we allowed them to use the app on their own device, or we provided a device for them. They absolutely loved this mobile health app. They thought it was great because they could upload their photographs, their discharge summaries, and they could have their evidence available during appointments at the touch of a button. But they also thought it was very simple. They loved the simplicity of it, they loved the functionality, but they loved the fact that there was a QR code which could be saved as a wallpaper on your phone, that in an emergency setting, they could just scan that emergency code and it came up that I've got SJS and you should not give me carbamazepine, for example. So they loved the fact that this had this function. And so this was our patient group. They came into Liverpool and they worked tirelessly with us to evaluate the app. And so now we're in the process of refining the app according to the findings from the evaluation. So again, we had the passport, we evaluated it for its benefit. Brilliant. We designed the app, we adapted the app, we're adapting the app. And then we reach the top of another mountain and we think, what are we going to do to disseminate this information? Because it's important to have this information, but we have to make sure that it's accessible to patients within clinical practice. So we thought about a dissemination plan and we worked closely with our patients to allow this to happen. And so Jane Burns, who's in the top corner here, James was one of our patients who experienced SJS, which progressed to TEN approximately 38 years ago. And she was seen by Munir and other professionals in the Royal Liverpool Hospital at the time. And thankfully, she survived. And she now came back to work with us 14 years ago because she wanted to give something back to research. So Jane has now been involved with the Royal College of Physicians and the British Pharmacological Society, and she's been involved in a publication back in 2002 to have a patient voice about the importance of embedding pharmacogenomics into clinical practice. And so that's wonderful. So Jane and I have recently, well, a couple of years ago, we were working closely with the Academy of Medical Sciences in London, and we've worked to co-produce an educational video. And this educational video, and the link here is to the YouTube channel, is Jane's story. And she talks about her experience, she talks about working with the research teams, the importance of pharmacogenomics and the importance of the passport to support patients who've experienced the similar condition as her. And so Jane and I now work for the last 10 years. We've been going into higher education institutes regionally to try and raise awareness of pharmacogenomics to undergraduate nurses, postgraduate nurses, and also non-medical prescribers so that they understand the importance of pharmacogenomics right at the start of their journey. And so this is brilliant because I think when you have a patient who's had that experience with you and you're explaining the situation to healthcare professionals, that it really does sink in, and it's a really great take-home message. So I also contacted the British Association of Dermatologists and asked, could we cite the passport in the national guideline, national SJS guideline? And they thought it was a wonderful idea, and they said, once this is published, we will definitely cite this in the guideline. And so consequently, we went away, we published the co-production of the passport with some of our patients as co-authors on this, and now this national guideline is being revised and the passport is being cited. And so healthcare professionals will have access to this at the point of diagnosis to give to patients. More importantly, we've been working with the MHRA, the Medicines and Healthcare Products Regulatory Agency, and they've been using the passport now as part of their Yellow Card Biobank, and they've been giving it out to patients who are joining the biobank when they're exploring allopurinol-induced SJS. But really, most importantly, just a shout out to SJS Awareness UK. This is a charity in London founded by a lady who experienced SJS, Nadia Lawson, and she's been working with us for the last 14 years, and she's been instrumental in making sure patients are at the centre of everything that we do within the Wolfson Centre for Personalised Medicine. So a big thank you to Nadia. But more recently, we've started to collaborate on an international scale, and now we're linking in with SJS Canada. And this is brilliant because we are sharing resources. We are invited to join their monthly meetings where they invite speakers about the topic, so really spreading the word about pharmacogenomics globally. I've also invited people from SJS Canada to come and speak here in Liverpool. And more recently, I was invited to speak at the Serious Cutaneous Adverse Reaction Conference in Nashville. And I had the opportunity of meeting patient groups from Canada, from all different parts of America. And now we are going to collaborate on a global scale to create a serious cutaneous adverse reaction passport that's available to all patients who have different types of skin reactions. So that's a brilliant kind of example of the international collaboration. And I just have a couple of more slides now. I just give you a moment to read this quote. This is a quote from Sonia White-Crossdale, the founder and president of SJS Canada, and this really just highlights the importance of collaboration, global collaboration, but more importantly with our patients, to make sure that when we are implementing pharmacogenomics, it really does include what's important to our patients. And so, really just wanted to finish by saying, I've been really fortunate. I've been blessed, really, to work in the area of pharmacogenomics for over 20 years, but not every nurse in the workforce will get that opportunity. So how do we see the future roles of nurses in pharmacogenomics? Well, we know there are pockets of excellent practice where there are certain nurses who are embedding pharmacogenomics into clinical practice every day, and an example of that is in oncology. And I recently spoke to a nurse called Peter who's worked in both clinical and research roles within Clatterbridge Centre in Liverpool. And Peter said, as a nurse responsible for administering chemotherapy and recording and reporting associated toxicities, my role involved educating patients on the benefit of the DYPD genetic test and explaining the results. So clearly, nurses are involved in pharmacogenomics in certain areas, in specialised areas of practice. He actually said it's just routine practice for us now to genetically test. And he did say it was great to see the impact of pharmacogenomics and the significant reduction in 5FU-induced toxicities following the implementation of the screening programme. And this is wonderful. They are aware of the DYPD screening programme. We're following a recent discussion with Maria, who works on CERSI. She was informing me that there is going to be a new published guideline soon for the irinotecan medication, which is often co-prescribed alongside 5FU. And so it's ensuring that our nursing population, amongst others, are continuously updated with news and developments in pharmacogenomics so that they know that at that time there should be 2 genetic tests to inform the prescribing of both of those medications at the same time. So when considering the wider nursing workforce, when looking at the future roles of nurses within pharmacogenomics, I believe that there is great potential for roles for nurses. So we know, as I mentioned earlier, nurses have extensive interaction with patients. So we know that they're perfectly placed to educate patients. If they're adequately equipped with the necessary skills and knowledge, they're perfectly placed to educate patients on the importance of pharmacogenomic testing and actually explain the results or reiterate the explanation of the results after they've been seen by a doctor or a pharmacist, perhaps. I think an important role for nurses would be the checking of pharmacogenomic test results before they administer medications in order to prevent errors and make sure there's good quality medication prescribing and the good quality prescribing of medications. But I think there's a great opportunity for a nurse consultant or a specialist nurse in pharmacogenomics who could actually order the genetic tests and then support the wider nursing workforce within their organisation or perhaps regionally, and they then could provide or create and provide educational and training programmes for the nursing workforce to make sure they're upskilled. Patient and public involvement, as I mentioned, is key. But not just patient and public involvement. I think nurses, the perceptions of nurses is really important to make sure that we go about implementing pharmacogenomics in the best way within the NHS so that it's acceptable to them. And I think there's also an important role for research with nurses in pharmacogenomics, because quite often some patients we'll see patients with rare diseases, and it's difficult to recruit these patients. So nurses could definitely have a role in the recruitment of patients to pharmacogenomic research. And I'd just like to finish really by saying, what next? How do we see us building the capacity and capability of the nursing workforce to allow them to embed pharmacogenomics into clinical practice with confidence and competence? Well, we know there's a number of initiatives in place, and we know that in 2018, the Nursing and Midwifery Council included understanding genomics in the standards for proficiency for nursing for registered nurses. But the onus was on the nurse to make sure that they were proficient. So that was kind of, you know, we can have a think about that. We know that there's lots of learning materials and educational tools out there, but often nurses don't know where to start to look for them. And in response to this, we know that genomics, through the genomics education program, then a genomics learning passport for nurses was created, and this was published just last year. And we know that this provides a user-friendly guide to nurses towards the available education and training resources to equip them with the skills to implement research, implement pharmacogenomics. More recently, we have the Nursing and Midwifery Genomics Framework in England, and we know this sets out clear and ambitious plans to prepare the nursing workforce for embedding pharmacogenomics into practice. And from a personal perspective, I've recently been awarded two roles. One, a senior research leader role, which allows me the platform to be able to go out there and equip the nursing workforce and enhance capacity and capability of the nurses to embrace pharmacogenomics within their practice. But more importantly, I was given some funding to develop as a postdoctoral researcher, and with that award, that's going to allow me to explore the perceptions of nurses related to pharmacogenomics. So that's kind of what I'm going to be involved in over the next year or so. And so really, I just wanted to say thank you to many people, but really just to thank all the patients and the public that have been involved in our PPI group, and all of those who took part in the research over the years to develop the passport and the app. So, thank you.
Thank you, Anita. Really fantastic work to hear about. I think we've got a question over here.
Thank you for a really good talk. I am a mental health pharmacist looking at implementing the carbamazepine CERSI guideline, and I just wondered if you could expand at all on the availability of HLA testing, when it might start to align with national...
availability, did you say?
Yeah, the availability of HLA testing.
So I think either Maria or Munir might be able to answer that question more effectively than me. So...
would you like me to answer the question?
Yes, please, because I'm unsure about the availability within mental health, so I'll kind of pass that over if that's okay.
So HLA testing for carbamazepine isn't on the National Genomic Test Directory at the moment, as in so nationally commissioned through the Genomic Medicine Service. It is available through some routes, so it's available through blood and transplant, so in an appendix in their commissioning. It can be requested on a kind of case-by-case basis in terms of when we need that, and they can provide that testing. So it is available, but it's not kind of routinely commissioned and set into pathways yet before every prescription.
Yeah.
Thank you.
That's just related to the Han Chinese population, really, where it's mandated as part of a screening programme. So,
yeah, but obviously we know the CERSI guideline looks much broader than that, but obviously, it's all kind of, hopefully, as pharmacogenomic delivery develops, we'll be able to incorporate these tests.
Thank you, Vicky.
Okay.
Thank you very much.
Okay, thank you very much, Anita.
Thank you.
Okay, and so I think we heard some really great stuff in that last talk as well about working with our patients and the public, and it leads us very nicely actually into the next and final talk of this session. So very pleased to introduce Vivian Parry, who is a writer and a broadcaster, but has actually been working in the field of genomics for many, many years. And so she's going to give us some insights on the importance of pharmacogenomics for patients and public.
Thank you so much. How lovely to see you all. So this was the title that I was asked to talk about, the importance of pharmacogenomics for patients and the public, exploring perceptions and understanding of personalised medicine. However, what I really want to talk about is the importance of patients and public to pharmacogenomics. And I think patients and publics are an undervalued resource in pharmacogenomics implementation. Now, I should say before I start any of this that I am a woman unleashed. I am a woman unleashed, which is worrying quite a few people who know me. I'm a woman unleashed partly because I no longer have any affiliations, although I worked for Genomics England for over a decade as head of public engagement. I also have reached a big birthday. Now, I'm not decided, like Wendy Cope said, to wear purple and spit. I am not at the stage where I have emerita after my name, which for a woman means you are going mad, and if it's emeritus means you've already gone mad. But I just feel that I can speak my mind. Okay, so let me talk to you first of all about what the public actually know already about medicines. Now, Emma McGovern and her team at QMUL with Genomics England undertook this UK nationally representative survey of public attitudes about pharmacogenomics. And it was a big, big number, 2,700, and it had an extraordinarily large response rate. 58% response rate is amazing. 89%, so 9 out of 10 people understood when they were asked that there was a variability in medicine response. 59% claimed to have experienced no benefit from medicines. I take that slightly with a pinch of salt when I think of my mother, whose attitude to medicine taking was opening her bedside drawer and saying, I think I'll have a blue one this morning. 45% had had side effects from medicines. But actually, half of the people who responded did not understand that this had anything to do with genetics. So take from that it's widely understood by the public that medicines don't work for everybody. So, as to pharmacogenomics, they get it. This is something, I've spent a lifetime talking about genomics and genetics and science to the public. Pharmacogenomics is one of those things the public just get straight away. So when pharmacogenomics are explained, people are really fascinated. And their attitude is, who doesn't want safer, more effective medicines? And the next thing they always say is, why aren't you doing it already? And they also say that consistently that if I knew that a medicine worked for me, it would make me take my medicine more effectively, unless you're my mother. So, but there are concerns and challenges. Pharmaco-what is the first response. People have no idea what the word means. And I think that that's shared amongst professionals as well as amongst the public. Whenever you're talking about anything that involves genomics, people always then question about privacy. Because a bit like if you're asked in the street by somebody, about, whether banks are safe, the first thing you'll say is, are they secure? But actually with genomics and genetics, almost always, the real question that people want to know, their security and privacy is the thing that they say automatically, but the thing that they really, really are anxious about is for what purpose? So purpose is incredibly important. Fairness comes up a lot with people. They want it to be available to everybody. And the who benefits is, again, a major issue that comes up all the time. And can I say to you all that Palantir is not helping at the moment? People do have concerns, and they have concerns about digital sovereignty. They have concerns about people running off with their data, the benefit not coming back to the NHS being ripped off. You all know this. So let's dig down into some of that data from that big survey. So after pharmacogenomics had been explained to them, 89% said that they would complete a pharmacogenomics test. 85%, as I indicated before, think the NHS should be already offering pharmacogenomic testing to those who are already taking medicines. I want you to really concentrate on this last bit. 91% want direct access to this information.
91%. Now, ideally, they'd like it on, as we just heard, they'd like it on their phone. It's not that they don't want the pharmacist to have it. It's not that they don't want the GP to have it. They do want the GP to have it. They want everybody to have it, but they want to have it. And it's really, really important to them. And there is a bit of an attitude that actually patients can't understand this stuff. They shouldn't have access to it. They don't really get it. Can I just mention pensions? How many of you understand your pensions? You don't. Don't claim you do. You absolutely don't. If you really needed to know about pensions, could you go and look it up? Put a wet towel around your head and think, I can get through this eventually with 3 cups of coffee and a gin? Yes, you could. So actually, patients are you. Patients are the public. Of course they can have this stuff. So there's very strong support for pharmacogenomics, and this is not to say that these 3 individuals have very strong support, particularly for pharmacogenomics, but I just before make the point about Rishi Sunak, that people with chronic illness are even more in support of, or people who are taking multiple meds. So I wanted to just have a caveat. So although the NatSen survey was representative of the population, when Emma McGovern did another study, because we asked them particularly whether they thought that PGX data, so genomic data, was any different to normal data, like a kind of, like a X-ray or something like that. And whether it should be regulated in any different way or have any special concerns attached to it. And actually in the NatSen survey, overwhelmingly, they did not. However, when Emma McGovern did a smaller study involving South Asians, actually 9 out of 10 of them wanted stronger data protection for pharmacogenomic data than for, say, scan data. And again, fewer respondents amongst British South Asian communities supported PGX testing, and they were much more concerned about misuse of data. Now comes to Rishi Sunak. Here are 3 incredibly prominent Asians. We are them, they are us. There is no difference. But there is a move that I see coming from the States where EDI stuff becomes disregarded. We're already seeing in the UK, I think, a lot of standing down of engagement professionals right across many, many different fields. But these differences really, really matter, and we must continue to have a look at them without being concerned that somehow we're doing the wrong thing. We should be looking at the differences amongst all our populations of their attitudes, because this really counts. So there's really low awareness. I mean, you will know this. Lots of people have never heard of pharmacogenomics, and they don't really understand the impact of genetics on drug response. But that you will equally find in professionals. I've talked often to people in lifts or on stations. Don't ever stand next to me at a station. I will always engage you. I will probably ask you about pharmacogenomics. You may miss your train because I've been talking to you about pharmacogenomics. So there's a real need for education. But here's the thing about education, is lots of you think that education is about you telling people what you know about pharmacogenomics. My friends, they do not need to know it in the way that you know it. There is a way of talking to people which does not involve lots of long words, and you do not have to explain pharmacogenomics with every last cough and spit of SNPs and variants. But you have to be simple. They don't need to know everything you know. And again, I go back to your boiler this time. If your boiler breaks down, you can go and read the manual online. You do not need to know right now how your boiler works. You just need to know where to go and look. Okay? So here's a big warning for you all. Pharmacogenomics is great, it's super helpful, but people still need to read the label. And I think there's a real danger that you're telling people pharmacogenomics is brilliant, and they forget that there are other things that make medicines tricky. I remember not 500 yards from this building being stung by a bee on the day I got my results of my finals through. I had a huge reaction to the bee sting, had to take a massive dose of antihistamines, and I then had at least 10 margaritas on top of it. I was sick as a dog. It had nothing to do with my pharmacogenomic profile and everything to do with margaritas and antihistamines. So I'm making the point to you all that just be careful that you don't overemphasize the pharmacogenomics and let people forget that they really still do need to read the label and take the stuff with food, not mix it, all that sort of stuff. So there's lots of stuff about privacy and data use, how it's stored, lots of concerns about discrimination. That always worries people. And also, people will ask you, well, what happens if you show me that there's no medicines that will work for me? What do I do next? Lots of the systems that Cathie was talking about earlier, the strong governance, it being part of healthcare is really important to people. So what do the public want? They want increased personalization. They want to be away from the one-size-fits-all because they absolutely can see that it doesn't work. They want medicines that work straight off. They don't want to be going constantly back to their GPs with trying new medicines. And they want pharmacogenomics to be accessible to everyone. They want equitable testing. They want it through the NHS. And when testing is part of the routine healthcare offer, then they accept it far more. Here's another warning. Implementation. Munir was a child when all of this started, and he has white hair now. It's taken a long, long time with pharmacogenomics. And while all our debate about how this is going to be implemented at the NHS going on, there are a mass of providers out there who are already eating your lunch, my friends, because they are setting their own narratives. They are creating, in effect, already two-tier provision, because it's available to people who can pay for it. And they are telling people what to think about it. So people want to have, the public want information about pharmacogenomics from trusted healthcare providers. But here's this other klaxon. If you don't provide it, someone else is going to come in and provide it for you. And it may not be in the message terms that you would like. And people do not want to be patronized by health professionals who deny them their data. It's their data. Stop it. They want it. They are perfectly capable of understanding it. Okay, so let's get on to this. The importance of patients and public to pharmacogenomics, why I think that actually patients are an undervalued resource. So this is the push me, pull you. Where does the push me, pull you come from, anyone? Dr. Dolittle. In Dr. Dolittle, there was this creature, a push me, pull you, which tried to run away from each other at the same time. What we are trying to do with pharmacogenomics is push it into the health service. Pulling it is far easier. And I think that we're worrying always with implementation about the few, but we're forgetting about the 80–90% who are absolutely there, desperate to have it. The majority of the public want it. And what you should never forget is the power, the social movement change that can be there if people have something on their phone and they say to their friend, have you seen this? Look at this. It tells me this. Patients, people, because it will be people, it's preemptive, telling their friends about it will do far more for you than any of you can do in terms of public awareness. Social media can really build a change narrative. This needs to be a social movement. If it's just about constant iteration of one little thing here and a little thing there, it will not take off. I've been in broadcast all my life, and we do not broadcast to the few, we broadcast to the many. So the ideas about how you're going to get this out there need to be thought of as not addressing a few people, but addressing a population. I showed you Rishi Sunak before. His dad was a pharmacist, which is partly why I had him there. But you need to have community leaders to help level up. They need to be taking this into their communities and showing them what their communities can do that can pull something that could be so beneficial into their communities. And I have an absolute fetish about this, which is we need to be thinking about preemptive. We need to be thinking ahead. We need to be thinking about what policymakers want from this. We need to be thinking about the economic case. And we often talk about much older people, and that's where the medicines burden is. Of course it is. But actually, when you start to look at the groups that could make most difference and where the signal is going to be so much stronger than the noise surrounding it, particularly in terms of economic benefit, if you look at specific groups like adolescents, there is no single health check for adolescents at the moment. Government would very much like there to be a single health check for adolescents whose health is very much neglected. Any of you who've got teenagers, you'll know that they will never see their GP unless their leg is hanging off, or they're denied going to a party because their tonsillitis is just so appalling. They will not go to their GPs. They don't go there. So how do we look after their health? Well, there are lots of things that we'd like to do. We'd like to check on their mental health. We'd like to offer them vaccines. I spend a lot of time in the vaccine world. It's a real opportunity, I think, for a whole cohort to offer them pharmacogenomics. Think about the fact that something like, I'm looking at Munir, hoping I'm right here, about 40% of drug gene interactions are psychiatric drugs. He's nodding, thank God for that. 40, and when are those conditions diagnosed first? They are diagnosed in late adolescence and early adulthood. How fantastic it would be to empower adolescents to have on their phone, which is their life, data that just gave them a red, orange, green. And to say, look, you may never need this in your lives. But actually, if you have unfortunate enough to have a mental health problem, take this to your pharmacist. Because they will remember it. They will not forget it. They will take it, because they always have their phones with them. They will take it to their pharmacist. You can have a QR code, just as Sonia was showing us earlier. You can have a QR code. You can have all that kind of stuff. But they then create the movement for the pharmacogenomic system that you want for the future, which I'm assuming, looking at you all, is preemptive testing on a population-wide scale. But to me, you get things that government want, which is annual health check. You get things that you want, which is having something that returns an economic benefit because it's a relatively small population and it's very defined sets of illness. You get something that's returned to you quite quickly, and you also get the start of a social change movement. Because teenagers, and remember teenagers are the great, I'm such an enthusiast for teenagers because, think of Ada Lovelace. She was 17 when she met Charles Babbage and they started to think about computing. Charles Babbage himself was 16 when he went to Cambridge. He became a grumpy old man and he invented the computer printer, as well as the difference engine. But so if you're ever having a fight with your computer, or the printer, which is always going wrong, isn't it? Just blame Charles Babbage and swear at him. But so teenagers have achieved some of the most extraordinary things in our lives. They are the people who will pull pharmacogenomics through your system for you, and they will create the social change. So how do we get that to them? Well, there are lots of things that will come up in the future. Cathie has talked about the adolescent health survey. There's all sorts of things that you could do, but there are specific ways. I think about as a broadcaster of the communication medium that you need to get to touch those bigger groups. And it's because often I think that you will think about patients, you'll think about specific groups. But actually, when I think about broadcasting, I think not about narrowcasting. I think about getting to as wide a population as I can through the means that are appropriate to that particular group, whether it's through music, whether it's through football, whether it's through, there's a multitude of different avenues for different groups of people. But that's how, in my view, we should be thinking about pharmacogenomics and the public for the future. They want it, you've got it, let them pull it through for you. And that, I think, is enough throwing stones into water. Can I take some questions?
Thank you very much.
I've left them all with horrified faces now.
Well, no, that was great. I think you really touched upon, if I'd had time to ask Jess or Eunice some of the questions, which is how do you kind of go from just giving information to empowering patients to use that information and hold it, and particularly, I think the interesting thing around pharmacogenomics, before perhaps anything has actually ever happened to them. So
yes.
In terms of using that data before they have a reaction.
And I was going to say as well, is that sometimes you worry about how we're going to deal with, often when you talk to people in the NHS, the thing that they say constantly to you all the time is, we'll be overwhelmed, we can't cope. Well, have any of you come across Euphonia and Dora? So Euphonia is an AI system that the NHS has already adopted. There's a specific program called Dora, and if you've had a cataract operation, Dora is a bot, and Dora talks through elderly people about the consequences and whether they need follow-up for their surgery. And it's absolutely brilliant. It was designed with patients. It's been fantastic. And so you need to employ things like Euphonia. There are other systems available to make sure that you are not overwhelmed and that you have that facility to answer the questions that some people will inevitably have.
Mm. Yes, yeah, but I think there's a lot of infrastructure, yes, we have to get into place to do that, but absolutely, that's the sort of tools we want to get to. I'm just saying, I feel like I'm taking pledges from the audience in terms of what they're going to do next month or next year to make this work, but does anyone have any questions or comments?
Cathie, I've horrified you. But I'm on a roll now. I've always been fascinated by pharmacogenomics. I am bloody going to see it implemented.
So, Vivian, thank you very much. Persuasive and inspiring, exactly as expected. And I love the teenagers as agents of social change. It's a fantastic model. What you've shown us is, in terms of the public views on this particular type of data about them that can inform their care, is very similar to what we see about their views on their medical records and health data in general. You know, the issues of purpose, privacy, fairness, who benefits, anxieties about the evil corporates, all of those things, they're generally applicable. And obviously we are moving forward, I mean, at snail's pace, of course, in the UK in terms of people having access to their medical records. So is your sense that access to genomic information that is relevant to the safety and benefit balance of different medicines, it feels like it should be part of that, and that this movement should in general be pushing for access for people to have ownership of and availability of their own medical information, irrespective of the others in the healthcare system who need access to it as well. And I think many of us in this room, hopefully most of us, would be completely in favour of that. It's rolling out rather slowly across England.
So
and
I'm going to
just
say...
one thing to finish, but have you spoken to, because the brakes are being put on this by certain members of the health profession, and I loved your sort of school marmish stop it. It was very compelling. Have you spoken to the BMA and the health professionals that they represent, in particular our general practice colleagues who have anxieties about the impact on them? I think they could do with hearing this kind of very compelling narrative.
So here's the thing, and I would say to you, Lady Sudlow, Trojan horse. So I have always said, in all my years at Genomics England, I said, pharmacogenomics is the Trojan horse of genomics. You don't need more than a couple of pages on your phone to tell you about pharmacogenomics. You do not need to be told about SNPs and, you know, ACTs and Gs. You don't need that stuff. In fact, as I've talked about, now I've been talking about genomics or genetics for 50 years. 50 years. At the beginning, I started out with lots of science words. Now, I regard it as a failure if I've used a science word when I'm talking to a public audience. They get it, they understand it. So they don't need to know. They have it on their phone. They go into a pharmacist, they slap it on there. I've been given this. What should I do? Because this is what my pharmacogenomics, and there's I don't know, red, yellow, green. Tell me. And the pharmacist, in my version of events, looks at the QR code, scans it, and says, you need double the dose, half the dose, whatever it is. But think about that in terms of mental health. Think about what the burden of mental health is at the moment, where kids who go on the wrong meds struggle through the system, don't get to see a specialist for years, perhaps, because of the burden on CAMS and mental health services for the young. So if you get them on the right drugs straight away, think of the difference that makes to the bottom line of the NHS. I mean, to me, that's a compelling case for doing something that is really simple, that actually then pulls through later on all the other information. But you start with the easy stuff because people get it. And they don't need to do anything about it until they're sick and they're prescribed something. And that's the moment that they can present it. And they won't forget.
Okay, thank you. I think we've got time for one more question.
Hi, Vivian. Aaron Peace from Northern Ireland. Looking forward to coming over and talking in September.
What, terrorising the Northern Irish?
So, I mean, you mentioned there that the public really do already pretty much accept this. How then do you think you're going to convince the NHS itself? Because within it, I've encountered an awful lot of obstruction officers, as I like to call them.
You are absolutely right. The obstruction and I don't want people to know, well, in genomics, people don't want to know, the professionals, and not, of course, including you, professionals don't want to know about genomics because they don't know about genomics and they don't want to be shown up by their patients. And so they tend to be, do any of you know Partha Carr in here?
Yeah.
So Partha Carr, fantastic, he's NHS clinical lead for type 1 diabetes. When he came along, first of all, there was only 3% use of closed-loop systems for type 1s. Now there's 97%. And people said, Partha, did you discover a gold mine under Skipton House? And he said, no, 30% of the NHS professionals will be the enthusiasts, 30% will put their heads down and just do whatever they're told to do, and 30% will say, nobody is bloody going to tell me what to do. And what Partha did was he employed patients to go round to the ones that didn't do it and say, everyone else is doing it, here is the information. And it was the patients that achieved that social change. With pharmacogenomics, I promise you, it will be the patients demanding it that actually will force it through. You need to create a social movement. It's a social movement of people saying, this is really good, it's great, everyone should have it, that makes it a popular decision for policymakers, provided you've got the underlying economic case, which I think that you could get, particularly if you're choosing groups where there's not so much noise as there is in older people taking a mass of different medicines.
Okay. I think I should step back. I've appalled you on that. I am convinced that this is the way for you to go, to make this a social movement. Because when hospital managers, when politicians, when policymakers have enough people pitching up at their doors saying, why isn't everybody doing this? And they also see the private companies getting in and doing their stuff, they will suddenly think, oh my God.
Okay. So quite a lot of food for thought there. So on that note, thank you again to all of our speakers for some really fantastic presentations. And now you can take all of those questions and things you need to discuss into the last coffee break of the day. So you've got until 20 to 4. Please do take the time to chat to each other, chat to people on the stands, and yeah, maybe solve some of these problems.
So it's a pleasure to welcome you back to the fourth session of today's meeting. I'm Rich Devons. I'm Head of Population Health Sciences at the Medical Research Council. I look after a small team that looks after our funding for longitudinal population studies such as Genes in Health that you heard about earlier today, and also some of our work on prevention, particularly around the upstream determinants and the more strategic angle, rather than the more molecular agenda that we're talking about today. So very pleased to introduce this session on polygenic risk scores, and we have 3 excellent speakers talking today. Each speaker will have around 20 minutes, so we have 20-25 minutes, so we have a couple of minutes for questions after each one. And please do think of your questions whilst you're listening to what I'm sure are going to be 3 fascinating talks. So very pleased to welcome our first speaker, who's standing in at short notice for Professor Donnelly. So pleased to welcome Dr. Mike Wheel, who's Director of Statistical Methodology at Genomics Limited. And we'll be giving a talk today on a new prevention-focused agenda for healthcare. Thank you, Mike.
Thank you. And a couple of apologies. So firstly, on behalf of Peter, he sent his personal apologies for not being able to make it today. There were very real reasons why he couldn't make it, and they were sort of short-term notice. So he's very sorry that he wasn't able to be here today. And then the second apology is from me. I'm not Peter Donnelly. I have neither the extent of practice nor the innate ability at public speaking that Peter has, and I don't do it as regularly as he does. So my apologies if I can't convey the same talk in the way that he would. But having said that, I am going to try and convey a sense of excitement a sense that maybe we are almost ready for prime time in terms of genomics-led precision medicine, and also accepting that there have been many false dawns in this space. I was quite struck by a comment from the Q&A session at the end of last session that they'd been in the field for 50 years talking about, how to convey genetic information. It's been a long time, but I do think there are things happening now that indicate that we're really getting into clinical practice. So I want to invite you to sort of go back in time for 25 years, or 25 years, and, excuse me, I'll turn off my... If you had a person's whole genome sequence at that time, and this was a healthy person, say in their 40s, and you surveyed that person's genome in order to try and find medically actionable information from that genome, then maybe in about 1 or 2% of people would you find something medically actionable. And that's because it was focused on these rare pathogenic variants, very impactful for the person, but thankfully very rare at a population level. Now, if you fast forward today and you did the same thing, then we would expect to find something medically actionable in about 70% of those people, and I'll present the evidence today for why I think that's the case. But where that lies, where that difference between 1% and 70% lies, is in the advent of polygenic risk scores. I'm Director of Statistical Methodology at Genomics, the company I work for. But having said that, I'm not going to go into a detailed statistical explanation of what polygenic risk scores are, partly because I think we're now at a stage where most people understand what they are, and partly because it's not the right audience and I don't want to sort of dwell on it. I will just say, though, that what you're doing here is aggregating information at more common variants, not the rare variants, but more common variants across a person's genome, and you're aggregating them typically, ultimately in a linear combination of that risk information into a single score that gives you a readout on the genetic risk from the common genetics of each person. One of the key things here is that you only need to do this once, so you can perform a relatively cheap array-based assay of that individual, and you can get the readouts for any disease that you wish, provided you've got the appropriate genetic model to aggregate those variants together. So what does that do? Well, in terms of stratification, what that does is it greatly stratifies a population according to their risk. So on this slide, we have an example for coronary artery disease in men, and the red line of those are the highest risk group, the top 3% of the PRS distribution. The green line is the median, the average person, average man in this case, and the blue line is the lowest 3% of that distribution. And you can see that starting in the age 30, as you look at the accumulated risk of getting a CAD diagnosis, then you get enormous separation between, say, the red and the blue lines, so that once you're at about age 65, there can be something like a 10 times or more risk between those two groups. The observed number of diagnoses is separated by that amount. And I should point out that this data is independent to the data that was used to train the PRS, so this is independent testing data that we're looking at here. And that can be seen vertically by the red dotted line, but also it can be seen horizontally, which is a temporal difference. So if you think of someone of average genetic risk, the green line, at age 65 and their risk of coronary artery disease diagnosis, then someone in the red group will have the same equivalent risk, accumulated risk over their lifetime, or at that age, at about 15 years younger. So in terms of preventative strategies that you might want to apply, and given that currently in the guidelines for the management of coronary artery disease or cardiovascular disease, it's about your risk, then there's a huge stratifier here that's not currently being used in the current equations for calculating a person's risk. And this isn't just about coronary artery disease, and I know that Professor Nilesh Samani will be talking about that later. But also in other diseases, you get a similar, very strong stratification. So on the left for breast cancer in women, and on the right for prostate cancer in men. So I'm not going to dwell on that slide, except to note that we have similar stratification. One of the things that has been noted from right at the beginning about PRSs is this point that they don't have the same separation or stratification in different ancestries, and that's largely a function of how they're created. So they are trained on these large genome-wide association study data sets, which historically have been very much skewed towards people of European ancestry. And so as a consequence, your stratification in relative terms between your red and your blue line is greater when you're of European ancestry and is smaller when you're from a different ancestry. But there's 2 points I want to make on this slide. The first is that regardless of your ancestry, it's still a useful stratifier. It's still something that would greatly aid in the management or the understanding of risk of a person of African ancestry, of South Asian or East Asian ancestry. It's not just that it stratifies European ancestry. And the other thing I want to say is that other factors are involved when you're trying to calculate an absolute risk or an accumulated lifetime risk. So it's about the relative risk between the red and the blue lines, that matters, but so does the baseline risk, which can also vary by ancestry. So looking at South Asians here, if you look at the green line representing the average person in terms of their genetic risk, so in South Asians that's elevated, and so then when you look at the combination of that in the red line, in fact your absolute risk is higher than it would be if you were European and in the red line. So there's a combination of relative and absolute risks going on here. Okay, let me drill down into another example. So obviously BMI was an index of obesity when it's above a certain level. This is a study that we did in Alsbach. That's a longitudinal study that followed children from birth through to first 20 to 30 years of their lives. And we had the genetics on that cohort. And so using that data, and we were able to have a PRS for pretty much any trait that you can think of. So we took our PRS for body mass index, we applied it to that cohort, and we split the cohort according to which decile of the PRS they fell into. So that's the x-axis, 1 to 10. So the first decile, the most beneficial PRS group, your genetics is kind of helping you to reduce your BMI. The 10th decile, the worst from this point of view, genetics is pushing up your BMI. And what you can see is that even at 8 months old, in babies effectively, you're seeing that there's a stratification in BMI. And that simply gets stronger and stronger through until 18 years old, where there's even stronger stratification in BMI. And that's not to say that you should be giving babies Wegovy, but it's just saying that you can see this right from the start. You can also represent this in terms of a trajectory. So this is like an individual's trajectory in their BMI over time. So note that in fact your BMI, if you measure it at very young ages, it's a bit higher and then actually dips at about age 5 and then it starts to increase again. But the relative positioning according to where you are, according to your genetic risk, stays the same. So if you're in the top 3%, you're at a disadvantage. Your genetics is, taking you on a trajectory towards high BMI, such that when you reach the age of 25 or so, in the top risk group here, the average person in that group has a BMI greater than 30, which is one of the clinical definitions for obesity. So the genetics is a strong stratifier. Another way to represent this, this is off the back of a study done by other colleagues quite recently in the US. They looked at All of Us, which is a US-based, large population-based cohort that you can do various kinds of studies in. It's kind of the US version of UK Biobank, if you've heard of UK Biobank. So they fitted a model where they had a genetic model, a PRS model, fitted to the individuals, and they also had accelerometer data, which sort of like measured how much walking each person was doing in that cohort. And they were able to show that, you know, you could derive a model that adjusted how much someone would have to walk a day in order to offset their kind of genetic goodness or badness for BMI that they had, their inherent genetic predisposition to risk of obesity. And what this graph shows is that if you're at the 20th percentile of the PRS for BMI, then you need to walk about 3,500 steps in order to offset that. Whereas if you're in the 95th percentile, then you need to walk about 14,000 steps a day in order to offset that. So it's not that you can't offset it, it's just that, you know, the genetics is it's a bigger barrier to overcome, it's a bigger hurdle to overcome if you're in the disadvantageous PRS group. So back to my original point. So at the start I said, okay, so 25 years ago you could find out something medically actionable in a healthy 40-year-old maybe 1% of the time. Now it's about 70% of the time. What's driving that is the big disparity between the number of people who are at similar risk according to their PRS, what you might call their common genetics, compared to their risk due to their rare genetics. So here's an example from people at risk due to rare variants in several loci that allow you to be diagnosed with familial hypercholesterolemia or FH. Using UK Biobank data, we observed a similar rate of risk in people who had a PRS between the top 8 to 10% of the PRS distribution. Those people have a similar risk of coronary artery disease as familial hypercholesterolemia carriers in UK Biobank. And in terms of the number of cases that then get identified by those two groups, there's this huge disparity, figure on the right, between those that are at risk because of their FH carrier status and those that are at risk due to being in the highest 8% in this case of their PRS. So there's between like a times 18 to times 30 difference in the amount. So that's why even for a single disease, it's more important to know about your common genetics. At a population level, it's more important. And I agree that at an individual level, it's still very important to know if you've got an FH mutation. But at a population level, in terms of prevention, for example, it's much more important to know about the population level of risk that is given to you by your PRS. And in some cases, that's really the only piece of information that you need to know. So if you take breast cancer as an example, of course we know about the rare genetic variants that highly predispose you to breast cancer, and of course they should be screened where there's evidence that they exist from, say, family relations. But again, in terms of the population impact, it's all about your polygenic risk score. So we've actually got rare genetic variants on this list, alongside some other relatively weakly, associating risk factors for breast cancer. You can see that family histories there. This is all from UK Biobank data. But if you know your polygenic risk score, then your population level prediction ability in terms of your area under the curve on a population level, if you know your polygenic risk score and then you know everything else just bumps up your AUC by 0.1%. So if you're doing, let's say, breast cancer screening based on a combination of age and other things. I should mention this is all corrected for age. So age is not on there, so age is very important. But this is adjusting for age. Then, you'd really only need age and polygenic risk score. And I'm not saying you shouldn't do the rare genetic variants as well, because you should, because at an individual level, they're very important. But in terms of population screening and making that screening as efficient and effective as possible, it's all about your POS and your age. Okay. So another example, this is from a recent paper that our company published in Nature Communications. Another area where POS could be applied, and I kind of mentioned it just now, is in the area of screening, of using it to come up with risk-guided rules for entry into screening that are more personalized than the current system, which is basically your age. And maybe if you're, maybe if you're a smoker, like abdominal aortic aneurysm, that also is important. And maybe also ethnic background. So in prostate cancer, if you're black, then the guidelines suggest that you should be having more of a serious conversation with the person if they're black, and certainly, of course, they've got family history. So these things are not all screening in the sense of national screening. We all know, for example, that prostate cancer, recent ruling from the National Screening Committee is not to have population-based screening in prostate cancer. But nevertheless, there is still a conversation that clinicians are supposed to have with the people who come to see them. And factors like age, family history, and ethnicity play a part in that. And if there was a POS available to that clinician, then we're advocating that that should also be a part of decision-making about, the shared decision-making about whether to have a PSA test and at what frequency. So what we did in this study, we took these, actually there was 7 diseases, so one of them's missing here. Okay, hopefully it'll come in a later slide. And we used UK Biobank data in order to calculate these plots similar to the ones that I was showing at the beginning, where you can separate people into low, medium, and high POS. And here, they don't mean the same thing. At the beginning, it was the top 3%, bottom 3%. Here, low and high refers to, are you at 3 times the risk, or I think half the risk, I think were the 2 that we used. Oh no, sorry, twice. Twice the risk or half the risk. There was a secondary study which uses 3 times the risk. This is using twice the risk. So that's what it means if you're in those 3 different lines. And again, we're talking about this horizontal equivalence, so that at a certain age, say at age 50, the average risk for a woman would be represented by the green line. And then if you're in the high POS risk group, that's at least times 2 the risk, then you'd be at the same risk about a decade earlier, and you're at 40. So the logical implication would be that if you're doing screening in order to capture people who are at high risk of breast cancer, then in those people it should be starting at age 40 and not age 50. We can do this for the other diseases as well. I'm still trying to figure out which is the one that's missing, but there's one disease missing there. But we've got, aortic aneurysm, we've got your breast cancer, colorectal cancer, coronary artery disease, prostate cancer, type 2 diabetes. It's not type 1. Atrial fibrillation, thank you. Thank you, Nilesh. It's atrial fibrillation. So that one was, I guess because 7 didn't fit into a panel neatly. You can do that for all of these diseases, and then you can ask the question, so what happens if we implement a POS-guided screening strategy? What impact would it have? And we used real-life data from either clinical trials, or mostly clinical trials, in fact, where we've looked at the difference in mortality and the relative risks involved in order to work out how many lives would be saved if you implemented this screening strategy. And we found that 25% of individuals would be at high risk for one of these 7 diseases, and premature deaths would be reduced by, again, similar amount, almost 25% in those individuals if this strategy was implemented. Okay, I'm in the final 5 minutes. So what are we doing as a company? I work for Genomics Limited. We've been going for about 11 years now. The clue's in the name. We do genomics. We have a bank of PRS models. This figure shows that our PRS models do very well compared to competitors either from the academic or the commercial sphere. So our ones, this is like a area under the curve. It's a measure of performance. And our ones are the blue ones towards the right of that figure. And again, looking back at how much they stratify, it depends on the disease. I mean, prostate cancer, more so, breast cancer, less so, but they all have a large degree of stratification for them. We have multiple publications that we've published validating PRSs for clinical use. I just described one of them in UK Biobank for the screening strategies. Things are starting to change. I mean, again, Nilesh is going to talk about this, but particularly in the cardiovascular disease space, there are now publications from the European Society of Cardiology and also the American Heart Association and American College of Cardiology, which advocate the use of PRS as part of finding out persons' risk and combining them with other risk information in order to make those decisions about, for example, LDL lowering therapy. One study that we've done looking at clinical acceptability and feasibility is this HEART trial in collaboration with the NHS in the northeast of England. We gave an integrated risk score, or an IRT as we call it, to individuals alongside the Q risk score, so that they had a side-by-side comparison. Well, that was given to the clinician. It was up to the clinician to decide how to present that information. But what we found was that, I mean, again, speaking to a point that's made earlier, I mean, the patients loved it, right? And the patients thought, 99% of them thought that it was helpful to include genetics. The GPs advocated changes to the management in 13% of the cases. That was, obviously reduced by how many people actually went above. Obviously, there's a clinical threshold of 10% risk, and only a certain number of people do that. But the figure on the right indicates how much your risk changes from the Q risk score on the x-axis to this integrated risk score on the y-axis. Substantial and important changes in your risk occur once you've added your PRS information in. Another thing that we're doing, we provide the PRS scores for Our Future Health. So currently these are for academic use only, but we have a bank of about 50 or so that are for academic use. And there's absolutely an intention within Our Future Health to go towards pilot studies to look at the use of genetics in preventative medicine for the individuals who've volunteered for Our Future Health. But again, things take time. There's still a review process that's going on at the moment to decide how best to implement these studies, these sort of pilot studies within Our Future Health in order to give people back their PRS-guided risk information. On top of that, we have an MHRA-regulated product in the UK called Health Insights UK. We've got a clear certified product in the US that's called Health Insights US. These are currently with private providers, healthcare providers. So Bupa, we've already had a pilot study with Bupa. We're ramping up to full implementation in the next 6 months. And some others as well, Spire Healthcare. In the US, we've got MassMutual. Gene by Gene is collaborating with us on the Bupa project. So that's what we're up to right now. And then in the NHS, we've just had, well, last year, the 10-year plan, which put genomics at the heart of the prevention strategy that the NHS has for the next, 9 years now. And so we're very much hoping that they'll stick to that, and they'll stick to their word, and that will become a reality over the next 9 years. So, thank you.
Great. Thank you, Mike. So we've got time for a few questions. If you can wave your arm, the microphone will descend on you, perhaps over this side and then at the front.
Oh, hello. Yeah, I was talking, we were talking earlier about how professionals sometimes kind of don't want this stuff and, don't like to, to dispense it. And one of the reasons here is that quite a lot of this stuff, it depends on lifestyle changes. In other words, a lot of this stuff is not quick fix, like breast cancer, where, don't mean quick fix, but, where it's additional monitoring, for instance. It's something where they have to change lifestyle. And GPs are notoriously loath to give lifestyle advice. So how do you overcome the resistance from professionals who don't want to introduce this stuff because actually it puts an onus on them to do something more than just hand out a couple of pills?
Yeah, excellent question. I've got, I guess, a couple of answers to that. The first is, I'm allowed to go back? Yes, I am. So in this study, again, perhaps cardiovascular disease is a special case. Again, I know Nilesh is going to talk to it, but they already have risk-based conversations in the when you go for a health check in the NHS. So there was very little resistance from clinicians to the idea of, okay, now we're adding genetics to the risk score. Well, okay, they're already doing that, right? They're already doing Q risk, so it's just another risk factor, and wholeheartedly support your point earlier that you don't have to talk about genetics. It's just, you have to talk about risk, but it doesn't have to be, you can say, and yes, we've got genetics, but it's just one other factor. And the other point was, although, yes, of course, lifestyle changes. I should point out about this. There was one clinician who hated it, right? So we had 20 clinicians, and one of them said, no, we're going to get all the, because they also had to do a questionnaire about how much they appreciate or did not appreciate the use of genetics. And there's one person, no. The other 19 were fine. Right? I don't know, that doesn't seem like the same ratio as the rest of the NHS, but that's what we found. And the other thing I wanted to say was, yes, of course, lifestyle changes are important, but in every case that we looked at in this study, the screening study, it's usually about something else. So, it's about doing a PSA test, or in case of cardiovascular disease, I know you start with lifestyles, but then there's the discussion about statins if you're above 10%. So there's always something a bit more than just the lifestyle, I think, about what can be done.
Thank you for the great talk. PRS at the moment, they pick up only a very small subset of the population that are very high risk of getting the disease. You very nicely showed in a couple of slides after that all those with cardiovascular disease, breast cancer, this one, yeah, that's right. So it's 25% of the individuals. But if you look at those diseases in the population, probably it's 100% of the population that's going to get one of those. How do you perhaps this could be the reason that we only identify those gene hits with a higher effect size compared to the very many variants that we have with smaller effect sizes. How are you addressing this? Do you have an approach in order to be able to pick up all those many variants with small effect sizes in polygenic and common diseases?
It's a very important question. Obviously what you can do in theory is you do one genetic test, perhaps even at birth, or an assay, and that's also part of the NHS plan, actually. And then you have the information there, and then you can calculate whatever risk score you want, and the benefit should then be accrued over multiple diseases, as we did in this particular study. But the implementation problem is that that's not necessarily how practices work, how clinical practice works. It tends to be about one disease area, and so then all you're interested about the cost benefits for that one disease area. I totally get the point. Do I have a solution? I don't think I have a solution to that. But one of the definite positives about POS is that you should be able to be thinking about this as a multiple disease benefit. So in principle, that should work.
Thank you. Final question from Cathie?
Yeah, thanks. So it's really great to have an update on all this work, a fantastic summary of the field. And presumably, as a company, you're very keen to see uptake of this technology implemented across the NHS in the UK and benefiting care and so on. So I wondered if you could just briefly talk us through what you see as the key barriers, because you must be like having those discussions. So is it cost? Is it cost effectiveness? Is it system readiness? Is it resistance to a commercial provider? I'm just suggesting a few things.
No, there's all, I mean...
Or is it questions about, does it make a difference to people's behaviours, enough to merit the cost beyond what we already do? I just wondered if you could walk us through some of those discussions you must be having.
Yes, thanks. I mean, all of those apply, okay? And also, I mean, one of the things that I think you mentioned at the end is that if you're talking about prevention and you're talking about a disease a person is yet to have, the validation studies have to, in principle, have all that follow-up, right? So that's why the validation studies usually have to be retrospective. You take a big population cohort like UK Biobank and you go back in time to when they were recruited and you follow them forwards. And some people, because we've talked to people at NICE about this, say, well, that's not good enough, that's retrospective historical data. You need to do another study, you need to follow that up for 20 years, which of course would then make that impossible to implement. I think what we're noticing, and again, this goes back to, I think, what you were saying in the Q&A at the last talk, was that we're getting more traction because patients are positive and demanding this, and the public health sector are adopting these tests. And if we have, and all the data we have so far indicates that these are beneficial. So if we accumulate enough what you might call, real world evidence as we go along to show that these are beneficial, then I'm hoping that the requirement for a prospective 20-year study will eventually be overcome by the fact, well, it's obvious these things work, it's obvious they have benefit, and it's obvious that we should be incorporating them into clinical practice.
Thanks very much, Mike.
Thanks.
So, very pleased to welcome our second speaker today, who's Dr. Ann-Britt Jones, Clinical Research Fellow in Oncogenetics from the Institute of Cancer Research. So, Dr. Jones, we're looking forward to your talk on polygenic risk scores for stratifying clinically significant prostate cancer. Thank you.
Thanks very much. Thanks for inviting me to come talk, and thank you to the previous speaker to set that up. Some issues up quite nicely for me today. So my name is Ann-Britt. I'm a postdoc fellow working with the oncogenetics team at the ICR under Prof Fields' team. My background is in epidemiology and oncology, and then I got into kind of germline genetic testing in asymptomatic and screening, but also in treatment, particularly in prostate cancer. So I'm going to take you through our experience and a study of using polygenic risk score and its use to stratify and guide screening for clinically significant prostate cancer. This is no conflicts of interest, but this is that kind of meeting, so that's kind of nice, but there's nothing to declare. So first I'm going to set the scene, because we're switching gears quite a bit and talking about cancer today, and this one in prostate cancer. It affects 1 in 8 men of European ancestry, so it's the most common cause of cancer in men by the age of 80. It also affects 1 in 4 black men, so we know that that's higher. It's the most common cancer, as I said. There's about 62,000 new cases every year that are diagnosed, and about 12,000 deaths per year. And the top is just about the age standardized incidence, and then the bottom just depicts the deaths from prostate cancer. We know that there are certain risk factors. There aren't many, but age as one gets older, ancestry, as was alluded to before, and family history. So this is what we have to work with within the space of prostate cancer, and we'll move on. It's also one of the most heritable cancers, with an estimate of 50 to 60% of prostate cancers thought to have an inherited component, be it germline, inherited, or familial So just moving on with those risk factors, as I said, we know that age is ancestry. We also know that there's the highest risk in the Black African Caribbean with 2 times the risk of prostate cancer. That cohort has twice the risk of death from prostate cancer, and they're more likely to die at a younger age. Family history is also implicated as the risks increase with the closeness and the number of affected relatives, so whether it's a first degree, second degree, and how many people are associated. And then we have the established germline genetic factors that we know about, these rare genetic variants such as the BRCA1, BRCA2, and those serve as an independent prognostic factor associated with poor outcomes. Those with other DNA repair genes. And then we come into, as was alluded to previously, the common genetic variants and using a polygenic risk score to help as an adjunct in screening or risk stratification. So I'll touch on each of those briefly. First, with the germline rare variants, we know that there's a well-established evidence for moderately increased risk of prostate cancer within the DNA repair genes. And when these genes are functioning normally without an alteration, they help protect against cancer by repairing DNA damage. However, when an alteration is present, you can have a risk of breast and ovarian cancer, as well as prostate and pancreatic cancer. The prevalence for a BRCA carrier is about 1 in 400 in the general population, and that increases with different subgroups. So in the Ashkenazi Jewish population, it's about 1 in 40. And it was also found within Scotland in the Walesey group, I'm not sure if I'm pronouncing that right, in Shetland of 1 in 40. And we see from studies that have done within our group the impact that within BRCA2 carriers, the risk of prostate cancer is 4 or 5 times general population risk. These variants are found in about 5% of men with metastatic cancer. So is there an association with aggressivity, higher grade disease, and also diagnosed younger? With BRCA1, it's less of a, what do I want to say? It's less associated, but still the risk is 2 to 3 times the general population. And there's an increased proportion of unfavorable disease. And then we get into the Lynch syndrome genes, which also carry a higher risk for the population. And this data is variable across the literature and cohorts about the predisposition to more aggressive disease in that cohort. And detecting these genes also has implications for treatment for anyone in this current age in terms of PARP inhibitors and immunotherapy with MMR. So it is important. And then we get to polygenic risk. And as discussed previously, most common diseases like cancer, diabetes, and heart disease aren't caused by a single gene variant, but hundreds of genetic variants contributing to the small effect. And from these large genome-wide association studies, we can see which each variant has a specific effect size, and then summing up the number of the risk alleles of these single SNPs or single nucleotide polymorphisms can give us, and weighted by their effect size, can give us an estimate of risk. It's not going to tell us that they are going to get disease. It's going to, another useful piece of information about risk in terms of developing. And again, we was touched upon that lifestyle, environmental, and other modifying factors do play an important role. So in terms of the, genetics and prostate cancer, if you want to look at the proportion of prostate cancer and where the genetics is divided up, we know, as I said, from this, the rare variants constitute a certain percentage. And some of them are in current use and in the NHS test directory, depending on the indications. As I said, if you're from those populations previously mentioned, if you're diagnosed under the age of 50, or if you have metastatic disease under the age of 60. So those are in use. So that makes up a certain proportion of where the genetics and the prostate cancer is coming from. And then the other proportion is those SNPs identified from previous GWAS studies. And as also was talked about, the when do you integrate that into population mass testing? Because publications and studies have shown that the top 20% or percentile have similar risk to the rare pathogenic variants. So with that effect size, you're kind of beginning to see things come even. And then, oh, it's coming up on my screen, but not, there it is. So way back when, not way back when, but maybe 10 years ago, there was about 130 single SNPs that were used with it, that were found to have associated risk with the prostate cancer. And that was predominantly in men of European ancestry. And then 80 new variants came along, particularly within the Black ancestry cohort with Conti et al. And that brought up the number of SNPs to about 269. And most recently, we've come up to Wang et al., which has about 451, which is a multi-ancestry SNP. So that still leaves us with a big percent that's unexplained and where to go from there in terms of genetics and prostate cancer. And this is just another way, kind of, I think, is another way of showing it nicely in terms of what we were talking about before with having a rare variant with a large effect size. So we know that's detected through linkage studies and patterns within families and sequencing. And then we have these more smaller, these common variants with a small effect size, but if you can aggregate them together, they do come on the large effect size from the GWAS studies, and in the middle also the intermediate effect size, which is where these DNA repair genes largely lie. And again, back to the thing. So I kind of have a lot of different ways of looking at the same thing, but I find that quite helpful. So if you look at most people, as the previous speaker was showing, in the median kind of PRS average risk, and then you have an increased risk and decreased risk. Once you find out information, what are you going to do with it? Are you going to change their screening? Are you going to stratify it? How can you improve it? And this just goes back again that individually it's small, but if you could add them all up, not add them all up, it's not, the statistician would not be very happy hearing me say that. But if you could get the summary estimate, then you can go forward. And right now we don't have that in outside of research studies. So this brought our team to the background of the Barcode 1 study. Can a PRS be used as a risk stratification tool in the general population to target prostate cancer screening? And so we evaluated the use of PRS based on 130 SNPs at the time to identify men in the top 10%. And those in the top 10% went on and were offered PSA and MRI, which is what is the normal diagnostic pathway for prostate cancer, and then a biopsy. And we wanted to establish the incidence and tumor characteristics in that group of individuals who are at a higher genetic risk of the top decile. So we recruited from general practice. It was started back in 2019. So it was men of white European ancestry, aged 55 to 69. It didn't matter whether they were asymptomatic or symptomatic. The letters were sent out via the GPs, and if they expressed interest, then they wrote back to us. And then we returned results the beginning during the COVID pandemic, which seems like a zeitgeist now, but it was quite interesting at the time because we were doing saliva-based tests, and there was a lot of discussion about whether the saliva would, is it a respiratory thing? And now when you say it now, there's no harm in, passing on COVID-19, but I vividly remember in the February, March during that time receiving these samples and people getting quite worried, but that's by the by. It just shows when it was done what we were dealing with. So 40,000 men were invited, 8,000, almost 9,000 expressed an interest. For various reasons, there was not eligible or withdrew or deceased. 8,000 saliva kits were sent out, and we had a return of 6,000, about 6,500. I think it was a return rate of about 22% in the end. So 6,393 participants had genotyping data, and of those, 745 fell in the top 10%, or top 90% in the top decile. So they went on. So the next few slides are kind of, I'll get through them, just to give you an idea where things went and how things kind of, the pathway. So we sent them the kit, they sent it back, we did the profiling in-house, and then those in the top 10% went on to have a PSA test, any biological samples research, and the MRI. They all went on to have a biopsy. If they didn't want to have a biopsy, they weren't forced to. If they refused, we would discuss PSA screening with the GP, and they weren't in the study anymore. But we did have 100% of those 745 patients go on to have a transperineal biopsy, in which case it was prostate cancer. High-grade PIN or ASAP is kind of like a precursor. And so we would go through what the normal clinical standards are in terms of repeat biopsy plus or minus MRI, and then benign. And those benigns would go on, carry on in the study for another 5 years of screening with PSA. So there's this 745 that were in the higher risk. 550 underwent MRI. Different reasons why people withdrew. Just going to get to the take-home message. So of those that underwent biopsy, we detected 187 cancers. Median age at diagnosis was 64, and the median PSA at diagnosis was 2.1. Again, of these cancers, so they're divided into different risks, and these divisions of risks are done internationally. We use the NCCN, which is the National Comprehensive Cancer Network definition, and they help guide what treatments individuals will be going for. So we found that overall, 55% of these gentlemen who had a detected cancer with their intermediate risk, favorable, intermediate risk, unfavorable, or a very high or high risk. And those are what we would call Gleason 3+4 above. Gleason is one of the markers used to divide these groups. It's a sign of aggressiveness on pathology that's been used in prostate cancer for a very long time. The other parameters are PSA level and the extent of tumor on MRI, so whether it's confined within the prostate capsule, whether it's gone to both sides, or whether it breached the capsule. And the really important point was, of these that were detected, 23% or 20% or 1 in 5 needed radical treatment. So that's surgery or radiotherapy. So that's a pretty big number for us. So and then you can look at it a different way, which people like to do. All these participants, if you stratify instead of, since we did the higher genetic group first, that's what we decided what the population was, and then did biopsy and the other parameters. What if you divided it up and looked at the PSA above 3, PSA below 3, whether they went on to MRI, et cetera? You'd still find, again, in these Gleason and these risk categories, the 55% that are Gleason 3+4 and above. And if you compare that to other screening study that was done within the European sector, and they used Gleason 3+4, but also just by PSA testing, so PSA directed, they found a pickup rate or detection rate of 35%. So in this context, using the higher genetic risk category as a starting point was picking up more or detecting more. So another way of looking at it, if you kind of look at the categories of the risk stratification of the categories, we started here, right? So we picked up 187 cancers. And if you were to take those cancers and just say, okay, do PSA alone, PSA above 3 picked up 69. But what's more interesting is it missed 118 cancers just on if you were to do PSA based alone. MRI I won't really go through because I don't find it terribly interesting MRI only, because I don't think it's ever done just in isolation. But if you also look at the diagnostic pathway that's used in the UK, which is PSA and MRI, it picked up 30 cancers, but you missed 156 cancers. And of those, these 17 needed radical treatment, and those would have been missed. And the other thing that's interesting about this information actually is if you chose these 74 individuals, of all those diagnosed, of the 103 were diagnosed, that's a 70% that was missed on, if you were to just rely on the UK screening, regular UK screening, not screening, but diagnostic pathway for prostate cancer. And this is another way of showing the same thing, but it's just to put it into context. So As I said, one way you can use is the NCCN way of grouping prostate cancers. Another way is looking at the Gleason in and of itself. And again, you have this favorable and unfavorable depending on the pattern that's seen under the microscope. And this is just a nice way, okay, so here's our PRS. This is all the ones we detected. And then if you look at, say, PRS plus PSA, how many are you missing? And again, PRS, PSA, and MRI, and the number you've missed. This also adds in PSA density, which is another biomarker that people also like to use. So we found that the number of missed cancers was well, I'm trying to be politically correct, but it wouldn't have been acceptable. So the other thing with prostate cancer is that there's a major concern with overdiagnosis in prostate cancer screening, and which leads an overdiagnosis can lead to overtreatment of indolent prostate cancer. So a man can be diagnosed with prostate cancer and not have anything for 30 years and not have any problem, and it might be old age that in the end is the fatality rather than the prostate cancer. So within screening programs, this is a big topic of conversation, and overdiagnosis is based on the probability that the time it takes for the cancer to surface clinically is longer than the life expectancy remaining. So we, in collaboration with Nora Pashnyan at University of Cambridge, wanted to do some modeling just to see what happened within the context of barcode 1. So we looked at PRSA as a screening test individually, MRI, and PSA. And it was really found that the weighted average of overdiagnosis wasn't that far off from each other, especially the PSA and those within. So that reassured us in terms of the overdiagnosis. So in summary, barcode 1 really detected 40% of individuals had cancer, and more than 50% of those needed radical treatment, so surgery or radiotherapy. MRI missed some 65% of cancers, and another 63% of those had a PSA below the level that would trigger a diagnostic pathway within the GP setting. And this was then published earlier last year. So we wanted to think about what to do with these results and where to go next. And again, we found a higher proportion of clinically significant prostate cancer in men at a higher genetic risk, and that 70% that was also missed on the, if we were using the national diagnostic pathway as it is. PSA and MRI missed some significant cancers in this high-risk group, and the baseline results are informing ongoing work. So these individuals are being followed up for 5 years. We're looking at cancer incidence over time, tumor progression, and had led us on to the PRODIX study, which I'll discuss just briefly. There are some sub-studies going on within the barcode 1 cohort in terms of looking at psychosocial impact, and overall using a PRS to assess the risk of prostate cancer didn't have any long-term negative psychosocial consequences. But the problem is that we didn't really reach out to the ones who opted out, and we need to know more information from those who are declining it and what reasons, and those who withdrew, if it was based on PRS or if it was based on the fear of having a biopsy, because everyone was going to go through and have a biopsy in any case. And then the main thing that was touched upon in the first session this morning is representation. This was in the primarily European cohort, and we need research focused on wider demographics and underserved communities. So we came, the evolution of the PRODICT study, which is now recruiting, came to be prostate cancer risk prediction. So we're, again, recruiting through GP practices using a saliva-based kit that's sent out in the post. We're also doing community outreach events for community leaders. And we're looking at men, so a younger cohort, completely asymptomatic, ages 40 to 55. And particularly looking to recruit in the 4 different ancestries in terms of Black African, White European, South Asian, and East Asian. And this is also in collaboration with colleagues Pete Buckle at Imperial, who were looking at more human factors and implementation barriers given from the NIHR Invention for Innovation grant. So what's different with this is we do a sample collection again, DNA extraction, and we're going to have everything all together. So those rare variants we talked about in that pie chart previously, along with the common SNPs. So the candidate genes are those reflecting that's done in the NHS test directory at the moment with inclusion of the HOXB13 gene. And we are basing this on a PRS of 400 SNPs based on that multi-ethnic GWAS that was described earlier. Briefly, this is the aim. I think I'm low on time, so I'll just kind of get through there because there's another one. But again, we'll do genetic profiling on patients. Part 2, those identified with a high genetic risk, being a pathogenic or likely pathogenic in one of those genes, or a PRS in the top 20% this time. We'll undergo either PSA, we'll go undergo PSA testing and MRI, and you can see the outline of where things will go from then in terms of diagnostic pathways. So we're hoping the simple non-invasive test will enable risk stratification, identify barriers into implementation and uptake, and help understand what is causing or what is promoting these underserved group health inequalities in the underserved groups. I'd like to embed it into primary care because it is about earlier detection, and hopefully see this stage shift. So that's the product, and that's 1,000. And so it would be remiss of me not to talk about Transform, which is a trial done with Prostate Cancer UK, which is a randomized multi-arm multi-stage trial looking at screening in men. So again, it's 50 to 74. And if of Black ethnicity, they are lowering the age to 45 to 74. You're ineligible if you have a history of prostate cancer, which is understandable, but the main thing here is that you must be PSA prostate scan or any biomarker test or biopsy naive in the preceding 5 years. So you might get a lot of men who have had a PSA who want to go in it, but won't be allowed. So what they're doing are these prostate health checks, and they're looking the first stage for about 16,000 gentlemen. We'll each go into one of these arms. So PSA, if you're above 3, then you'll go into a community-based, so not a hospital normal perimetric MRI, but a prostogram. And the thought with that is that it's in the community, it takes less time, it's about 10 minutes versus about 40 to 50 minutes. If your PSA is above 1, you'll be followed up just by MRI, or you'll just have an MRI. And then PRS is the fourth arm. Followed by the prostogram. The PRS is being done with UCL, array-based, but then analyzed by our team at the ICR. So I hope that I've taken you on a journey of how genetic risk score can give a targeted guide to screening cancer. There's no globally agreed population screening program for prostate cancer. It's been in the news quite a bit in the last year. That could be another talk within and of itself, if I'm honest. There's difficulties with PSA alone. Genetics is becoming more accessible and affordable and acceptable, as we know. It's an opportunity to utilize other tools. And I think it's going to be a multimodal approach in the future that will help improve the situation for men with prostate cancer. And I just want to thank you for your time and also members that were involved in the study.
Really great talk. I'm sure we have questions. So again, if you'd like to wave your arm if you have a question and a microphone. So one over this side, please. Probably time for 2 questions. So if someone else would like to have one in their mind.
Very interesting findings. Thank you very much for presenting. You showed that in the population, the cohort that you looked, you managed to identify almost 200 cancers, and a subset of them, quite significant one, had a PSA that was less than clinically significant. But in the next study that you're planning to do in the younger population, where you would probably expect a lower percentage of cancers at the stage that you will be testing rather than the follow-up, you would use the PSA as a monitoring marker.
Yes, so are you talking about in the product study, the next one that's coming through? Yes, so instead of having all participants follow on with a PSA and MRI no matter what, and biopsy, we will streamline it more to replicate kind of what goes on in NHS practice to begin with, because the idea would be to help an easy saliva test, getting it out into the community and then back with the GP results to see what they're going to do. So we want to kind of model what GPs would do in the first place. Now, there are other studies going on with Sam Muriel and his group that are looking at gentlemen who present to the GP practice with symptoms, and then they'll also do the SNP 451 polygenic risk score, PSA, and MRI as well.
Great, thank you very much. Just a quick follow-up. Will you look at other markers like proteomics and metabolomics in the follow-up?
So we, for the Barcode 1 study, did take other samples in terms of urine, and we are looking at some metabolomics in that one, as well as protein.
Thank you.
One more question.
Thanks very much for that. You said you want to implement this in primary care. Have you spoken to GPs and what they feel about this?
So again, following on previous discussions had today, you're going to find a range, and those with, the GPs that used to have special interests or gypsies that are very much interested in it, and you're going to find the same that just want to be told what to do or don't want to have an extended conversation. I think more to the point with prostate cancer, being it is the most common cancer of men, there's no national screening. GPs are already having these difficult decisions and long talks with gentlemen who want to have a PSA done, what their family history is, what the nuances around PSA testing are, and if you're adding in a genetic test as an adjunct that shows something positive towards it, that they only need to do once, it might actually help GPs in that situation, she says.
Okay.
Sorry, thank you.
In the interest of time, we need to move on, but thanks very much, Anne Britt. So our final speaker today is Professor Sir Nilesh Samani, who's Professor of Cardiology and a consultant cardiologist at University of Leicester. So Professor Samani, we look forward to your talk on cardiovascular disease risk scores and whether they're ready for prime time.
Thank you very much for that introduction. Thank you for the invitation to speak at this meeting. And thank you for hanging around for the last talk of the day. So I'm grateful for all of you staying behind. I wanted to sort of build on what the two other speakers in this session have said, and particularly what Mike said, and say if there's a case now for introducing a polygenic risk score for cardiovascular disease. And to set the context for this, I would say that coronary heart disease, as all of you know, remains the most common cause of premature mortality and morbidity, and is a largely preventable disease. So I want you to remember that context about prevention. And it can be prevented by two different things. So what I mean by premature is somebody below the age of 70. It is a disease of age-related disease, but below 70 I think is largely preventable. And there are two ways we could do this. One is through public health measures, so smoking, of course, diet, having junk food stores next to schools. There are lots of things we can do as a community. And that's really a community-based approach. But the other approach, and the topic of this talk, is around identifying individuals at high risk. As you know, in the UK, and indeed in many countries around the world, there are health check programs that have been introduced because of the issue that, yes, if we can identify people at high risk for cardiovascular disease, there are both lifestyle and drugs that we can deploy in this situation that might reduce their risk. And as you know, in the UK, we have the health check program for people between the ages of 40 and 74, where people can come every 5 years to have a check, which stratifies them into a low-risk group, under 5%, 10-year risk, an intermediate risk group between 5 and 10%, a high-risk group about 10%, and a very high-risk group. And this, there is some debate about the value of this and the cost-effectiveness of this, but largely there's a view that this has helped in reducing the burden of cardiovascular disease that we see in the UK over the last 15 years since it was introduced. But there are limitations of the current clinical CVD scores. So in the UK, we use Q-risk. In Europe, there's a score called Score 2. The Americans have their own scoring system, but they're largely similar. And all of these scores have some limitations. The main one being that they are imprecise, as I'll show you in some of the subsequent slides. They're highly age-driven. So in young people, these scores do not stratify people into risk. And they're short-term horizons, so 10-year risk rather than a lifelong risk. I thought I would put this slide up because we are in the Royal College of Physicians. And indeed, the fact that coronary artery disease, like many of the other diseases we discussed today, have a strong inherited component. It's been known for a long time. William Osler, the father of medicine, gave a talk in this building, I think, or maybe in the Royal College of Physicians over a century ago, identifying that this particular condition can happen in individuals in generations of particular families. And there is a very large twin-based study which really provided the foundation for showing that there is a high familial risk of coronary disease. So if you're a sibling who has premature coronary disease, your risk is increased 3 to 4-fold. If you have an identical twin, your risk is increased markedly so, and the heritability of coronary disease is estimated around 50% or so. In the last 20 years, as for many of the other common diseases we've discussed, the genome-wide studies have identified many common variants associated with coronary disease. So I've had the privilege of leading a large international consortium called Cardiogram, which has really led the field in this area of identifying these genome-wide associations. And at the moment, we have one of the largest data sets of any of the common diseases. And as you already are familiar with this, using the combined genome-wide information you can get from these arrays that could give you can consider a polygenic risk score. So what you see in this slide for coronary disease is the distribution of a polygenic risk score in the general population with people. So there'll be some people who are fortunate to have a very low polygenic risk score compared to the average, as shown in this gray zone here, so below average, and then people who have increasingly higher polygenic risk scores. And what's shown in the table here is the relatively increased risk as you move towards the right-hand side of this Gaussian distribution for the polygenic risk score. As you can see, in people in the top 10% or so, there's a substantially higher risk. And what this translates into, again, you've seen this sort of slide before, is that there is a significant difference in the lifelong risk, or at least between the age of 40 and 75, of people who are stratified into this polygenic risk score, labeled as GRS here, between those who are in this bottom decile or bottom quintile of the polygenic risk score. As you can see, this is the lifelong risk, whereas people in the top quintile. Women, of course, have a low risk, but even in there, we can see this stratification. And several studies have shown this, because it's quite important to say, how does the polygenic risk score compare with other risk factors that we know for cardiovascular disease or coronary artery disease, and how does it add value to this? And what is shown on this slide is that this is a sort of C-index, which is, if the test didn't show any benefit, then the C-index would be 0.5. So you can see that if smoking as a risk factor increases your risk, as does diabetes, as does a family history of ischemic heart disease, body mass index, hypertension, high cholesterol. And this is the polygenic risk score here in terms of an individual risk factor which increases risk. I think Mike showed this for another condition as a single factor. And more importantly, it adds, so the conventional risk factors as a total have a significant risk, and the polygenic risk score adds to this, to this risk. So the other thing that's just saying the framework for the introduction of polygenic risk scores is that if you have people with high coronary disease polygenic risk score, several studies which are really retrospective studies of some of the clinical trials which have used various types of drugs to lower your blood pressure or lower your cholesterol level have shown that people with the high PRS risk, as shown in the dark brown here, have a much higher relative, which you would expect, but also an absolute benefit in terms of change in their risk compared to people who are in the low polygenic risk score. So for some reason, people with a high polygenic risk score not only have a relative benefit, but an absolute benefit in terms of risk. So identifying these people may have relevance in terms of treatment. And of course, the context in which we are discussing all of this, and when this, I saw, I've been here this afternoon, and this slide's been presented many times in many talks, is of course this is a 10-year plan on the NHS. 3 components to plan: moving community practice from hospital to community, going digital, and moving to the prevention agenda, from sickness to prevention. And part of the plan says that we will implement universal newborn genomic testing and population-based polygenic risk scoring alongside other emerging diagnostics to identify individuals at high risk of developing common diseases. So that provides the context for, and the background to how you might think about introducing cardiovascular disease polygenic risk score into practice. And really there are two potential options here for using a polygenic risk score to prevent CHD. The first is as an additional tool to existing clinical risk scores. I mentioned people having an NHS health check, we do a Q risk score, and the simplest possible option here is to say, if those people had a polygenic risk score added into their risk assessment, would that make a difference? And that's probably the easiest thing to implement. But there is perhaps a second approach, because as I said, coronary heart disease happens from early life, as a standalone test in younger individuals to identify those as high genetic risk, to allow preventative measures to be implemented much earlier. And these are two slightly different things in terms of whether it will be accepted or not, and I'll touch on that in a few minutes. But let's focus on the first one of these options for introducing a polygenic risk score. So we've done a big study. This started in 2012 in Leicester. We're having led the discovery work for common variants associated with CVD. I thought we should really do a study embedded in the NHS where we should test whether this addition of a CVD PRS would help. So I set up a study called the GenVAS study, where across GP practices in the Midlands, we recruited about 44,000 people undergoing an NHS health check. So these are the sort of standard bulk of people, inner city practices, rural practices, of about a 14% population from the ethnic minorities. And what I'm showing you in this slide is the impact of adding a CVD PRS to risk stratify these people. So all of these people had a Q risk score, which is shown on this bar of the slide, okay? So you can see that a lot of people had a very low Q risk score. Some people had a higher Q risk score in this population, and very few people, so this is the Q risk score. Now, if you added I'm calling it an integrated risk score, so this is the Q risk score plus a polygenic risk score. What would happen to these people in terms of the risk stratification? And you can see that many people who are in the low risk score, there is no change. So they remain in the low risk. Some of them move upwards, and some of them achieve, a very small proportion achieves an integrated risk score, which takes them into the threshold, the 10 to 20% threshold where we consider treatment. So these are people who had a very low Q risk score. If you look at the group who are in that intermediate zone, where a GP at the moment does not initiate any preventative treatments. So they wait for people to have a Q risk score of greater than 10%. So these are people in the low and high intermediate risk group. You'll see again, a proportion of people don't change. But what I want you to focus on is the number of people who shift from being in the zone where they would not have received treatment or guidance to those who are now in the threshold where they would probably be considered for treatment, either lifestyle or drug therapy. And indeed, in the group that with the 7.5 to 10% risk, there's a significant shift in people who moved into the high risk, or indeed some into the very high risk category. Even in the people who are in the Q risk score, which is 10 to 20%, so these are already people who have been identified as being at risk, you'll see that the proportion of people are put into a category that were felt to be at a very high risk. And this often alerts and changes clinical practice, because often GPs will concentrate on that very high risk group individuals. There are people who are downgraded, as Mike showed in his own slide. There are people who would be downgraded by the combined score compared to their clinical, Q risk score. And we need to think about whether that downgrading is something we also take into account when we identify people. So this shows in a very large real-world population what would happen to a Q risk score, or indeed a European or American score, if you added in a polygenic risk. So a significant shift in people in this intermediate risk group. And does this matter? So if we change people into that categorization, does that make a difference? And I want to just highlight whether this effect of reclassification of risk has an impact on subsequent CVD outcomes. And I wanted to just highlight two studies which show this. So this is a study by a colleague of mine, Harry Schunkert from Germany, where he looked at UK Biobank, and he looked at the number of people who would have been reclassified in the low risk and the intermediate and the high risk group. I want you to just focus on that intermediate risk group individuals. As you say, a lot of people fell into the category. Now, the average risk of those people was this. 4.1% average incidence risk. But if you reclassified a proportion of these people, about 10% of those people were reclassified by the addition of a polygenic risk score into the high-risk group, you can see that that risk of that almost doubles in that particular population. So switching people from being in what would not have received treatment or who had get guidance, if you had reclassified them, their reach approaches that of those people who are originally into the high CVD risk group. The rest having a slightly lower risk because some of these people have moved across. And similarly for the low risk group, there is a slight shift. And this is the GenVAS study. So we are following up GenVAS. We started recruiting in 2012, so we now have over 10 years of follow-up. And what we looked at retrospectively was to ask the question, how many people who went on to have a major cardiovascular event, so either a heart attack or a stroke or needed bypass surgery or PCI, how many of those people would have been identified as being at high risk? How many were identified as high risk by just a Q-risk score? And how many additional people, if any, would have been identified if you added a Q-risk? So as you know, the health screen is from people from 40 to 74 years of age. And you can see here that in this particular group, if you just had a Q-risk group, if you just had Q-risk 2, then about 3/5 of people would have been identified as being at high risk from the Q-risk, by the Q-risk alone. If you added in the polygenic risk score, then that number goes up to 68.7. There's an 11.7% relative increase in identifying those people. Okay? If you focus on young people, so there are people who develop their coronary disease much earlier, and this should be 40 to 54 rather than 40 to 50, then Q-risk 2 only identified 1 in 5 of those people as being at high risk at their screening check. Most of those people who go on to have events are silent, they are invisible to the Q-risk score. If you added in a polygenic risk score, it's not a panacea, it doesn't identify everybody, but you can see it increased the number identified from 26 to 38.4%, a relative increase of almost 50% in the number of people who are identified as being at high risk. If you scale it up to a population level, if you're able to identify, if the whole purpose of the NHS health check is to identify people at high risk, if you're able to identify 11.7% more individuals as being at high risk, or in a young population, particularly those who are economically active, of almost a 50% increased risk, then any measures you use to improve their health, lifestyle measures or drug therapy, any benefits you get from that should scale up at the same level. So you don't need to do anything different to these people. You only need to treat them in the same way that you treat anybody who identified high risk, and the benefit should follow in proportional terms to the number of increased incidence. Barring, of course, the fact that I already showed you that people who had high polygenic risk often benefit more in terms of drug therapy. So as a consequence of this, there is now a consensus developing as to whether we should be implementing a polygenic risk score for CVD. And recently, the European Society of Cardiology has published this consensus document which asks how you might implement this in clinical practice. So one possibility is that you implement it for everybody, but the vast majority of patients, nothing changes. Their CVD, their overall risk doesn't change. So one option is to focus on this intermediate risk group. And in the low risk category, you just don't do anything. But the intermediate risk group, you counsel for PRS, and then you recategorize them. And if they go into a very high risk category, then you provide that advice on lifestyle and treatment options. So if you want to think about cost effectiveness, and I'll come to that in a minute, one option is to focus on this intermediate risk group in providing this. So I've made the case, or at least tried to make a case for saying that adding the PRS to the NHS health check or similar tests that are done in other countries, for focusing perhaps on people in the intermediate risk group, may have some benefits in terms of reducing the burden of coronary disease. But I think we are missing a trick if that's the only group we are going to focus on, because NHS health checks and similar tests in other countries don't start until you're in your 40s. And by that time, often the train has left the station, so to speak, in terms of developing atherosclerosis, because many of you who are clinicians will know it often starts in the second decade of life. Young soldiers dying on the battlefield, if they have a post-mortem, you look at their coronary arteries, they've already got the early origins of coronary artery disease present in their vessels. And by the time you're in the third decade, it may already be more advanced. And if you really want to practice true prevention of cardiovascular disease, then you really want to get in as early as possible, rather than waiting when you're 40, 50, or 60 before you implement or identify people at high risk. So, and as I mentioned, this is not, and you can identify these people, of course. Lifestyle factors don't help, but a polygenic risk score, you can apply this at birth if you wish to, or at an early age, and pick up those people in the top 10 to 20% who are clearly at a significant risk. As Mike pointed out earlier, people in the top 10% of the polygenic risk score for CVD have the same risk as people with familial hypercholesterolemia. And there's obviously a push to identify people with FH as a really important activity for any health service. But the number of people who fall into the top 10% of the polygenic risk score is 20 times greater than the number of people with familial hypercholesterolemia. So if you're going to focus on FH, and identify those people with FH using genetic testing and lipid measurements, you're missing a real trick if you don't identify people, 20 times more people who fall into the top 10%. And this is the same slide I showed you earlier. Those people in the top 20% develop their problems of coronary heart disease much earlier, a decade or 2 decades earlier than people who have the lowest. So I think there is an option here around a paradigm shift in the way we start thinking about preventing coronary heart disease. Not wait till people are in their 40s and 50s and so on and do an NHS health check. You start identifying those people at high genetic risk, and you can set the threshold where you want. You can say the top 10%, the top 20% perhaps. Think about targeted prevention for those people, and then you fine-tune their risk in later life when other risk factors start coming into play, such as diabetes and weight and so on. So that is an option. This is not, as Mike answered one of the questions around, there's no trial we're going to do here. There's no randomized clinical trial we can do for this. We can do some studies for the adding the PRS to Curie score, and I showed you some of them. But this is going to be an article of faith as to whether you introduce this at an early stage because you think you can prevent things. So I think I've been quite keen to hear the audience's view of which of these options they think, or either of those options are ready for introduction. But there are challenges to introduce the CVD PRS, and Cathie Sudlow asked that question of Mike, and I'm glad you didn't answer the question comprehensively, Mike, because I wanted to just go through some of the challenges. Because there's a Department of Health working group at the moment, I'm on it, which is looking at polygenic risk scores for a number of diseases, and cardiovascular disease in particular. And these are the sort of questions we are going through at the moment in terms of saying, is it the right time to implement this? So there are scientific challenges for polygenic risk score. I think Mike alluded to this in his talk, and this is from one of the papers from Genomics PLC. So I've highlighted coronary disease and cardiovascular disease. What it shows is the standard deviation of the odds ratio per standard deviation of PRS in different ethnic groups. And as you can see for coronary artery disease, and indeed also for cardiovascular diseases more broadly, because these have been trained, the polygenic risk scores have been trained in people mainly of European origin, they perform less well in people of East Asian or South Asian and African populations. So one of the issues about a polygenic risk score, if you're going to do it, is about equity. There's always a question around equity, and we may get to a situation, we need more data to train or get a better polygenic risk score for people with other different ethnicities to make sure we apply the right tool for the right people. There's also a question of standardization and updating. So if you're going to do this, do we create polygenic risk scores for different ethnic groups? How do we standardize them? How do we upgrade them as you get more knowledge? So those are scientific challenges that we need to think about. There are operational challenges as well. How do we introduce this into an NHS system particularly based on primary care. So these are not going to be implemented in secondary care. So we need, whatever test or whatever polygenic risk score we agree to, and there are many of them available. You know, every research group has its own polygenic risk score, and companies do as well. So we need to be sure that whatever one is applied it has got analytical validity, and we get the same result every time. So there's a question then of how that information is fed into an NHS healthcare system. Who computes the polygenic risk score? So there's a standardization of testing. There's a question about who does the bioinformatics to extract the polygenic risk score at the right time, and how is it presented to the GP or the healthcare practitioner who is going to talk to the patient about this. So there is this issue of clinical and patient understanding and acceptance of the test as well. So this is a really important area, and I want to just highlight the paper that Michael also did. It's a really nice paper where they tested whether this would be clinically acceptable to a group of general practitioners in the north east of the UK. And really in that setting, there was quite a high level of clinical and GP acceptance as well as patient acceptance. So there was feedback, but this needs to be obviously be considered or tested further as to how valuable this would be. Then we need to think about clinical impact. There's no point presenting that polygenic risk score and then nothing changes. Okay. And we need to have better evidence. There are some small studies that looked at whether if you presented a polygenic risk score to a patient or a GP or together, whether it would affect behavior change, whether it would therefore lead to a risk trajectory change and therefore improve outcomes. And we don't have that long-term follow-up data of doing this. There are studies that have shown that a year later, presenting a polygenic risk score to an individual lowers their cholesterol more than it would if it didn't have this information. You know, we even spoke earlier about empowering patients, or how do we do this? How do we empower people using the new digital tools so that there is an impact on behavior change as a consequence of presenting this information? And thus again, these are going to be very difficult things to get information on. And the final two points is around cost effectiveness. You know, do we go broad for CVD? Do we do it on everybody? Do we do targeted on the people with intermediate? One of the things about cost effectiveness that I find always challenging is that you look at one-off tests, but of course, polygenic risk, because if you do a genome-wide array, you can do it for prostate cancer, you can do it for breast cancer. There's a one-off cost. And finally, there is this issue of societal impact of introducing this, particularly if not when you do it, mix it with the Q-risk PRS. There you can present in a way that's clinically acceptable. But if you're going to start presenting the polygenic risk score to young people with CVD, there are implications. There are implications for employment, there are implications for insurance. If I was smart and I was told I was in the top 10%, I would take out the biggest insurance policy I could if I didn't have to disclose it to my insurance company, because I know that I can protect my family. So there are really important societal questions around about introducing genomic information and who should know about it or not. So I'll finish by saying, I'll be interested in the audience view about whether, for CVD at least, and I think it probably is the condition where I think it's most ready because we have lifestyle and behavioral changes that we can implement. Is it ready for prime time? I'm persuaded, but I wonder whether the audience is. Thank you very much.
Thank you very much. I think we have time for one or two questions. Vivian, the microphone on its way to you. If there's another question over that side, perhaps you could. I think Munir.
So I've got a question about the Boer War. The Boer War. Okay. So in the Boer War, when people were recruited to fight the Boer War, which was in the 1880s, something like that, there was absolute outrage because the men were not fit enough to be recruited, and it revealed a real problem with public health. One of the places that you could have most impact is actually in the army, because the army draws its recruits disproportionately largely from disadvantaged communities. Okay. And actually, an exercise with the army in which you helped them once people have been recruited, because they have all the facilities to make those changes, and those recruits then go back into their own communities and can tell people about why it's so important to have that.
interesting thought. I'd never thought about that before, but I'm interested.
Well, there you are. That's
That's
my gift to you.
But you see, it just brought me into this, that if you have a polygenic risk score, I hope that it's not Trumpian in a way that you can avoid doing army service if you have a high polygenic risk score. It doesn't,
I think you want to recruit them first on their merits and then give them a PRS score.
Yeah, okay.
Thank you. Munir. Final question at the front here. Munir, please.
So just comment on that. There are some studies going on in pharmacogenomics in the military at the moment. So I don't know whether they're doing PRSs as well. But just in terms of PRS, very interesting. I am convinced.
Oh, good.
But just in terms of interventions, behavior change is going to be very difficult. Particularly if you're starting young, they're not going to maintain it, the persistence of that. So are you suggesting that pharmacotherapy should be started earlier? And maybe for those at the highest risk, the pharmacotherapy should be more intensive. You know, for example, you go straight to PCSK9 or you give combinations, etc. So, you know, how much work has been done on that because in terms of intensiveness of interventions?
So I don't think very little work, I would say, Munir, about. I mean, I think the issue of lifestyle changes, as you say, behavior change is difficult to achieve, but nonetheless, there is some evidence that that people do view the polygenic or a risk score as being something that is more deterministic for them, in one sense, and they will follow changes more. They're more likely to, rather than you say your blood pressure is a bit high, you should do something about that. So I think there is some evidence towards them taking more notice of the risk score. In terms of intensity of any therapy, statins or blood pressure lowering, I think we should just follow standard guidelines in terms of saying we need to get a lipid level down to this level. And as you know, the thresholds for bringing cholesterol down are getting lower and lower as this blood pressure. So you just get it down to target for these people. And it individually vary on how much statin they need to achieve that. So I'm not advocating we should go for very PCSK9 inhibitors or anything like that. I think just getting the cholesterol to target the current targets or as low as possible would be great. So, but there is cost to that. In the GenVAS study, do you know what proportion of people who are diagnosed in the high risk group or the very high risk group were on a statin? So this is an NHS health check across 147 Midlands practices, all right, with people being diagnosed as being at high risk. Anybody thinks there's over 70% of those people who are on a statin? 50%, 35%, 22%.
Really?
So these are already people who are being diagnosed as being at high risk. And this is not a criticism of the GP practices as such. It's just a comment on where we are. And that's what the NHS health check. So it's no point identifying people at high risk if you're not going to do something about it.
And how many of the 22% are actually taking their statins?
That's another question. You see, so I think this issue of prevention and identifying people at high risk is a challenge, or what do you do about them is a challenge.
Great.
Sorry, Cathie wanted to. I wanted to ask can I ask the audience a question? How many people here think that we should introduce a polygenic risk score for CVD in addition to the Q risk score? And how many people we should not? Oh, okay. I'll take you back to the working group. There are about there was a ratio of 4 to 1 of people who say they would like it in. So that'll make a difference.
So I suppose my answer to that question might be that there's some schemata to think through, and you listed those challenges really well. So there's a few things to think about before implementing. Really. But so my question kind of follows up on that. Actually, so nowadays we're starting to screen newborns. So we're going to have an increasing number of people in our population who already have known genomic factors with whole genome sequence from birth, and maybe following the experiment that JAL is currently conducting, that will be larger and larger. So I suppose the question is, what do you think might be the optimum age for either introducing this sort of scoring or indeed revealing knowledge of the scores from existing genomic data?
I think it will depend on the disease. So if I just focus on CVD, I think we need to give them choice, of course, whether they want to know or not. But for people who want to know, I would say that the 20s would be the right time to give that information. If you're going to really prevent it, there's no point waiting until you are 40 or 50. But I think we need to give people a choice as to whether they want to know and what age. So I think we need to leave it to them to make that decision. Of course, understanding that the well-informed people will want to know, and those people who, there are a lot of, in the deprived areas, the people just don't want, don't have that access or desire. So I think we need to make that more equitable as well. But it will be an interesting thing as we do the study. Okay.
Okay. So thank you very much, Professor Samani. Brings our session to a close, and I'm handing over to Professor Pirmohamed. But please thank all three of our speakers once again. Fascinating talks.
People need to go to their trains and planes and automobiles. So I just quickly thank a few people, if that's okay. Again, a fantastic day. Another sort of great annual meeting of the UK Pharmacogenomics Stratified Medicine Network. First of all, thanks to the fantastic talks from the speakers, all the speakers and the chairs as well. So thank you very much. So I want to thank the British Pharmacological Society staff for organising the meeting, and Becky particularly for leading this. So thank you very much, Becky. And also the AV staff as well. I mean, they've been fantastic in terms of helping us and so on today as well. Thank you. And finally, thank you very much to all of you. If you weren't here, there'd be no point having a meeting and so on. So thank you for coming to the meeting, and hope you can continue supporting the UK network and have a safe journey, and see you next year. Thank you.